thing which is holding the haptic is the sclera. It is the rigidity of the sclera which is holding it. It is not the suture at all. That is my take. I've experienced this also. And it is very important that the tunnel in which we are tucking in the haptic, that needs to be, the thickness needs to be good. The length has to be also good for that.
So, do you prefer to suture corneal tunnel in this case? Always?
Since it was not leaking, I did not suture the corneal tunnel, but yes, any leak I would have definitely sutured. Like I mentioned, because this is again a second surgery and it's a complicated surgery, so any hypotony later on may lead to, adverse complications like endophthalmitis also. So,
but in absence of vitreous, don't you think all the ports should be sutured, irrespective of what it is leaking or not, sir?
But it was the 23 gauge and the ports were not leaking. Okay. The wound was tight in the end. So
probably you are asking about the main port, the corneal tunnel.
Yeah, I asked about corneal. So overall, a great demonstration.
Very
of
nicely done.
Scleral fixation of IOL, sir. We learned a lot in this case.
Can I ask one question?
Yeah, sure.
Dr. Deepak, have you used retrofixation of the iris claw lenses? Suppose this case definitely requires expertise, this type of management of secondary IOL implantation as a scleral fixation. Anybody who doesn't want to go into that much of intricacies, would the retrofixation of the iris claw lenses could be a good alternative choice?
I have not used it, but in this particular case, if you ask me, I would not go for an iris claw because the iris itself is a bit, it has become atrophic. There is a pupillary fatigue. The one part of the iris has been stuck to the cornea. So this particular case, definitely iris claw lens would not be a very good idea. But yes, if it had been a clearer case with a well-reacting pupil without iris atrophy, in those cases, iris claw lens could have been done.
One more question: how do you manage if the haptic got extruded in later on?
Yeah,
in those cases, what do you do in those cases?
Sometimes, if the sclera has become thin, by chance the haptic has extruded out, I would try to see why it has extruded, whether it has not been tucked in properly, what is the cause. I would go in and explore, and I would make another Gabor-Chereau tunnel and try to tuck it in that time. I've tried putting a suture like he had said, but the suture, it never helps. If it has to extrude, it would extrude out, and in those cases, a scleral patch graft would help. And I remember in one of my cases, I had an extrusion. I found, rather while I was doing that case, I realized that at one end the sclera was thin. And later on that side itself, after 3 weeks, the haptic had extruded out. So I thought I'll go and try and do it again. And I made another tunnel and tucked it in. And again, after 3 weeks, it extruded out. And that is when I referred it to our cornea specialist. I think Dr. Rashmika is there. She only did it, I think. So a scleral patch graft was done for that.
Okay, and can it be done in the vertical direction, 90 degrees?
Yes, it can also be done in the opposite direction. For example, if the patient is, if the corneal diameter, if the horizontal corneal diameter is more actually, especially in high myopia cases, I have seen that the horizontal corneal diameter, if it is more, and if we go ahead and we are not vigilant and we forget that the length of the IOL is around 13 millimeter, the Oro lab has 13.5 millimeter, but sometimes that also may not be enough. So if we feel that the horizontal diameter is less, we can actually do a vertical, we can do it in the vertical direction also.
Thank you.
Thank you.
I have one question, Dr. Deepak. Usually for this scleral pocket for tucking the SFIOL, after doing vitrectomy, there is hypotony part. So what I have learnt, I usually do the marking with Malinga's ring. The Bolesh was pointing that it should be just opposite. And then in the beginning of the surgery, I prepare the scleral pocket, because practically it becomes very difficult when you do the scleral pocket preparation after vitrectomy and vitrectomy.
But since the infusion is on, the pressure is maintained.
Many a times there is dimpling of the cornea, and there is always some shaky type of things is there.
Because I make the pockets according to the exteriorization of the haptic. For example, the area where the haptic has been exteriorized. So I think that becomes more later. If I do it, I can guide it much more easily. That is my.
And second thing which I want to say, that since you are doing vitrectomy, you never know. So there is always safe to do take a 10-0 bite in the main corneal side, because you don't know when you will have to repeat the third surgery.
Last question.
Okay.
Sure. You may need to put anything.
Age threshold for pediatric SFIs for you?
Age threshold is definitely after the eye has fully grown, which means it has to be above 6 years to 7 years. That is my threshold. Because before that, if we do it, the globe has not reached its full size, and it should be done after the eye has fully grown. That is my take. And definitely has to be avoided in cases where the sclera is thin, like Marfan's. All these cases, actually, scleral fixated IOL should be avoided.
Do you trim haptics in microcornea cases, sir?
In microcornea, I have not done in microcornea, but yeah, definitely, since the globe would be smaller in those cases and the haptic would be longer, we can trim the haptics.
Do you decrease the dioptric power of SFIL from what is required for the PC IOL? Whatever is the calculation of the posterior chamber IOL, do you decrease the dioptric power, and by how much?
No, I don't decrease it, because it's almost in the same plane, so I don't decrease it.
So whatever was the IOL power
required
for in-bag,
I put the same. Same.
I think even if we have to decrease, we can just decrease it by 0.5.
Yeah, 0.5. And do you think the 3-piece SFIL that we use, it makes a difference if the IOL is implanted the other way around?
You're saying if the lens somersaults inside?
Yeah, if the lens somersaults inside and you have to
eventually implant it. Then if the lens somersaults inside, the angulation of the lens will change. It's a 3-piece lens. It's a 3-piece lens, so the angulation will change. And it's very easy to bring it back to the normal. You can just take 2 dialers and you can pivot it around that, and it comes back to the normal. So we should not put a somersaulted IOL. Definitely no. Yeah.
So very nice discussion. Thank you, Deepak sir.
Thank you.
For a great skill demonstration of SFIL. We will move to our next presentation. Dr. Roshan. Okay. So Dr. Vidhata is going to show us next deferred life surgery video with a discussion. He has done his post-graduation from medical CMC Kolkata and post PG VITREO RETINA fellowship from Sadguru Netralaya Chitrakoot, and after that he was a consultant there. So now over to Vidhata.
A very good morning to all of you. So my recorded video has been done 2 days back at the Divdrishti Eye Center, So the case that I am going to show was operated 2 months back for retinal detachment. The patient had presented with retinal detachment with choroidal detachment. So I had put him on oral steroids and took him for surgery after 5 days. And after 5 days, I did vitreoretina surgery with silicone oil injection and methotrexate injection. After 2 months, macular hole was noticed along with thick epiretinal membrane, and silicone oil was in situ. So the surgery that was planned was silicone oil removal with membrane peel, followed by fluid air exchange and then gas injection. So let's go to the video.
A very good afternoon. Corneal refractive surgeon at Dividishti Eye Center, Patna. I am your OT coordinator for the session of the Deferred Live Surgery, and which is organized by the 6th Annual Conference of the VRSB Society. We are highly honored and thankful for the opportunity given. Today we are going to observe a very eminent and young vitreoretina surgeon with us, Dr. Vidhata Vidu, who is going to operate a case of macular hole. He is going to do a silicone oil removal with ILM peeling with fluid air exchange plus 20% SF6. So just to mention that we are doing a deferred live surgery, and I would like to mention the date, time and location of today's deferred surgery. So we are at the OT complex of Dividishti Eye Center, Patna, and the timing today is 12:45 p.m. and the date today is 31st July. So going ahead with the patient's detail, a patient of 55-year-old gentleman came to the OPD of Dividishti Eye Center, Patna around May 2025, and he was an operated case of phaco plus trav in the right eye. On examination, the patient gave complaints of diminution of vision, which is sudden in onset, and on examination, we could see there was retinal detachment in the patient's around with choroidal detachment. And hence the patient was taken up for a VR surgery with choroidal detachment drainage, injection methotrexate was also given. So this was in the month of May 2025, and on post-operative examination after a month time, we could observe that there was a complete attachment of the retina, but we could see there was some amount of some amount of defect in the macular area. We could see there was a macular hole present in the patient, and hence a macular hole with a minimum linear diameter of around 400 micron was observed. The patient was then, he was planned for a macular hole surgery, and hence we are going to observe a silicone oil removal with membrane peeling with gas today. Talking about the surgeon who is going to operate this case today, we are very well known about Dr. Vidhata Vidu. Just to give a short introduction about the surgeon with us today, Dr. Vidhata Vidu did his MBBS from Patna Medical College, Patna in 2013. In 2019 to 22, he did his MS from Calcutta National Medical College. After that, to pursue his interest in vitreoretina services, he went to fellowship to Sadhguru Netra Chikitsale, and where he did his fellowship for 2 years from 19 to 22 to 24, and then he also continued as a consultant there. Today, he is one of a very renowned, he's a budding retina surgeon. Today, he has become a very budding vitreoretina surgeon, and he has been practicing as a consultant at Dividishti Eye Center from past 9 months. So let's, without further delay, let's invite our surgeon to pursue ahead.
Annual conference. This is deferred live surgery that is going to be happen at the Dividishti Eye Center. The case has been operated 2 months back for retinal detachment, and macular hole was noticed a month back by me. So I have planned to do a SOR plus membrane peel and fax. So first I will be removing the oil, and then after staining, I will be doing the peeling part. In these cases, peeling is a bit difficult and tricky. Let's see how it goes. Funny. So I have made 3 ports. The infusion has been switched on. I'll make another port for chandelier. Port 5 minutes around. This is a big size globe, so Around 5 ml of oil will be there. I will be speaking the skipping the oil removal part. You all are well aware of that thing. The port came out actually, probably when the first port that was made, it went through the same area which the previous port was meant, so it was quite loose. So I decided to change the area and make another port just near the older port. Initially, I had lot of difficulty while starting the case. Probably the defogger was not working, so I had to face a lot of fogging issue. Okay, the oil has been removed now. So I am working on a Constellation 25 gauge hypervitrectomy system, and the biome that I am using is Ion Meditech from Kolkata. I am in Chennai. The cut rate is around 20K, and the vacuum that I will be using for I used for silicon oil removal was 650. For cutting at 20 Ks cut, I use a vacuum of 500 mmHg. So you can see there is a lot of fogging on the lens. I was not aware that defogger was switched off. Dehumidifier actually. So as a VR consultant, VR surgeon, we have to go through these scenarios. If the nose is not taped properly or the humidity is too high in the room, the fogging reduces so much of visibility that you cannot focus on the retina only. Somehow I try to stain under the fogged lens only. You can keep asking the questions in between. Okay, now I am using the chandelier. The chandelier increases the view actually, and also the recording becomes quite good under chandelier. While I was doing my fellowship, I used to record all my videos under the chandelier light only. And Alok sir always used to teach us like use chandelier. It decreases the chances of complication, increases your visibility. Also the recording is quite good.
It seems that you were knowing case was high myop, so you kept little bit.
The IL power that we used was 18 diopters. The axial length was around 25.
We can see your port is at 5 mm, I think 4.55 mm.
The globe was quite big, so I deliberately made it a bit posterior so that I can reach the posterior pole. The patient was glaucomatous. You can see the disc 0.8, around 0.8 cupping, and the stain is very poor. I cannot see any part of the retina getting stained.
Usually that is because of silicon oil induced epiretinal proliferation and ERM formation. In these scenarios, we need to stain under FX.
Second time I tried to stain, and I was planned for doing the staining after FX. After if this staining I could not achieve a good staining after the second staining. The staining is being removed.
So how much time you give to your BVG to stain there?
I wait around 30 seconds.
Vedanta, what was the pre-op vision?
Pre-op vision was around 460.
This seems quite plain.
So this part of the retina has taken a stain, so I decided to remove the epiretinal polyp from that area only.
In some cases of high myope, even after multiple attempts of staining, ILM doesn't take stain. So in that case, what is your approach? Like 3-4 times, even in under FX, it doesn't stain, especially if there is a posterior staphyloma and depigmentation of RP.
It becomes very difficult if it has not taken the stain.
What is opinion from audience in those conditions? Yes.
You mean despite doing a fluoride exchange, even after that it has not taken up the stain? Then it definitely becomes a bit difficult, and then negative staining may help, or we may actually try with ICG in those cases.
Yes, sir, we can try.
One
ICG
practical
also.
thing which you can do, you can start with DDMS, scrapping. Something will be visible to you, and then you can start your surgery, peeling part.
So, what do you do if you are not getting a good stain? That is the question, right?
Yes, sir.
So, we should look for the cause why you are not getting a good stain. First is, we are not getting the adequate time or the concentration for the dye to be there. So, you should repeat it. Again, do a stain. Then look for whether you remember, always pre-op OCT can give you a clue that there was pre-existing ERM, or there is something sitting over it. Sometimes even hyaloid is present, not unusual cases, like in post-traumatic macular hole. Then there is a chance sometimes that the remnant of, island of hyaloid might be sitting there. That is in post-traumatic, generally happens in post-traumatic. In these cases, in older age, most of the time is that there is an ERM which is sitting over it, and ERM has a different staining pattern than this. So you can do for double staining, you will get that island of ERM which you can see via negative stain, and start from the periphery and take it in toto, or you can remove the ERM and then again re-stain and look for the ILM. So that is how we go. And sometimes, rarely, this is a secondary case. Like what if some patient was operated outside and had come to him? So might be somebody had already done an ILM peeling also. That can be also there, right?
But then the show us that ILM peeling was done before.
So
sometimes we can, definitely.
If you see the flaps, or we can,
But then if you stain, you'll get a negative stain also. And sometimes if you have seen that if you stain with BBG or with the brilliant blue dye, the hyaloid also gets stained.
yes.
It does stain the posterior hyaloid. But he's saying if it doesn't stain at all, then how would you go about it?
I think
Recently, I encountered a case with axial length of 34 with macular hole MHRD. Macular hole RD was there. So in that case, I could not stain even after 3-4 times. Even under FX, I wait for at 2 minutes, 2.5 minutes. Even then, it was not stained. Some peripheral HST were there, so there was no question that there will be any. PVD was there.
So ICG could help in some cases.
I think in those cases where it required intraoperative OCT,
Sir,
incorporated with the microscope.
Sir can buy an intraoperative OCT, so we are not going to take his argument. We are talking about, general ophthalmologists who can't afford an intraoperative OCT. So your scenario is a totally different ball game we are talking about, right? We have a large eyeball. Generally, there would be a pre-existing chorioretinal atrophy. So what we are seeing is a stain which has to be manifested against a background. So there are two scenarios. One is the pre-existing myopic traction maculopathy, and sometimes what happens that there is a pre-existing RP atrophy and all. So you will not be able to see the contrast per se due to this. Another scenario is that the dye migrates subretinally because of a pre-existing localized detachment in high myopics. Then because of the dye migrating in subretinally, the contrast is lost. So you'll not be able to see whatever time you see. So whatever we are seeing is a contrast of what it is, right? And to manifest it, what we can do is that multiple, I mean, you can just, this is, I think, a genol light source, right? So the companies are coming with other type of light source, like if you apply a yellow filter, then this accentuates the contrast.
Yes.
So that there are few systems which are available with 3 LED systems, different wavelengths. You can customize the wavelength just to accentuate it. How you can, even the 3D viewing systems, they do have artificial filters also.
Yeah.
Just a color filter to accentuate the contrast.
Cost is very much on those.
So I'm talking about sir's view also. I'm taking into sir's view also.
So after a lot of difficulty, slowly, I was able to remove the large prolapse from the temporal side. And you can see there is some amount of staining now when I stained it for the 3rd time. And I could delineate the epiretinal tissue marking. So as Sivan sir said, you could use a DDMS. So I don't have any experience of DDMS. What I have used is the finish loop. But I wanted to know from the seniors, finish loop do you use in the alum peeling, the Alcon finish loop? Any one of you used to remove the peeling during the peeling?
Yes, I have used it and it works quite well.
But what one of my teachers said that don't use it on the attached retina because it causes a lot of the traction on the this retina. So better avoid it if the retina is attached. For detached retina, it's fine. So
that's quite true. So we use it only when we don't get a peel. Unless otherwise we always use pull and pinch.
So regarding the pull and pinch, sir, previously I was using that classical forceps, ILM forceps. Recently I got this shark fin from Alcon. So the feel is quite different. I mean the tip is slightly bent outside and the hold that it gives is a bit different from the one that I was using previously. Like in this video also I had to pinch multiple times and the tissue trauma is quite less.
You?
So while doing the surgery, as it was getting prolonged, I lost the view because of the corneal edema. I was unable to focus. These are quite issues with the VR surgery once it gets prolonged. I debrided it. I had to debride the epithelium, although I try to do without debridement because sometimes I have landed up with the corneal infiltrates during the post-op period. But like the retina comes first, everything is second. Whatever comes in between, remove it. So be it lens, cornea, epithelium, whatever, remove it if you are unable to visualize the retina. Now I was able to get the view properly. So now the things have become easy for me. Again the tissue, the epiretinal tissue, again towards that nasal side.
So how do you differentiate whether it is epiretinal tissue or you are dissociating some retinal fibers, Dr. Vidhata?
If you pull that retinal tissue, it will bleed. So it's sometimes initially when I pulled up the tissue, I thought it's a retinal tissue. So I re-stained it. It was hanging quite freely in the vitreous. And once you touch the retinal tissue, it's going to bleed. When the stain is not good, it's never easy to pull the ILM. So
Very
this much
patient.
I have removed the ILM. Now this is the, finally I was able to remove the temporal ILM. And out for my surprise, there was a foreign body waiting for me inside. Probably this was the soft tip, which could have broken in the primary surgery itself. And it landed on the macular hole only.
You are doing very patiently.
This is the last chunk of ILM I wanted to remove. So finally it's all around completed 360-degree peeling.
Whenever we pinch epiretinal prolif, then we need to focus on nearby capillary or arteriole or venule. If it is dragging, it means it is retinal fiber. Like especially we encounter such situation in silicone oil induced proliferative retinopathy cases, as I can see in yours. So whenever we pinch, if we caught retinal tissue or retinal fibers, nearby blood vessel will move with movement. Then we need to leave that, and then we need to hold it little bit superficially.
Also, it's better to pull the ERM from the edge.
Yes, yes.
See where it has taken the stain, and then hold it at the edge. The chances of holding the retinal tissue will be less.
Yes. In such cases, actually epiretinal prolif is also thicker.
In this area, the ILM was quite adherent. So whenever I was trying to pull, the retina was coming up. So I decided to leave as it is. Otherwise, it could have led to the break, which I didn't want to. Just freed that area from the ILM. Now I wanted to remove the tip, silicon tip, iatrogenic intraocular foreign body. I should have used a serrated forceps or the maxillary forceps. But somehow I got the hold.
So in this case, which gas you are planning to use?
SF6.
So you are using
SF6 I would like to use in this patient.
So you are using
because the hole size is around 300 micron, and I don't want the tamponade too long, because the EZ loss was quite extensive in this patient. The OCT showed there was a global EZ loss, so vision was probably not going to improve.
So I request for expert comments from audience.
Checking the periphery, the facts. No, not in this case. But once I have done the massage in very large macular hole, what happened was, while doing the facts, I had made a very good flap, but while doing the facts, all the flap came out. So I did the massage somehow.
Particular case, the ILM here was very thin and friable, so it kept on breaking, and so the desired probably amount of ILM which you wanted to remove, were you able to achieve that? arcade to arcade?
No, I could not achieve. Though I had
Usually
planned
we
for
prefer
the same.
arcade to arcade
Yeah.
removal of the ILM.
Always.
So here, since we were unable to do that, so you felt that massaging the hole could have been another step which could help in closing the hole.
Yes, sir. Nice surgical demonstration, Dr. Vidhata.
Very nice presentation, Dr. Vidhata.
Thank you, ma'am.
Now we'll move on to our guest national faculty for the referred life surgery, Dr. Sangeet Mittal.
Hi, Pooja.
Hello, sir. A very good morning.
Hi, Pooja.
A very good morning, sir. From
Good morning.
VITREO Retina Society of Bihar annual meeting in Patna.
Yeah.
We are very, very pleased and happy that you could join us for this session, though in the Zoom mode. A brief introduction.
It's my pleasure.
So, a brief introduction about Dr. Sangeet Mittal.
Recording in progress.
Dr. Sangeet Mittal is a very prolific and a very experienced senior vitreoretinal surgeon, and it's a absolute pleasure for me to introduce him. He is the director, VITREO RETINA of Thind Eye Hospital, Jalandhar. He did his VR fellowship from Shankar Nethralaya, Chennai in 1996-97. He is the recipient of several awards, and in a very light tone we always tell him that a room will fall short with the awards. I mean, there is not enough place to put them. So, and one thing I would like to specially mention about Sir, his mind is always into innovations. He's always trying to experiment new things, new techniques of doing surgery. His mind is always, trying out new things. So just to name a few awards of the many awards, he is the recipient of V.T. Joshi Gold Medal for the Best Fellow Shankar Nethralaya, Chennai. He is the recipient of J.M. Pava Best Paper in VRSI, the EVRS Best of the Show, Ophthalmology State of India by AIOS 2020, C.S. Reshmi Award, E.T. Selvan Award for the Best Scientific Paper in 2021, AIOS Trauma Award, VRSI Best Video Award in 2022, the P.N. Nagpal Award by VRSI, and the Narsing Rao Award by AIOS in 2023. So over to you, sir. This is a deferred life surgery.
Yeah. Thank you, Pooja. Are you able to hear me?
And just before you start, we would like to have a few words of welcome from our president, Dr. Subhash Prasad.
Hello, good morning, Dr. Sangeet.
Good morning, sir.
This is Dr. Subhash, and we are really very much thankful to you for having agreed to do this deferred life surgery, and it's always pleasure and treasure to watch your surgery. So thank you very much for joining VRSB again. You have been a regular attendee and regular, will say that, teacher for us, all of us. So thank you very much. Yeah.
Thank you, sir. It's my pleasure to join you here. And I am proud that I have been part of all the meetings that VRSB has held, and we'd like to continue the tradition further. So today I'm doing this, I'm showing you this case. This is a patient of PDR with vitreous hemorrhage and epiretinal membrane. And I think the introduction of the case is in the video itself, if you can start playing the video. If there is a time, then we can show the second case, which is RD with PVR. So both the cases around 50 minutes of time, if the time allows, then you can play both. Yeah. We can start the case, Dr. Pooja.
This is the case of Mrs.
Yes,
Boli,
sir.
presented to us with vision in right eye with finger counting. She was diagnosed and vitreous stage with olive in right eye, and she was advised VR surgery. And this is the fundus photo of Mrs. Boli.
Kamal.
So good morning, everyone. We are going to start this case. This is a patient of PDR with vitreous hemorrhage. So we are planning to do a 3-port plasma vitrectomy in this patient.
So Dr. Pooja, if there is any query, I can answer same.
So the infusion cannula goes into the inferior nasal
Yes,
quadrant.
sir. There'll be some questions along the way. So Dr. Bhulesh will be moderating your surgery, and he can coordinate with the questions.
So,
Sir, सीधा रखो मत
Good morning, sir.
good morning, Dr. Bhulesh.
Sir, can you introduce your system?
It's a pseudophakic eye. We are making the incisions at 3 millimeters. So after incisions, we need to clear the ports. There is a PCO also. I am doing a capsulectomy with the cutter itself.
So sir is using a 25G vitrectomy system of Constellation.
Yes, yes.
Pink क्यों आ रहा है?
With
इसको बुलाना
ultra
विनय
bit
को
cutter, I guess.
Yes.
इसमें पिंक क्यों आ रहा है सर? पिंक आ रही है इमेज में मेरे को. कुछ चेंजेस तो नहीं. चलो कोई नहीं. ठीक है. चलो देखते हैं.
I think they've still not shifted to the microscope mode.
Suction कितना है? So the cut rate is 20,000, the suction is 650, and the infusion is at 30 millimeters of mercury.
So
Is
you
it
are
on?
using hyperweight cutter, sir.
Yes, this is hyperweight.
Lens. Lights off. Yes. So here you can see there is a fibrovascular proliferation running from the disc superiorly along the superior arcade. So first we just remove this blood.
So do you prefer to inject pre-operatively anti-VEGF, sir, in such cases?
Yes, I think the patient had received anti-VEGF 3 days before. I prefer to do it rather than later.
Hi sir, Abhishek on this side. Can you hear me, sir?
Yes, yes, I am here.
Sir, there are situations in which there is a large subhyaloid hemorrhage just sitting on the posterior pole, and the patient presents with, he has abrupt decrease of vision. From he was seeing all right, and now he is hand movement, but we can see the rest of the retina. So what is your protocol in these cases? Like, will you do laser? Because you can see the whole of the retina. Will you do laser?
Yeah, if the laser is not there, I'll add laser.
Okay.
I'll wait for about 4 to 6 weeks. If the hemorrhage comes down, then I'll wait further.
Okay.
But if does not, then I go in for an early vitrectomy in these eyes. Okay. Especially if the patient is having a recurrent kind of problem.
And I like to start my dissection from the disc and gripping. So I'll just separate the membrane from the disc. Now the plane is created. Now I just have to go and cut around the epicenters.
Sir, regarding the avulsion of the
Section 450.
Yes.
Regarding the avulsion of the fibrovascular front sitting on the disc, rarely
Yeah.
we encounter if we remove it, and then there is a lot of bleeding from that point. So many.
Next step is to induce PVD from the periphery.
So many a
So
times.
generally you don't
see,
find any
using the
bleeding, much
PVD
of
in
the
the
bleeding
periphery.
from there. Most of the
this
time,
will
if there is
also
some
open up
bleeding,
the
you just have to
fibrovascular
be patient,
proliferation.
just raise the bottle height and wait for some time, the bleeding will stop.
Okay, sir.
But if you are planning to remove the stump from the disc, then it is better you start in the beginning and have time rather than doing it at the end of the surgery.
Okay.
Then you will have a lot of problems later on.
Right.
So, and in addition, if you start from the disc, it gives you a proper plane of dissection where you have to proceed. So what I do is I start from the disc and then I make a wedge between the disc and the peripheral retina. And then I start inducing PVD from the periphery, and then it becomes very easy going all around the epicenters, just one by one with the cutter itself. You can
There is a
take out
membrane
most
which
of
is
the membrane.
keeping the fibrovascular proliferation tight. Just have to explore the membrane here.
So if you find that there is the membrane is not freely coming into your cutter, it means that there is some sticky ERM which is present along with the proliferation. So just explore that area, and you'll find that there is an epiretinal membrane. You just free the edges of the proliferation and then again go in with your cutter. It will come very easily. See, there was a membrane which was sticking to the retina, and that's why the proliferation was not free. And now I got hold of this membrane, just separate this membrane from the retina.
There's another of this here.
There was another membrane inferiorly, and I tried to remove it early, but then the edge was not visible. So I decided to remove the blood first and then proceed with the membrane. So now you see the superior proliferation, because now it is free from all its attachments. Just with the cutter only, it can easily get attracted by the cutter, and you can remove all of the membrane with the cutter itself. Though there were very close attachments in this, still easily you can do it with your cutter.
Green forceps.
So I tried to remove this membrane before removing the blood, but it was not possible because the edge was not visible. I could not get the edge, so then I thought I'll just remove the blood first and properly see where is the edge and then remove the membrane.
Backflash.
Good morning, sir.
Good morning.
I have a question. Dr. Bholesh earlier asked you if you had injected anti-VEGF in this case prior to the surgery. And
yeah, I did inject, yes.
So this is often the practice nowadays to inject anti-VEGF prior to diabetic vitrectomies for VH, advanced diabetic eye diseases. And we often have this in mind that the surgery is to be done 3 days after the anti-VEGF injection.
Yeah.
For multiple reasons, tractions increasing, but I have invariably seen whenever I also advise the patient to get surgery done after 3 days, 4 days, 5 days, but invariably whenever the patient has himself prolonged the surgery, say to 10 days or a month's time, I have always had a simpler surgery at that stage. So what is your take on that? Most of the times, even if the patient himself waits for another 10 days, 1 month, the NVEs have regressed further. Sometimes the vitreous also becomes easier to dissect. So I often have come across this thing that probably some more time for anti-VEGF to act in such eyes is not a very bad idea, is what I have come across. What is your take on that, sir?
I agree to you a little bit. The only problem is in delaying the surgery is the increase in the tractional retinal detachment. So, which may happen because when the membranes regress, they may pull the retina. And if your membrane is threatening the macula and you are not operating early, the membrane, the TRD can increase and involve the macula. That is one of the major problems if you wait after anti-VEGF. And that's why we avoid giving anti-VEGFs in the diabetics' eyes blindly. Otherwise, definitely what you are saying, the membrane becomes quieter and the hemorrhage also resolves to a large extent after you give anti-VEGF and you wait for some time. So I would prefer if there is a properly lasered retina, you may even wait further. But if it is a fresh eye or a naive patient, then I don't think that you should wait. And another problem that can happen is the crunch effect, which we see sometimes. The anti-VEGF, this regression of membrane leading to breaks and causing tractional retinal detachment to be converted into combined retinal detachment. So these two risks actually, that's why we avoid delaying the surgery much rather than we just wait for maximum 5 to 6 days, and we prefer to do it before that.
All right, so thank you.
Sir, do you prefer to inject post-operatively, I mean at the time of closure of surgery if you see a massive diabetic macular edema after peeling?
So usually I don't inject post-operative. What I feel is that if you do a ILM peeling in your diabetic macular edema patients, there is a slowly, this ILM peeling it's also acts as an anti-VEGF only. The slowly the edema resolves and you find that it does not recur also.
So, do you prefer, sir, to peel ILM in all cases of diabetic with?
Nowadays, yes, I prefer,
Membrane
because now I
dissection
realize
is
that
over.
the chances of...
Now, just finish off the vitrectomy. We'll do some,
Now
we'll do ILM peeling in this eye and then we'll do laser.
After ILM peeling.
Sir, good morning, sir. Which forceps you are using while removing the membrane? Was it the Sark skin one or the older one, the Alcon one?
I was using the Greensaber ILM peeler. So if you see the ILM peeler, it's got a very good I think the jaws. You see, one of the jaws is just like a cat's paw. So when you use the cat's paw to scratch the membrane, you get a very good edge. And if the membrane is small, you don't need an end gripping at that. You just hold the membrane from there only and just peel it off. I use, generally I start with the ILM peeler. If I get the edge, if the membrane is large, I shift to the other forceps. Otherwise, I just use the ILM peeler itself.
Another point in peeling the ERM is that sometimes if you have subfoveal hard exudates, it also gets resolved, as you have earlier shown some videos, Dr. Sangeet.
Yes, sir. What I have observed is, I've done now, I think, nearly more than 150 cases of subfoveal hard exudative plaques, and I have seen that they respond very well to vitrectomy with ILM peeling rather than injecting again and again. It will be better if you do a primary vitrectomy in those cases. I prefer to do primary vitrectomy in those cases.
I generally start peeling under the dye itself.
Sir,
so
do you think...
I do is I don't wait for 30 seconds or 1 minute or 2 minutes after injecting the dye. I just start peeling the ILM. So you just get a nick, and once you get a nick and the dye is still there, then you'll see the stain gets better. In the previous surgery, what we were discussing was that if there is no stain, so once you start inject the ILM, just make a little bit pinch, wait for 10-15 seconds, and you see that the stain gets better with time if the dye is there after you pinch.
In diabetic patients, ILM is a little bit sticky side, so it won't come as one piece. Generally, it will come as piecemeal.
Sir, Abhishek again, just asking for your view on this inferior polyp, which is a very small polyp, polyp. And regarding that, any inputs that if we had already planned for an ILM peeling, could we have taken out in toto by extending the ILM peeling?
Over the proliferation or over the membrane? In that
No. While we're doing the ILM peeling,
one,
can this prolif come out while we
yes,
if
yes,
we extend it towards?
Yeah, if you are able to extend your ILM peel up to that membrane, definitely it can come. Both the things can come together also.
Yeah.
But sometimes what happens is in these diabetics, the ILM is so sticky that you are not able to actually extend ILM peeling to the.
Yeah, they do come out in piecemeals many times.
Yeah. There's sometimes if the membranes are closed, and they do definitely, you can do both of them, ILM and ERM together.
Right.
Yeah, in most of the cases when we try to peel ILM beyond the extent of FVPs, it breaks at the root of PEG of that prolif. So
that happens in these diabetic patients. Otherwise, if there is a normal ERM and ILM, you can always do that. It becomes easier, in fact, if you peel both of them together. But here you see the ILM was a bit sticky here, so I did not extend it much. I just left it there only. You see, the retina was like getting pulled along with the ILM. So that was due to the edematous retina which was there. So I just now thought this is the end of the ILM peel. And now what we did was laser.
Now we'll do laser and then.
So as you mentioned, you do ILM peel for most of the diabetic vitrectomies.
Yes.
If the patient has an underlying significant macular edema with cystoid spaces, do you encounter any deroofing or thinning after ILM peeling post-operatively if you see a laminar macular hole or thinning of the macula at posterior pole, thinning of the retina at posterior pole happening because of the ILM peel in diabetics?
Personally, I have not encountered, but definitely there is a risk in those patients who have chronic large cysts. There is a risk of deroofing the fovea and cause a macular hole. In those cases, you can also try the fovea sparing ILM peel. But I have done a lot of cases in which there had been hard exudates in the fovea, and the fovea was very thin. And personally, I have not encountered this complication as such while doing this surgery.
Okay. So, have you ever injected Ozurdex at the end of a diabetic vitrectomy?
No, I don't. What I have seen, I feel is ILM peeling itself is quite sufficient, though it is not as fast as Ozurdex or intravitreal triamcinolone or any other anti-VEGF. But if you patient to wait, the ILM peeling itself is sufficient. It reduces the macular edema, and the chances of recurrence becomes very, very less.
Sir, in cases of diabetic TRDs, if there is no break, if we have relieved all traction, do you prefer to put tamponade?
So again, it is situational. So if supposedly if the patient this patient was one-eyed, so I had to go in early. So if the patient is one-eyed and there is a lot of SRF still present, I would prefer to make a retinotomy, drain the fluid, and then put in oil or gas, whichever tamponade is there. But generally, if there is no break and there is not much of fluid, I will leave the eye like that, only maybe partial fill of air just to have a proper closure of sclerotomies and nothing more than that.
Thank you, sir.
Sir, we can see that you are doing a very scatter sort of PRP, not very aggressive PRP, sir, in this case, sir.
I don't think now, if you have done a proper vitrectomy and removed all the traction, now you don't need actually so aggressive a PRP.
Right. So we should take home this message that if you have done a complete vitrectomy, relieved the traction, you don't need that sort of aggressive PRP. And
yes.
Itself.
So you can always add, if you want, you can always add the laser later on.
Yes.
So what happens is, like, if you do a very aggressive PRP in these situations, you may land up with choroidals in the next post-operative day.
So you didn't use endocautery to. In this case, we see you didn't use an endocautery for the proliferations. Do you use it often or not at all?
Not often. If there is bleeding from the sides, then definitely if it is not stopping by raising the infusion pressure, then I consider it, the next step is endocautery. I don't apply pressure and wait. That is, I don't do that. I try to just raise the bottle height, and if the bleeding stops, well and good. If it does not stop, then do some endocautery, especially if the bleeder is away from the disc.
So, do you think 27 gauge vitrectomy system helps in these kind of cases, diabetic VH cases?
Yeah, I have done. Actually, I had done a lot of 27 gauge vitrectomies, and especially I used to prefer 27 gauge in diabetic vitrectomies because it gives me extra edge of being a smaller, and you can easily go between the small areas where you want to go. But nowadays, because of the Alcon, this six pack, you can't afford actually to have 27, 25, 23. So all the systems with you. I find 25 is good enough for all surgeries. So I just keep it that. Because otherwise you'll have to get all the accessories of 27 gauge, and they're that 266 per box. So it becomes too expensive. But otherwise 27 gauge definitely for diabetic vitrectomies I would prefer over 25 gauge any day.
Usually such patients will have variable blood sugar levels, sir. What is the threshold for you to operate them?
So I don't prefer to lower the blood sugar just before the surgery.
20.
Like if their blood sugar is high, sometimes we have to do that if the condition demands, but I generally prefer that the patient gets his blood sugar controlled. And even if it is phakic eye, sometimes even in if there is a cataract, I ask the patient to get his cataract surgery also done before I take him up for the vitrectomy. And once that settles down, then we inject, and then 3 days later we take the patient for vitrectomy.
So if the patient is on anticoagulants or aspirin, do you prefer stopping it before surgery or not required for diabetic vitrectomies?
If the patient's physician has asked me, then I stop. Otherwise, I don't stop if the bleed. We do all this coagulation profile before surgery for all patients. So if it is fine, then I don't stop.
Okay, sir. Thank you.
Sir, in combined cases where cataract is also there, do you prefer to do 2 surgeries together, or you keep 25. Some time in between cataract surgery and VR surgery?
I prefer a stepwise approach. First do the cataract surgery and then take the patient up for vitrectomy.
Okay.
Because I've seen that there is a lot of inflammation. The chances of inflammation, post-op inflammation, increase many fold after you do a combined surgery.
So that's the
and then there is formation of pupillary membranes, then secondary angle closure glaucoma, and all those things happening more in cases if we are combining the surgery. So I prefer to do a stepwise approach that gives me a better control and better leverage.
Yeah, very true,
sir. Regarding the stepwise approach, I mean, the phaco with anti-VEGF, one sitting and the second one after how many days? Or the anti-VEGF, phaco first, anti-VEGF second, and third is the surgery. How do you? Yeah.
So phaco, if the patient gets his phaco done, wait for now 15 days, then inject. If the blood sugars are under control, inject, and then after 3 to 4 days, take up for the VR surgery. But in some situations, I have to do an early surgery because if it is a patient of, especially if combined retinal detachments, because they tend to progress very fast. So in those cases, I tend to generally wait 1 week after cataract surgery or do a combined surgery.
And if the patient has a NS1 or the very early cataract with a diabetic VH, so would you do a phaco because just the vitreous, it is easy to clear the vitreous from the base, or just skip it and just do the vitreous surgery?
So I think what I'm saying now is something very controversial, but I generally prefer even to remove a clear lens before a diabetic vitrectomy. So one thing is it gives because you always find that there is a lot of anterior highlight which is left after vitrectomy if the patient is phakic. And there's a lot of chances, there is many increased chances of anterior hiatal proliferation and later recurrent vitreous cavity hemorrhages, which keeps on happening in those patients. So I prefer if the patient even gets a clear lens extraction, if the patient is above 45 years of age, get a clear lens even extracted, because I've seen even after vitrectomy, within 6 months, the patient will need a cataract surgery later on. So better to get the things done. Secondly, what happens is if you do a vitrectomy first and do all the complicated things first, and still the patient develops cataract, he is not going to appreciate your effort. Only when the patient gets a cataract surgery done, he will say, oh, that cataract surgeon has got me correct. The first surgeon was not good. So better you get the cataract surgery done, and then only the patient will appreciate your effort.
True. Thank you so much, sir, for a great presentation. It was an amazing surgery we all witnessed.
Thank you. Thanks a lot. It was all my pleasure.
Thank you so much, sir. Thanks again. We move on to the next deferred live surgery. We move on to the next deferred live surgery. Dr. Abhishek Anand, sir. He is Associate Professor at RIO IGMS. Dr. Shivani will be the moderator for the session.
Can I have that PPT? So, this was a case of a 60-year-old female who presented with, who noticed diminution of vision 15 days back, and on examination her visual acuity was hand movement, but PR was accurate. Other eye was 618. The lens status was pseudophakic in that particular eye. So the fundus photo had a total RD with a macular hole, and the OCT demonstrated macular hole also. Video.
RIO OT. Dr. Abhishek Anand sir is the operating surgeon, is the additional professor at RIO IGM. And I am Dr. Shivani, who is assistant professor at RIO. So sir is going to operate on a 51-year-old female who has got total rhegmatogenous retinal detachment with macular hole. In this patient, in the fundus photograph, we can see that there is a macular hole in the center, and we can see the bullous appearance here. And this is a total RD with a suspected lattice in the superotemporal quadrant, and with a suspected break in it. So sir is starting the case, and he has made his first infusion port.
What is the phakic stage?
So
Phakic or pseudophakic?
while we make the infusion port, it is important to check the placement of the infusion in the vitreous cavity.
So if you are dealing with a RD case, so it's very important sometimes that we have to look for it. Two reasons. First of all, there might be sometimes be coexisting shallow CD also, or it might be a frank CD also. So your infusion port might be under choroid also. and then that can cause an accentuation or iatrogenic increase in the choroidal detachment itself. Second is that sometimes due to anterior PVR, the retina is pulled anterior. So you might accidentally place this infusion port under or you might have, while you are entering it due to the trocar cannula system, you might end up in the subretinal space due to anterior PVR. Or sometimes even if the retinal detachment is very bullous, then also. So it's very important, especially in cases of retinal detachment, that you look for the placement of the tip of the.
So there are cases in which we use 6 mm cannula.
Yeah. So we have not been using 6 mm cannulas, but traditionally we have been taught during our fellowship that you should know how to use 6 mm cannulas, especially where you are not able to, when you will not be able to see the tip of the infusion. So what are those cases? Are mainly when you have very bad INDOF, dense INDOF, or very dense vitreous hemorrhage. So you want to be sure about it. The other way is to go around is that you put the trocar cannula system. This was more in the era where there was no trocar cannula system. So now with the advent of the trocar cannula system, what you can do is that you can put the trocar cannula, and rather than putting the infusion port, you can just insert the light pipe. So if you are able to see the light pipe, tip of the light pipe, that means most probably you are not in the subretinal space, and also by the quality of the glow, you will be able to know it. So till now you can see the subretinal fluid coming, right? This is not what I intended, but this is inevitable sometimes in macular hole RD, especially, that the subretinal fluid is coming as a gel through the break itself. Till now I have not been able to see any break. Only one break that I have been able to see is this macular hole retinal detachment. There is a superior lattice which we can see. The PVD appears to be complete. See. So one thing that, Shivani, we are going to stain it with tricot, right? In this case.
So we will stain it with tricot.
So you still see, can you see it?
We can see the fluid egressing through the macular hole.
It's still like a gel, right? Ideally we should avoid it as much as possible, but it's coming inevitably.
And we can see that by using the light pipe as a source, sir is using it to eliminate the vitreous and is cutting through it.
Now this time what I'm trying to do, I would be injecting the tricot crystals, and if it had been any other, I could have injected here, but since there is a macular hole, I would just injecting, and I would be decreasing the volume also, because sometimes they might go, because there is the RD is present, so I was not able to do that, and might be some crystals would have gone subretinal also. But I have seen that once the crystals go subretinal, see, you can see the crystals have gone subretinal.
So staining of the posterior vitreous is very important with the use of the Orocot.
Diamond dust script, yeah.
And we are sure of the PVD because in this case we can see that the crystals are floating away, and we are sure that there is complete PVD in this case.
So one of the unique part of this OS4 system is there are two very unique part is that whenever the cutter gets occluded with the vitreous, they have a different, just like the FICO system, they will give you the sound. And just to be doubly sure, I can see some crystals hanging there. So I just want to sweep with my dumb endoscopy, which is a very important to look for whether I am not missing something.
So we have got additional sound cue in this machine, which enables us to identify the occlusion of the cutter. So sir, this is sir is using DDMS to scrape off and see whether there is any remnant vitreous which is left sticking to the retina.
Yeah,
onto
because
the
these
retina.
crystals you see, they are sticking in a bit of unusual pattern. So I think there's not a seat of cortical vitreous, but then there are certainly remnants of vitreous which are there. So these can act as a foci of future gliosis, ERM formation, gliosis, epiretinal gliosis. So I just want to take care to remove it at least in this equatorial, this posterior pole. I just want to be doubly sure that this goes away. But I am not able to elevate any seat of cortical vitreous, which would generally be able to. But I then certainly some amount, I think there is some remnant of it, which is present. Now I'll just inject some PFCL, hard tip.
So PFCL is a very useful armamentarium in the kit of the VR surgeon. So it acts as a third hand. So what are the cases in which you will prefer PFCL, sir?
So PFCL is very, the most important in a case of here you are doing a case of retinal detachment. So in those cases, if you have a lot of fluttering of the retina while you are doing peripheral vitrectomy, so in those cases I would like to use PFCL. And also, like in this case, there is a macular hole which is already present. So my action is to stabilize the posterior pole by using PFCL, and then I do now.
So sir, while injecting PFCL, what are the precautions that you take?
Yeah, the first step, did you notice that I did some amount of fluid exchange? Could you see? So I think the most important aspect is that why PFCL goes subretinally is because we do give lot of pressure while we are injecting it.
So it should be a smooth injection.
Yeah, so to achieve that smooth injection you need hypotony.
Yeah.
And for that you need to create some amount of relative hypotony. So in this OS4 system, the issue is that once you press on the foot pedal, the infusion will be always on. So then that is why I had to use the passive system to ingress some fluid to create a relative hypotony, so that I am able to inject the PFCL very smoothly. There appears to be a small break here. See?
So as we can see, the PFCL has stabilized the retina, and the fluttering of the retina is very less. If it had not been stabilized with a PFCL, it would have fluttered, and there would have been a chance of retina being caught in the cutter.
So now I would be staining the ILM under the PFCL.
So there is a change in the lens which we are using.
This go down.
So this is the macular lens what sir is using now, and we can see clearly the posterior pole. So now we would be staining under the PFCL, right sir?
Yeah, I would be staining it under PFCL.
So we use BBG dye to stain the ILM.
So, and I am using the hard tip.
So sir is going underneath the PFCL and is going to inject.
So just
So do you always do the staining after injecting PFCL for macular hole RDs?
Yeah, I prefer that. I don't
do. So he's doing a very meticulous staining of the ILM.
I don't do it in a free floating retina. I always.
So are you not afraid of the BBG toxicity of the dye, sir?
So that is the advantage, right? So there are two advantages if you are doing it under PFCL. See, the amount of BBG that I am using is very less, right? And since the retina is already flat, so there is no chance that it will go subretinal. So I think
stain well under
if you are
PFCL
doing it
also?
under PFCL, you decrease the amount very less. See, I am just touching it and it spreads automatically at the interface. There is a fluid current at the interface of the PFCL and the retina which allows it to uniformly spread. I'm not pushing anything. I'm just keeping the dye at this place and it will automatically give me the cut.
So doesn't the PFCL change the elasticity of the ILM?
Yeah, that is, I think whichever way you are comfortable, do it.
Abhishek, can
So
we
I've
use
been doing
soft
it like
tip for
this.
this spec?
Persons advocated doing it
Soft
free
tip.
retina. I am in a government setup. I don't have access to soft tips.
So we can see that the ILM is
I
stained.
think soft tip will not. I have tried with soft tip. It's not that. I'm not that comfortable with soft tip. I think I feel more comfortable with the hard tip. And we don't touch the.
So a very important point is when we are staining the ILM, and if it's not staining with BBG, then we need to look for any ERM in those cases. So it is not going to take stain with the help of the BBG. This is a very important step in the macular hole surgery, the ILM peeling.
At this point, there was some amount of loss of focus. I don't know because of.
So which technique are you going to use in this?
So I will create multiple flaps under the.
This is a pinch and peel.
Yeah, I will pinch and peel. During the surgery, I was wondering why I am having this loss of focus, but now I am seeing that even on the camera it has been.
So this needs a lot of adjustment so that we have a very clear view of the ILM as it is very thin, and we need to be very sure that we are pinching the ILM, just the ILM.
Which forceps, Abhishek?
So he's trying to create a flap, and we can see he has lifted the flap.
So we are using the 23 gauge epsilon titanium forceps, and believe me, we are using it for at least I think 150 cases, and then they have
so
some.
This technique looks very easy in the hands of Sir,
we don't.
but he's a very good surgeon.
And we don't have access to the max grip
for a new VR surgeon.
It's very good. But it
peeling under IFCL is a little hard thing.
Less traumatic also.
Because many a times it comes in parts.
So this is the epsilon 23 gauge.
ILM peeling forceps.
Yeah, and this is quite old. I think we must have done peeling at least 100, 200 cases with this. There are multiple persons involved. Ram Babu is now involved mostly in sterilization, and we use the ETO out from it.
So the peeling becomes difficult in cases of RD. If it had not been RD and a simple macular hole, this lifting tendency of the retina would not have been there.
Yeah.
Still, it is more stabilized because of the use of the PFCL.
So I prefer PFCL. There are a lot of seniors and my peers who. So I'll just put everything here and just leave it here.
So sir is not stuffing, he just left it in place.
Yeah. And now I'll just do the complete peripheral vitrectomy.
So he will move ahead with the peripheral vitrectomy or the base shaving.
So now since we have changed the lens, now you see the amount of PFCL has decreased. What was there before is now decreased. Vacuum थोड़ा कम कर दो सौ. Vacuum 200 कर दो.
So now while doing the base shaving, he has decreased the vacuum. He has brought it down to 200, while before he was using around 350. So while doing the base shaving, he would be, it is very important that we keep on seeing the opening of the cutter, just to be sure that we are cutting the vitreous and not the retina.
Intent. अंदर जाओ, अंदर जाओ.
So by using indentation, it is made sure that the vitreous is removed till aura. So here we can see the aura clearly.
थोड़ा अंदर जाओ, थोड़ा वहीं पे अंदर जाओ. छोटा वाला से जाओ.
Sir, what should be the extent of peripheral vitrectomy, especially in case of young phakic patient?
So there was a small horseshoe tear at 6 o'clock also with lattice.
When I started my career, I was very aggressive for doing a lot of peripheral.
So it is very important to remove all the traction around the tears of the brakes, because if we are not able to remove, then
now I am less aggressive towards that much of peripheral vitrectomy. Also depends on which tamponade.
it is going to lead to re-RDs later.
So if I am going to use a silicone oil tamponade, that is going to induce a more aggressive, gliosis, whatever you say, interior. So in those cases, I will be more aggressive towards peripheral base filling. But if I am going to use a gas tamponade, might be I will be less towards not that extensive peripheral vitrectomy. Ma'am can also contribute.
Thank you.
So I will be very meticulous here, trying to remove the vitreous as much as possible.
See, in this era of visualization, we are seeing more than necessary. Like we can see even ciliary
So sir, how important is base shaving in a case of RD?
Yeah, one should do adequate job, not necessary. For example, in this case, I think the superior, whenever we find the lattice, for beginners, it's important immediately to cauterize, because sometimes things can change during the process and you may not find that again.
So this is a very important input that ma'am has given, is that your first priority is the brakes. You have to market it, just geotag it, something like that, that you don't miss it at whatever may be the worst case scenario.
And how much ever your experience, better to
break.
Tag it immediately, cauterize and
Yes.
keep it. So that could be, because sometimes, and in this case, you have used tricot, right? So I use only brilliant blue for me, because brilliant blue will stain the vitreous very, very well. In fact, even in pediatric retinal detachments or anywhere where we are sure that there will be underlying another cortical vitreous, even in high myopic patients.
Very thin sheet of cortical vitreous also you are using, ma'am.
So what I do is I put brilliant blue and then I try to go with the ILM forceps and try to see that wherever I can get a hold of either cortical vitreous or ILM. So sometimes what happens, there can be a patchy, and then on the because above the ILM only you are having cortical vitreous, so you will be able to get that sheet and then you can feel it.
Like in re-RDs, I am using a lot of, like I will fill the whole of eye with brilliant blue.
It's like a pan ILM.
Yeah, I just fill the whole of eye with brilliant blue. But you are doing it you have abandoned the whole of this, no?
Yeah.
You are not using tricot anymore.
No, I never use tricot, usually brilliant blue only. Because it works for both. Anyway, whenever you have macular pucker, you want to again remove the ILM. So even if there is no hole. So it will work for both ways. So brilliant blue, anyway you have opened, so you will stay in the vitreous also and it will help in the ILM also.
Yes.
Here you can come, because the anatomy of the lens is like that you can come here on the sides.
So we cannot cross the lens in the...
Yeah, you will not be able to cross the lens. Right? Here
So we
also,
keep on changing the hands
so
in a case of phakic patient.
Yeah, so here is the lattice. So we have two breaks, one macular hole,
We have a lattice here, and this I will just save the very small horseshoe tear here at the left side of the lattice. So I'm just removing. Chalo aage.
And peeling under the PFCL is one aspect, one way of technique. Sometimes what will happen is retina becomes too much flattened, especially in high myopes and all. Sometimes it will be difficult. So in a detached retina, it is much more easier to peel sometimes.
So yeah, you can do a Sandlia illumination and self-indent, or you can have the liberty of having a very good.
Ma'am, just one more question.
Assistant who can indent as beautifully
like if there is a pre-existing macular hole,
who understands where you want the indentation.
Sometimes the brilliant group
migrates. So that can only defend if, if the person is.
And then it causes the loss of contrast because of the subretinal migration. So what's your thought about that, ma'am? So do you do stain under fax?
No, I always under air.
Yeah, that is that. Yeah, that
so always I put, if required, something like a little more drainage retinotomy, or if there is a pre-existing break, and then under air only I do it.
So I stain it under fluid, and so that is why I feel, because one or two stances have happened is that when I have tried it, then without putting the PFCL fluid, it has migrated, and then I lost a complete contrast of that.
Just now mark my breaks and then go for fluid exchange.
Sir, how important is to mark the breaks?
I think it's very important because a lot of time under the air the clarity of the retina can give away in diathermy. So once you have marked the breaks, at least you are sure that you will be able to, you have to do laser of them. That is damn necessary. So you have to do, and how we approach the laser, like in this,
paucity of time,
so there is no space to move around. Then you will have to do
a bit forwarded, because
or
we
you
have
can do
one
an
more
extended
talk
laser
left.
artery. Somehow you have
One or
to
two more talks left regarding the live surgery.
In macular hole RD cases, sir, if hole is primary, then we definitely need to peel it. Can we, if hole is secondary, macular hole is secondary, primary is some HST or like in your case, it is looking like that. In those cases, if we only attach retina, we have seen that post-operatively hole closes even without ILM peeling.
Yeah, there are a lot of papers on that in which they have advocated that there is no need for doing an ILM peeling in cases of secondary macros, and they will close spontaneously. I think it's more of a surgeon preference.
So what is your opinion, ma'am, whether we should peel on at the time of operating RD, or we can peel at the time of SOR in those cases if hole doesn't close spontaneously with settlement of retina?
So I feel that, for example, if it is macular hole is not the reason, and sometimes if it is, you think that there is a lot of strong vitreous attachments and everything, and if it's a very peripheral break, you can always do a buckle, and later on nicely when the retina settles, you can do macular hole as a second surgery also. But when we are inside, we tend to go more in towards the ILM peeling because of the two reasons. Not because you need to definitely remove ILM, but you just don't want to miss any cortical vitreous. Because of that reason, you want to do ILM peeling. For example, in pediatric detachments, young phakic patients, you go inside and you try to peel the ILM, even if not entire, you need not be aggressive around the hole completely, but even if you remove the temporal arcade shape of ILM, you are sure that you have not left any vitreous. And if you could remove that anyway, you would like to leave the, and I also use the similar, I don't stuff anything, I just go with the semilunar flaps and leave the flaps there, like they will be freely floating.
So even in this case, we had a very small horseshoe tear which we marked it, and from that also we are able to remove most of the fluid. So you don't need to do a posterior retinotomy. That is what I also wanted to convey. Avoid creating, another, because there is a lot of urge to, dry the whole of retina. Avoid it as much because many a times those posterior retinotomy itself leads to a secondary opening and redetachment. Many a times I have seen, especially in young patients.
Yeah. So always, actually having a bullous fluid in the posterior pole, nothing is going to happen. It will, actually the retina will settle gradually in the whole night. I think that is much more, far more beneficial than trying to put PFCL or making a posterior retinotomy and try to flatten the retina. So, and that has been now proven very clearly by multimodal imaging by Rajiv Muni and all, showing regulated RD, non-regulated RD, and if it's slowly, gradually, it's like for example non-drainage buccal, when the retina gets the least displacement of photoreceptor occurs. So because it is just happening in a very gradual fashion.
And it's going to use 1500 CST Orocell in this case.
So just to
And we have seen that.
So we have closed this eye under oil, and just to emphasize that 23 gauge multiple times, you feel that it might not be, you need to put a suture. So
in the natural anatomy, rather than achieving very less time, we have to invest a bit more time to achieve a sutureless closure of this. And sometimes if we are not able to do, then we can go for a releasable sutures. If there is a case in this one of the port, if it remains open, I will show you how to do a sutureless, releasable suture, which you can remove it tomorrow.
So if you are using 25, so you have to stick to one of the systems. Either you use the 23 gauge system, or you stick to the 23 gauge system, or you stick to the 25 gauge system. So we had to stick because of the 23 gauge. So for, sometimes I think the scale has this sort of plasticity, and we need to give time to it to oppose it. Rather than why it is not closing, just if you punch it, and with a blunt instrument, with a force, if you move it, then can. Also we have developed a new technique in which we can just put a shoelace suture. You just pass one through it and tie it like a shoelace. In this case I wanted to sew it, but they close spontaneously. Then you put the shoelace, and the next day you just pull it out. So that is a releasable suture that we have developed, in which everything is fine, and till now we have done more than 150 cases and no chances of any end-off or anything like that.
70 VITREO or 80?
VITREO.
Sir, we saw you used silicone oil tamponade here. Probably there was a 6 o'clock HST.
Sorry?
We saw you used silicone oil tamponade here. Probably there was an HST at 6 o'clock.
There was HST.
Had there not been an HST at 6 o'clock, only superior lattices and breaks, not for the macular hole per se, what do you think? The gas tamponade is better?
I think gas tamponade would work best for the patient.
Especially for the macular hole scenario.
Macular hole with a superior
that is there, but for the macular hole also, is gas tamponade better than silicone oil in RD cases?
For me, if I have any liberty of using a gas tamponade, I will always prefer gas tamponade over silicone oil.
So what is your take about chances of closure of macular hole with silicone oil tamponade versus gas tamponade? Which is better? Any particular?
I think 80%.
I think because of the meniscus action of the and the surface tension that has the gas, I think it would be better.
With gas tamponade, the chances of closure of macular hole also in RDs will be better.
Yeah. Silicone oil conforms to the continuity.
So would you prefer where would you prefer SF6 and C3 fit?
So SF6 is, as we have running through, there is a renewed interest in SF6. So what we know is that SF6 is a rapid expansion compared to C3 fit. So for those scenarios, I can't comment on the surface tension of those because I don't have any idea regarding what is the difference in the surface tension of C3 fit or SF6.
So we are talking about SF6 versus C3 fit in regular macular hole.
Yes, ma'am.
So I want to share one experience. We also have a presence in Liberia. So in Liberia, I had to go and I had to operate macular holes. And they were very chronic macular holes, means distance large holes, and there is no gas in Liberia. Okay, so what we learned is that I do something like a same flower petal technique where I place semilunar flaps and I leave my edges of the flap just up to the edge and leave it all around, and I don't stuff anything, no PF cell, no substance, nothing. I don't even stuff the flap, so they will be like free floating. And then after air exchange, I go to the disc again. After 1 minute, I'll time it, because naturally many times we don't time it. We time only during brilliant blue to stain. And then I go to the disc and then suck the fluid again after 1 minute, making sure that as dry as possible. And I operate with Ingenuity in Hyderabad, and there it was a Reticare machine. So the fluidics are entirely different. So what I am trying to say is that next day, leave alone the complete air bubble, there was only half air bubble and there was also mild CDs. And then we operated 6 macular holes in 2 days, and all macular holes closed under air. So then I realized it is the technique of that flower petal, just keeping it, because what happens with the flower petal, if you observe, when we suck the fluid at the disc, some of the flaps, they just come and they actually come and act like a scaffold on your hole. And that is enough for the macular hole, and the tamponade, whatever we happen during the surgery, and making sure that it is dry is important. Now, last 2-3 months, March I went, and now I'm only putting air. So that means this gas has no meaning, but we can say confidently we are now going to do an RCT to say there are many RCTs are also air versus gas, but unless you do experience yourself, you cannot tell that. I would say that probably the technique, how we peel, some amount of ILM need to be there to act as a scaffold.
Okay, ma'am. Thank you. Thank you.
Ma'am, in some cases, like if we get post-op subfoveal PFCL, so how do we deal with that?
See, subfoveal PFCL is a tricky situation, right? Especially just underneath the hole, if you are having and all that. So that is something there are people who inject again developing the RD and trying to displace and all. Yeah, it's a tricky situation. Yeah.
So we move ahead with the next deferred life surgery of. I call upon Dr. Vivek sir to moderate the session.
Excellent
and Dr.
surgery,
Salab sir as the prime surgeon.
As if it is not looking deferred life surgery, life surgery.
The surgeon, Salab in surgeon's dress and gown is coming for deferred life surgery. It gives impression that he has come out from the OT right now, but actually it is a deferred surgery and it was recorded earlier.
To give the feel of life surgery.
It was a sacred.
It's always a surprise.
From next time deferred life surgery, President has to hear this.
अरे ये प्ले नहीं कर रहा चल नहीं रहा ये भी हैंडल करने की जरूरत है नहीं ये प्लेयर तुम्हारा ठीक नहीं है अपलोड कैसे नहीं हुआ चला के देखें प्राइवेट में थोड़ा सा डिफिकल्ट है मोस्टली फेक ओल्ड आरडी कुछ लेना नहीं
अभी टाइम नहीं चालू हुआ है अभी
ये चल नहीं रहा है इस पे नहीं चल रहा हाँ
So before you are starting, sir?
No, it's not playing.
So before sir starts, how many of us are still doing buckles in our regular practice? So, sir, ma'am, in which cases do you specifically prefer buckles?
think the decision is whether it is a buccal suitable RD or vitreoretinal surgical RD will come when we are comfortable with both the techniques. I feel we are choosing less buccals because we are not getting exposure during training periods or anything like that. But if you are learned the technique of buccal and vitrectomy, you will automatically choose wherever that is required. Like for example, young phakic patient, where you have multiple lattices. Even there is nothing like one quadrant, we have to do 2 quadrants. So in a suitable case, whatever you require is an 8 sutures and 4 quadrant is what required. So you won't step back to do in any indicated case to do a buccal. That's what I would feel.
Ma'am, bail.
Combination of buccal and
especially for the inferior breaks.
Yes, means like for example, Abhishek has done the surgery where there is and we are removing so much vitreous. In those kind of cases, no problem. But if you are expecting some anterior PVR changes and there is some PVR contraction, definitely we don't want to do any relaxing retinotomy as a primary surgery. So your buccal will help, belt buccal will definitely help you to, to support that vitreous base and those tractions. And as sir said, any inferior retinal detachment or any retinal breaks, it will give you a support. And sometimes you might miss a small flaps or anything that also can be there on the buccal, belt buccal.
Ma'am, one more question. Like in normal phakic patients, young phakic patients with sectoral RDs, so do you prefer sectoral band buccal or segmental buccal, or you support it with a 360-degree band?
No, I will see the other area of the retina. For example, have a segmental sectoral retinal detachment, but there are multiple lattices in the other area. So I put belt as a investment for me to in future to act like a support that way. And most important is we like how toric surgeons, cataract surgeons, they assess their refraction. We should also assess our refraction power, how much it is coming. So whether I put band or whether I put segmental buccal, my refractive power of buccal will not change beyond 1.5 to 2 diopters. If we aim for those kind of refinement in terms of tightening, it doesn't matter actually. If you, the problem will come when you can see cases where 8 diopters myopia, 6 diopters, then we will be worried. But if you are able to nicely do only a moderate buccal effect and you are able to assess the refraction, I think should not matter.
What is the experience of people at SN, like LVP, like after putting segmental buccal, do we really get chances of re-RD like post few years?
So I would say that for vitreoretinal surgery, we are not sure for life. Like even we see that after removing SOR, even after 2-3 years also we can see. But for buccal, I would say that if the chances of recurrence, we can count the number. After buccal. Yes, it does happen sometimes when there is a violent posterior vitreous detachment occurs in a child and all, but it can be less than 1%, I would say. But in vitrectomy, sometimes even 10%, 15% can be possible in spite of doing everything that is supposed to be done.
I think can we infer that if there is no problem in other quadrants, can we shift towards a segmental buccal?
Of course, you can always shift. But what I'm trying to say is that you just assess the other areas of the retina. If you feel any suspicious areas are there, or if you think there is a lot of vitreous changes are there or something like that, you can support with the belt. Otherwise, you can leave it. Absolutely.
Thank you.
Ma'am, suppose in the other areas there are lattices or holes, we can always laser them and then proceed with segmental buccal.
Absolutely. And what I would say is that any areas which are like either attached retina, even in the shallow detachment, instead of cryo, laser is always better. Yes. In fact, we used to do LIO first, finish off all the for example, child is under GA, finish off all that and then put the buccal placement.
Ma'am, how to deal with cyclitic membranes in uveitic RD patients, especially in pediatric?
So I think Chandler is a very good way where you can have control over your both instruments and everything, whether it is cyclic membrane or whether very adherent, vitreous membranes in diabetic or anything like that. Bimanual can be a very good way where you can have a control and then view of the thing. And sometimes we need not be aggressive. We can even just cut segment and leave it to relieve the traction. That is also fine. It's not that you will be able to remove in toto of the entire expected.
So, do you suggest to put belt buckle support in all pediatric uveitic RDs?
In fact, I go for 42 band.
Now, Salav sir is ready with his surgery, deferred live surgery video. He would be showing us a case of traumatic subluxated lens in which he would be doing phacofrag vitrectomy and scleral fixated IOL.
So thank you to the moderators and VRSB executives. So this is an elderly male. He sustained trauma in this eye, and you can see that the lens is partially subluxated. It's in the anterior vitreous. There is a area of iris has been torn. So placing the first infusion, and as I always tend to check whether the infusion is there actually in the vitreous cavity or not. So this is basically a Stellaris system, Stellaris PC, and these are non-valved trocar cannulas. So sometimes with with reuse, these tend to get stuck. So I started off by doing an anterior vitrectomy, and the lens somehow I felt like it was coming up. So I decided that I can probably remove this lens from the anterior root itself. So I'm now making an incision in the conjunctiva, and basically an SICS wound, you can see. 70. So if we have to remove the lens from these kind of cases, it's always better to have a self-sealing SICS wound rather than trying to do a. So as soon as I entered, what you saw was that part of the capsule actually came into the wound and released the nucleus. Now the nucleus is not going to come out from that. So the nucleus has already sunk into the anterior vitreous. It has gone slightly more behind. So now I'm not going to try and fish it. And as now you see that the whole nucleus, it will just sink into the vitreous cavity and fall on the surface of the retina. So at this point of time, I decided that better to do a conventional vitrectomy with a phacofragmentation. So trying to remove the remainder of the capsule there. Going from the other side. A little bit of pressure from the external part of the eye, you can depress and see more of the peripheral capsule there with a little bit of cortex. So just holding it and pulling it with suction, and then just chewing it up with the vitreous cutter. So one has to be very careful at this point of time. Sometimes the pull itself can drag on the base of the vitreous, and you can very easily create a giant retinal tear at that point. So we shouldn't be too aggressive in doing this. Okay, so now our conventional vitrectomy being done. This patient was an elderly male, and he already had a PVD, so there was no need to induce one. I will use Kenacort. As you can see, I've put Kenacort in the eye, and there is no vitreous sticking to the retina at the posterior pole. Just peripheral vitrectomy needs to be done, especially in the area where our phaco needle will go inside, and due to the getting the as I said, because of the reuse of the I just wanted to show you, because of the reuse of the instruments, so you can see that because of the Stellaris PC, my fragmentome actually goes through the cannula. I don't need to remove the cannula. I changed the cannula because my phaco needle was getting stuck in the lumen of the cannula. So it's a pretty hard cataract, as I said, 70-year-old male, and it took quite an amount of time for me to, break this nucleus down. I use a contact lens system. I don't have a non-contact one. So that's why, because if the eye is moving, the lens also tends to move with it. And the view can sometimes get hampered. If an air bubble comes in the anterior part just below the cornea, that also, sometimes, and that is what is happening actually in this case, that the air bubble is making it difficult for me to see behind. So you can see all these air bubbles that had come because of the phaco. This cavitational bubbles came into the anterior part of the eye, just behind.
But you will avoid fogging, right?
Yes, ma'am?
You will avoid fogging of the front.
Yes, there's no fogging because of the contact lens system, right? With a non-contact one, you can get fogging. Again, some little bit of anterior vitrectomy for the residual part. And this is a very important step that one has to do, make sure that your anterior vitreous, just where your haptics are going to come out, they must be totally free of vitreous. So I always depress that area and the area of the trocar cannula. Same thing is done on the opposite side. And then, sclerotomies are made 2 millimeters behind the limbus on either side. Actually, I wanted to show that I actually marked. So I'm measuring, see. So always mark exactly 180 degrees. Mark the 2 millimeter. One has to be exactly at 180 so that your lens is exactly right in the pupillary area and not, inferior or superior. So making the sclerotomy incision with the 23 gauge bent MVR, and then I'm making the chariot pockets for the fixation of the haptics. Side port incision. Oh, sorry. I could have just implanted the lens without the injector. Already have a large incision there, but still I use the injector. So this is a foldable 3-piece intraocular lens from Aurolab. What I find with the Aurolab intraocular lens is that the haptics are slightly more thicker than the ones available from either Alcon or the Sensar 3-piece. I feel that the haptics of the Aurolab lenses are slightly thicker and they are more friendly to touching, because I have broken few haptics at the ends. I have broken them because sometimes they are so thin and delicate with the Sensar and the Alcon ones. So I generally tend to prefer this lens over the imported ones. So what you can see, what happened was that although I grabbed the tip of the haptic, I actually couldn't bring it out. So again, one more attempt, making one more side port. So simple two-handed technique, a handshake technique. Make sure that you hold the intraocular lens right at the tip. Now holding that haptic, the trailing haptic is pushed inside the anterior chamber over the iris, and I do not use any buckle element or any other element to hold that haptic, because my direction of holding the other haptic is such that I generally do not dislodge the first haptic that I have brought out. So holding that haptic, and as I come out, I just hold the one that I had previously brought out. So now both my haptics are out, and just checking the pocket. One could make a conjunctival peritomy at that part, and make sure that your haptic is going right into the sclera. Sometimes if you don't do a conjunctival peritomy, your haptic can also be subconjunctival, but with experience you generally get away with just a pocket in the sclera. Yes, I have not done a peritomy here at this place. It is actually conjunctiva and sclera. That incision is there. In the learning phase, it's a little tougher to put it inside the pocket. Sometimes it bleeds a lot. So in learning phase, you should do a conjunctival peritomy at that place.
Even
I think
later
your
on, if
forceps is also helping.
Yes, these are
because
actually,
if you try to do with just tying for the regular forceps and try to put, it will be very difficult.
So this is actually a gluteal forceps set.
That is what making the difference.
And if we don't
from
do the
Epsilon.
peritomy and do it over the conjunctiva, the risk, we are creating a tract from the outside to inside also. So ideally, even the haptic should be under the conjunctiva, and there should not be any tract from the outside to inside the eye. So I believe always the conjunctival peritomy should be done, and the haptic must be covered properly with the conjunctiva.
So if the conjunctival peritomy is not exactly there, if we always, for example, even when we do sclerotomies, right? So if you displace and put the trochotomy, the conjunctival peritomy will not be lying on your sclerotomy. So it's always a good practice to
But here, since the haptic is outside, so a tract is there which is communicating from the outside
Yes,
to
so
inside.
what I always do is I always suture these sclerotomies. I don't leave it just like that. Although it is self-sealing, it's not leaking, but now I have made it a habit that I always suture these sclerotomies.
No,
And
I'm
you
not
will see
talking
that.
about the main port.
No,
I'm
no,
talking about the
these-
haptic.
Yes, the
Oh, you
haptics.
suture that.
Yes, always.
Oh.
So this is a pupilloplasty being done with a Prolene 10-0 needle. So because there was a tear in the iris, so to give better cosmesis to the patient, you would want to also repair the iris. So this is the technique which was developed by Dr. Amar Agarwal, the 4th row pupilloplasty. So this is a 30 gauge needle on which you will railroad the Prolene needle. If you use a 26 gauge needle, what I have felt is that sometimes the hole in the iris becomes too big. So it's better to use a 30 gauge needle so that the hole is smaller. You just need the tip of the Prolene needle to just go inside the lumen so that it just comes out. So now you can just bring out one loop of this. So you can see the loop here, and passing the suture 4 times into the loop. That's 1, and then 2, and the third one, and once more. So you have given 4 throws, and you need to just pull on the other part of the Prolene suture, and you can see that that defect that was there has been closed with single suture, and that is cut. And you can see that I always even suture the conjunctiva of any SICS wound also. If I make, I don't just cauterize. You can cauterize it, but many people just massage it over the incision, but I tend to suture it. And as I said, I always suture these sclerotomies also. The 23 gauge sclerotomy as well as the sclerotomy for the haptics. So once I have sutured all of them, you will see that I will also suture the. And just going back to the surgery that was presented by Abhishek, it's always better to put in sutures if you're having silicone inside the eye, because it invariably tends to leak and you will have subconjunctival silicone oil. That subconjunctival silicone oil itself causes a lot of inflammation. So one should not have that ego that I don't suture my sclerotomies. A suture doesn't make too much of a difference in the long run. It's always better to have a suture. See, I am also suturing the sclerotomy. Both these on either side, I always suture. And what that does for me is that not only it closes the sclerotomy, but also if you have taken a bite properly, sometimes it also holds this haptic. So the haptic doesn't slip out in the post-operative period. So at the end, this just a little bit of moxifloxacin inside the eye. As a routine, I always inject moxifloxacin. Okay. Sorry, I couldn't. That other video that I had brought didn't play, and because you mentioned about the brilliant blue, in that particular case, when I put brilliant blue, it actually stained the peripheral vitreous, and I could use it to just peel the vitreous from the surface of the retina and the periphery.
So in 2017, when I went to URetina, there was one video which got best prize. Was PVD induction made easy with brilliant blue.
Brilliant blue.
So, and it's a very nicely it will stain. Like we also observed that when we use brilliant blue for macular hole, and then after some time when we go inside, we see how much vitreous which was there peripheral, and it is much, for me I got used to, because much more easier to actually cut.
Very nice presentation, Shalabh. We have always a tendency, अरे तो निकल जाएगा, ऊपर से निकल जाएगा. But in this process, we unnecessarily prolong our surgery. There is vitreous prolapse and there is traction part also. So of late I have realized कि यार डूबना ही है तो पहले ही जाने दो इसको यार, and we try to go for direct frag and.
Because of the elderly patient and because of the hardness of the nucleus.
We have a tendency, अरे यार हो जाएगा.
Because of the hardness of the nucleus, sometimes what happens is if you have done a limited anterior vitrectomy, the fluid going into the vitreous actually pushes the nucleus out. You don't have to go in with a vectis actually. So if it just the fluid pushing the nucleus out, if it would have come out very easily had it not had the capsule not broken actually. So yes, the fluid going behind actually, of course, that is how SICS works.
What is your experience regarding using AC maintainer versus infusion port at conventional, for these cases in which we have already make it a single chamber? So is there any role of AC maintainer, especially
Yeah, so in case your pupil doesn't dilate fully, then that tendency for the iris to get caught in the injector is there. But if the pupil is fully dilated, generally it doesn't happen. And if in this case also, because it was an SICS wound, the opening was bigger, so the iris was tending to come out.
So
if it had been just a corneal incision, the iris generally doesn't come out through that.
Will that decrease if you use an AC maintainer?
No. See, if you are doing an anterior root scleral fixation of IL where you are not doing a 3-port pars plana vitrectomy, no, but why you want to shift the infusion from posterior to anterior? It doesn't make any difference.
Because of the relatively less trauma to the endothelium, relatively less trauma to the iris.
No.
I'm asking, we are deliberating.
No. The flow of the AC, the fluid through the AC maintainer is probably going to have more endothelial cell loss than what is there behind.
So that is what the house has, that it will cause more damage. Second is regarding your haptic that you said that do you find that the Aurolab has the best haptic optic integration?
Yes.
That is what you wanted to say, or do you want to say that the haptic is actually different?
No, the haptic of the Aurolab is thicker than Sensor or the Alcon. Longer also.
Slightly longer, yeah.
Length is also longer. So the ability for anyone to fixate the lenses is easier because you have more haptic in the sclera. So if you have shorter length in the sclera, it tends to come out.
So currently we have 3 options. One is the Sensor, second is the Alcon, and third is the Aurolab. I feel that Sensor has the highest tendency for optic haptic dislocation. Technically, same. Second would, I think, Alcon I have never encountered any, apart from recently what happened, which was more due to the, manipulation than I would say. And I think the strongest I feel is Aurolab.
Aurolab, yes.
Forceps, or you can put with normally or forceps also? You definitely need gluteal forceps for Aurolab to put it.
If you make scleral flaps, externalize your haptics, you don't need any of those specialized forceps.
That's what I'm telling. Is it more difficult to put the Aurolab haptic?
No.
Because I usually do only the Alcon. That's why recently I've shifted to Aurolab, so I thought I will ask you.
I think the Aurolab is
the best,
more friendly to a surgeon because of the thickness and because it is longer.
Sir,
more pocket friendly also, no?
Pocket friendly for the patient or for you?
I mean, for the surgeon. Yeah.
Sir, 23 gauge ILM forceps would tuck in the haptic in the same way as this blue dial forceps, or do you think?
Why ruin your 23 gauge ILM forceps with this? Because it is going to hold a very thick and a stiff haptic. So why you want to spoil your ILM forceps?
No, I mean there is a high chance of dislocation when you are trying exteriorize if you are using the ILM forceps because it has a very point grip. You need a broad grip.
Maybe ERM forceps, not ILM. Maybe ERM.
ERM. Yeah, microserrated forceps.
Use forceps for what they are meant for. I mean, don't. ILM forceps से haptic भी घुसाना है जरूरी नहीं है उसको ILM के लिए रहने दीजिए.
Sir, regarding the PVD induction in drop nucleus cases, I find it very difficult whenever the nucleus is lying over and sometimes it's more difficult than inducing a PVD in other cases. Probably it gets adhered to the retina. So what is your take? You do the phaco-frag without a PVD induction?
No.
Or just displace?
This is a question which is very, lingering in my mind for quite a long time.
Yeah, this is very, very relevant question.
Yeah, that all the simple cases like drop nucleus, in fact drop dial, they have a very, so is it due to the relative,
pressure.
No, I
pressure
think
effect.
it's the loss of the closed chamber. That is what I could attribute it to.
No, what
Ma'am, do you
happens-
have that? Could you understand the question? What
Yeah, we are telling that because it will be so difficult to induce the vitreous
No,
in this scenario.
Vitreous acts very differently, ma'am.
Yeah,
The-
vitreous acts differently, and it is difficult to induce a PVD, and
So-
we have to invest more time,
Yeah.
right?
Definitely, and even though age is more, we think that okay, 60-year-old still we expect that vitreous is already like how macular hole surgery, everything vitreous was. Definitely, I do agree, and also not only in these cases, but even in cases of macular hole and also in ERMs, the anomalous vitreoretinal adhesions are so significant, but that is the pathogenesis. So there are situations where we just induce PVD only up to equator. That also with lot of difficulty. So there is no point in going behind that vitreous tuner. But when we are using Facofrag, at least the area where you are introducing everything, there should not be any vitreous strand.
No, but see, what I think is, it's the weight of the nucleus. It's the weight of the nucleus. First, you're not able to see because the lenses or the drop nucleus, if it is a whole nucleus, it is covering the posterior pole. So you're not going exactly near the disc or near the macula and then trying to do the...
That is what we are saying. No, when
Yeah.
you can see clearly, everything is normal. This is a 60-year-old gentleman. Why should the vitreous PVD induction be difficult? Like we understand that VMA is there, then the vitreous has obviously different sort of...
it's a disease vitreous there.
Disease vitreous, and it will always, inevitably, whenever you are doing a VMA and you're trying to, you'll find that in periphery, just beyond the equator, you'll have some abnormal attachment. That is 100% sure. But why in a case of drop nucleus or IOL drop, the vitreous is going to behave differently?
Sir,
I mean,
but-
I just bought this because Vidata is also facing this.
I have struggled
Sir,
a lot of times.
Abhishek sir, but whenever we have a drop nucleus or something like that, there is some amount of inflammation also which the surgeon has already induced. The main problem which
Surgeon is not induced, the case
sorry.
happened. It's always the eye that responds to our interventions.
Sorry ma'am, the wordings are not correct. Also the weight of the nucleus causes, it's very difficult for us to induce and carry it forward. It keeps on weighing down. So it's very difficult, like I face difficulty in inducing a PVD in these cases relatively to other
Yeah.
cases.
No, the question to ma'am is, if it is that difficult, can we proceed with Facofrag without PVD? If we shave the port from which we are inducing that...
There is always some vitreous there. You're not seeing it. It's always
even
there.
no one can remove vitreous from the entire thing. But at least when we are using Facofrag, in the area of access where you are using the Facofrag, you should not have any vitreous. Probably in these cases, you try your work hard to remove it, induce as much as possible. And then your lens also, if the Facofrag is one thing, but those particles and all will be just scattered. And they'll all will be mixed with your vitreous column. And that is the danger. Where you might, in that view hazy, we think that the chunk is there, but it is actually mixed in the vitreous, and that is what causes the GRTs. And the breaks that occur in Facofrag should not occur to enemy also.
And one question more, ma'am. Like, question to ma'am. Like, we have a very hard subluxated nucleus lying in the anterior chamber only, means we can take it out through SICS tunnel also, and we can do frag also. So what would be your first choice? Is it frag or take it through SICS tunnel?
So I'm more confident when things are fallen down. In fact, even glued IOL also. See, glued IOL is not always as simple as it looks, right? Many times the haptic will not come, and also then I actually push entire thing down, and then very precisely you can actually pull it out. So that's how my preference is there. But at the second time, we would say that if it's a very hard lens and everything, and there are people, I think they also put PFCL and then try to bring the lens up and then bring back. I think it is all your comfort factor, the way you can actually remove. But if the capsule is not broken, only all those maneuvers are easy. If the capsule is broken, this is what that can happen. Yeah.
Ma'am.
So, like before we are discussing with PVD, when hard nucleus is lying on disc, we are not getting space there to induce PVD at the disc. So in that cases, I prefer to use PIC. that sharp MVR, thin MVR 27 G. I bent it a little bit and I try to induce PVD 2 disc or 3 disc diameter above disc superiorly, so that even if I dissociate some superficial fiber, it is not going to cause any problem. And from there I induce PVD, and as I get V's ring, I just try to pull nucleus inside that V's ring, and then it becomes very easy to induce PVD in those cases.
Ma'am, one question to everyone, and ma'am, I will put a case scenario. 7 mm pupil, black cataract, coloboma. So what would you take? Would you make a big tunnel, extract the nucleus
only phacophract,
or do a drop
and
the
you
nucleus?
have the advantage with the coloboma is getting into the difficult, but once you are inside, you have a big colobomatous area. There you can always keep playing with your colobomatous, and there will be like a Niagara. Sometimes it will be complete black cataract. So you spend time, and these are the cases. Editing, it will happen in 1 minute, but it will happen 1 hour also. But one need to be patient and then do in the colobomatous area. You do the frac.
So at what distance one should make the port? Like 7 mm cornea, it's very difficult to go near.
1
also.
mm only, and then you will be struggling with little temporally. You keep it so that your instrument. Otherwise, you will be as soon as you go. The cornea will become, shrink and everything. Like the view gets distorted.
Okay. Any more questions from the audience? Sir has already left for another surgery. Thank you very much, everyone.
Thank you.
So this brings to the end of the deferred life surgery session of the VITREO RETINA Society of Bihar. This is the first time in history, so we have made the history. Big clap for all of us, and again the credit goes to our mentor, Professor R.V. Azad, and of course the dynamic secretary and the man behind the dynamic secretary, Satyajit. And we all have worked together, but the ultimate credit and the guidance goes to Professor R.V. Azad. So this brings to the end of first session, deferred life surgery. So in few minutes time, we will have lunch break, and after that we will assemble at 2 o'clock for the next sessions. Since we have some time, so if deferred life surgery, this is the first time that I have personally experienced, but it has been there in some other places also. There was some confusion how it will be recorded, will there be some audio or some question answer or not, but thanks to one person who made it possible. I'm not thanking here, but somebody sitting in the Delhi who ensured that we go to deferred life surgery this time because of that NMC guideline. So definitely everything, whenever happens, it happens for good. So I think for deferred life surgery, if it is done in the future also, and I would say that we never felt that it is not life surgery. So it gave us the feeling of actually the life surgery, with the same amount of discussions and the same feeling of having life surgery. So it is no way less than the life surgery. At the same time, the surgeons were more comfortable doing surgery there at that point of time. So my experience is that it's very good, and it doesn't create so much of stress to the surgeons. Yeah, I support. Nagendra, your view.
Actually, it is very nice and great experience. For the first time, we have done it here in the VRSB, and I don't feel any difference from that we are going live or it is deferred. So it gives the same amount of feeling as a deferred surgery, deferred life surgery. So very good, it can be done. And as Dr. Subhas told, that the surgeon are doing there in the comfortable position. So that way, I think we can do it in a regular basis. Or what happens, I don't know what are the regulations coming by the NMC and the High Court and Supreme Court and all. Thanks.
Our incoming President,
cylinder.
The advantage of this Ingenuity 3D visualization is that if everyone wears 3D glasses, you will be able to appreciate the same depth. That is also one more way of live surgery one can.
Deferred live surgery was really a first time experience for us. We were not knowing the exact rules, what were the rules, current guidelines, and we had a lot of discussion before this deferred live surgery program. And one thing which we came that the surgeon can narrate the steps one by one, and the surgeon must not be distracted, and that is the main motto for this deferred live surgery which NMC has put the guideline. So it is one thing which is very important, and I think it will pave the path for the future in our society also and for other societies also. It is entirely a new experience, and it was marvelous.
Can we have one group photo of all surgeons, moderator, and all who are present here? लंच इज बीइंग सर्व्ड, आप लोग करके, क्योंकि 2 बजे सेशन हम लोग को स्टार्ट कर देना है, इसलिए लंच। सभी लोगों से ये भी आग्रह रहेगा कि समय मिलने पे स्टॉल वगैरह भी एक बार घूम लीजिएगा, क्योंकि दे हैव कंट्रीब्यूटेड अ लॉट, सो थोड़ा उन लोगों को भी लगना चाहिए कि हम लोग
लेके आया आया लैपटॉप पोडियम आया नहीं आया बहुत बड़ा यार हमें बोलिए ना पेंटिंग ठीक है चेक देखिए फुल स्क्रीन आ रहा है ठीक है और यहाँ नहीं ना दिख रहा है वो नहीं है
A very good afternoon to everyone. I'm sure after the hearty lunch and after the total excellent success of the deferred life surgery in the morning, we are ready to move on with our scientific program. For that, this program is Little Troubles, ROP and Trauma. And I would like to welcome Dr. Abhishek Anand, who is the moderator, who will moderate the session and invite the speakers. So over to you, Dr. Abhishek.
So we would like to invite you all for the ROP and the trauma session. So we have 4 talks in this. Dr. Abhishek Kedia was supposed to be moderator. Sir, if sir joins, then he will join us. In the meantime, I would like to call Dr. Sivender Sai sir, Dr. Deepak Agrawal and Dr. Volesh Rai on the podium, please. And so we have 3 talks on pediatric surgery and we have 1 talk on trauma by Dr. Sivender Sai sir. So I would be beginning this session with my talk on pediatric retinal detachments. Do it like a pro. So pediatric retinal detachments can be 3 types. It can be rhegmatogenous, it can be exudative or tractional. Now, how is it important that unlike adult retinal detachments, rhegmatogenous retina, you need to take a very detailed history of prematurity, infection, prior ocular surgery, genetic syndromes, or prior trauma become very important. Nystagmus can be a very important clue regarding the age of the insult itself, like in ROP, PHPV, or FEVR, Nuri's disease, and other disorders. Presence of strabismus may indicate a chronic retinal detachment, and we all must remember that a very important differential diagnosis is retinoblastoma, which should be excluded in whenever we are thinking about a case of pediatric retinal detachment. Another very important thing in pediatric retinal detachment is the bilateral retinal examination. So younger children may not be able to cooperate for a depressed retinal examination in clinic, and thus while we are providing an anesthesia, an EUA of the other eye is very important. Or we can do before planning the surgery itself, you can do an EUA and then go for the surgery. In patients with poor pupillary dilatation or opacified media, ultrasound B scan is very important. Management can be challenging and varies significantly from traditional management in the adult population. RRDs in the pediatric group are relatively uncommon. Etiology can be congenital or acquired. So acquired, we have trauma, myopia, aphakia, and there are some lesser common etiologies. My slides. So one of the very important steps of pediatric retinal detachments is the induction of the PVD. As you can see in this case, despite appearing there is no there is a complete PVD, when we stain it with triamcinolone acetinoid, we can see there is a very thin sheet of cortical vitreous, and this you will find inevitably in almost every case. Now you can mix and match. You can start with using a diamond duster scraper for creating the initial scaffold, and then you can extend it to the periphery by using the ILM forceps or the max grip forceps, and then you can put the PFCL to stabilize the posterior pole, and then you can shift from the ILM forceps to the vitrectomy cutter for peripheral extension. So you can mix and match for using the cortical PVD induction. Now another case, now this case was of a bullous RD. Now if you see at this case, it looks like there is a complete PVD. Now in this case, I had to create a drainage retinotomy, otherwise the retina was not going flat. And then once we have decreased the bullous nature of the RD, then we go for staining for the cortical matter, for the cortical vitreous. And once we have stained it, again the same process, you stain it, create a scaffold of vitreous away around the disc, and then you can extend it to the periphery by using any forceps towards the periphery, and then you stabilize the posterior pole. And this is very important because if this cortical vitreous is left, then in the future it can cause lot of PVR changes and lead to the failure of the eventual failure of the surgery itself. Now, it can come with multiple coexisting pathologies, like this is a case of a traumatic macular hole with a subtotal retinal detachment. The macula is still on. We have a superior RD, and then we have to do in this case an urgent. Urgent surgical. But what we can also see is that there is a almost 180-degree subluxation of the lens, and we after completing the complete vitreous detachment, what we can see here is that this was unique in this case. So we have done the inverted ILM flap in this case, and when we did the indentation and try to remove the peripheral, what we can see is the multiple small breaks all throughout, almost 360-degrey. There was multiple small breaks. You can see here there are multiple small breaks in the periphery, and this is most probably we can attribute might be to the trauma itself. And so it comes in various. So this is the 1 month follow-up in which the macular hole is closed. Now another aspect is the coloboma RDs which we present. Now the most important aspect of a coloboma RD is the induction of PVD itself, and if we try to do the induction of PVD, there is a very tight adherence of the vitreous to the retinal interface, and many a times when we are trying to induce, there is accidental iatrogenic breaks that might be created. And also important is that in coloboma RDs you can't use the PFCL per se to stabilize the posterior pole, because there is a chance of peripheral migration, subretinal migration of the PFCL. So the PVD induction in a retinal detachment in a pediatric population is one of the most important steps that we have to look forward to. We can be syndromic patients, and they can come with varied predisposition. This is a case of aniridia with cataract and a fever-like sort of picture in this. So this is a patient of aniridia, and when we look at there is on the temporal aspect of the patient, there is some sort of fever sort of presentation. We try to open up the folds of the retina, and we also did try to support this part of the retina by using a 240 band, and also a segment of 276 tire was tried to support the retina. This patient also had an aniridia, so another aspect was of the retention of the IOL. So we also put the retention suture per se in this case. This was a one-eyed patient, and we were able to achieve post-surgery 1/60. The patient had an eventual outcome. So in this case, we put oil retention suture. So syndromic patients can be also very common in pediatric population, and we put a cross of suture and try to retain the oil. This is a case of an Axenfeld-Rieger syndrome with GRT. Now in GRT, generally we don't expect with the remnant of a cortical vitreous be present, but this patient, when we GRT, you generally expect that the vitreous would be completely detached, but when we look at this patient, we could see that unlike other GRTs, this patient had a remnant of cortical vitreous. So it becomes very important that even in a pediatric population, if he or she presents with retinal detachments, you go and look for the presence of the cortical vitreous and try to actively manage it, and rather not anticipate that a GRT patient will have a complete PVD. Now, another part is that we not always need to go inside. This is a stage 3B codes which are presented, and patient wanted some amount of anatomic salvage. So we, rather than going in, what we need to do is that we just create a drainage sclerotomy, put a positive infusion pressure, and then we will be able to drain most of the fluid. The only issue with is the extreme manipulation that we get. So sometimes the anterior AC maintainer can cause or go and hit the lens. So what we can do is that we can intermittently create increase IOP. Like in this case, when we tried increase the IOP and we had created a good drainage sclerotomy, there was almost complete flattening of the on the table itself, and we are using a chandelier illumination trying to do peripheral cryo of the stage itself. Now another aspect is the pediatric tracheoretinal detachments, which we'll try to address, and stage 4A and stage 5 ROP. Due to the paucity of the time, I would like to conclude my talk. So pediatric retinal disorders include a wide spectrum of retinal pathologies. Small eyes have their unique set of surgical challenges and require support of pediatric anesthesists and an ICU PSU. Have a holistic approach, meticulous history and bilateral examination is a must. Identify syndromic associations and genetic counseling. Post-op rehabilitation is very important. Amblyopia treatment, strabismus management, and role of community ophthalmologists in early identification of pediatric retinal disease and appropriate guidance and referral is of paramount importance. So together we can save many young eyes. Thank you.
Well presented, Abhishek. Very nice collection of cases, and I think we all need to learn here that all these cases need to be referred immediately to the proper VRS specialist for proper management and timely management. May I have any questions from the
one thing,
panelists?
like, do you advocate, like, since they are pediatric patients and vitreous base dissection may be difficult in them, so all these cases we have to put a encirclage back? Do you do that in all your pediatric retinal detachments?
Regarding hematogenous retinal, retinal detachments, so like if there is a break which is below the 3 and the 6 o'clock, 3 and the 9 o'clock meridian, we can go for support, peripheral support. But if the break is above the 3 and 6 meridian, or even at the 4, or we can go extend it to the 4 o'clock and the 8 o'clock meridian, we can go for a gas tamponade or an oil tamponade without the band buckle also. Depends on the PVR status also. Like in coloboma RDs, I never do a peripheral, encircling band. We can get away with, because the pathology lies most of the times in the intercalated memory, or even most of the times, since the inferior is the colomatous area, the break is lying superiorly or at the beyond the 4 and the 8 o'clock position.
And one more thing, like, you know, that the single surgery success rate, what do you think that is in pediatric retinal detachments? Is it low?
So if there is a case which is buckleable, first of all, PPV is not the first choice. Buckle is the first choice, and almost 80 to 90% of the cases we will be able to achieve anatomical success and integrity with buckling itself. For the failed cases of I'm talking per se about the rhematogenous retinal detachments, we can have the secondary surgery success rate will not match that of the adult success rate, but it's definitely a bit lower in the rear RDs or patients who have to undergo PPV for this.
In syndromic patients, if retina is on, like in FAVR, in those cases, if you see lattices with anomalous VR interface, do you prefer to laser Baraz? Because past experiences are variable. Sometimes just after doing Baraz, traction increases and it causes reg RDs.
So like if you have a case of we have different syndrome. One is the Stickler syndrome, one is the, if you let's say first deal with the FEVR syndrome, I would go for demarcate the area of avascularity, and then I would like to do a PRP with further augmentation around the lattices if it's seen. If you see, I have very less experience regarding the Stickler syndrome per se, but if we find an area, then I would rather go for lasering of the breaks.
Usually the vitreous base is shifted more posterior.
Yes.
Right. So if we keep on trying to extend the PVD, we are going to create more iatrogenic
We should, our extent of PVD should be at, till we find where we will find a plane when we are extending is that there would be very taut adhesions with the retina, and that is the place
where we have to
place we
stop.
Yeah, but then that is more of the experience part we are talking about.
Actually, in stickler, usually it is a paravascular radial kind of lattices. So we usually don't get a single circumferential level of PVD in those cases. So do you prefer to laser on avascular temporal retina in FEVR cases?
No, if first we document it, and generally if you find a small new vascularization or subtle, we can go for a laser. Generally, I try to counsel the patient that there is no harm in getting the patient to laser the avascular retina, because there is a lifelong risk of proliferation and there is a chance of if the patient undergoes a PVD, which will he or she will go in the future, there is a chance of retinal detachment.
In coloboma RD patients, how you approach at the with laser barrage at edge of macula, or any other technique you prefer to do that?
So there are two aspects. One is the patient is already detached and we are doing intra-op, and one is the patient we are doing a prophylactic laser. Which question we are talking about?
If it is detached, in detached coloboma RD, if coloboma is crossing just macula, then what is your approach regarding laser?
So I think the most important point is at the macula what we have to do.
Yes.
Rest we can do what we prefer to do. We can give 1 row, or some persons do 2 row. I think at the edge of the at the edge, if you are seeing that the intercalary membrane break is around there, I might try to just give single way. And if I find that I tend to avoid that small area and let it be that because we don't know where is the break.
Yes.
Where is the seepage?
Thank you, Abhishek.
Thank you.
We will move to our next talk by Dr. Sevinder Sahai sir, and it's iododialysis repair with SFIL, my technique. This side, sir. Yes, sir. Yes.
So in coloboma RD, like as you said, like you don't use PFCL or you don't prefer to use PFCL.
Yes.
So how do you induce PVD? I mean, induction from the disc is possible, but how do you extend PVD to the periphery in those cases?
So I think it's more of the surgical experience we are talking about, right? I'm not very aggressive to extend it to the periphery. Let me be very clear. But I want it to be detached all around the colobomatous area. And there are two aspects. One is at the inferior horns. So at that point, I have found, that is my personal experience, I'm not quoting the literature. If we try to be very aggressive at detaching at the horns of the coloboma, then there are chances of breaks forming at that place is very much. So I generally don't tend to be very aggressive, and then I try to extend it as much as possible. Generally, I am able to achieve not a complete sort of detachment as we achieve in the adult population, but decent amount of detachment. I am not very aggressive that I have completely been able to, and I think it is working well for me till now.
See, what I have experienced, like recently I have started using PFCL in many coloboma RD also.
Okay.
So if the contour of the coloboma is smooth, it's not very irregular, if there is no intercalary membrane, so in such case there is no risk of migration of PFCL to the subretinal space. So if you see before putting the PFCL, you go inside and see whether your soft tip or cutter can reach up to the deepest part of the coloboma. Then in such cases PFCL can be used, so it stabilizes the retina. In such cases, at least over the retina you can extend it to the periphery, and later on you can remove the PFCL. So problem comes once you do fluid air exchange. That time, because of the absence of the contrast in that area, it becomes difficult to identify whether there is residual PFCL or not. So you go to the deepest part of that smooth cavity, and from there usually PFCL comes out. So in such cases at least PFCL can be used.
No, I am not saying that. But what I
can discuss
this we can continue. I think Sevinder sir is waiting for his presentation. Thank you.
Can I close it?
Dignitaries on and off the dais, dear friends, good afternoon. Today I am here to discuss iododialysis repair by a simple and different technique with SFIL implant in same sitting. This is a video-assisted case presentation in which the management of a case of aphakia with cortical matter drop with iridodialysis will be presented. This is a case of complicated cataract surgery in which the surgeon was doing right eye phacosurgery from temporal side, had some complications of PCR, surgeon converted to SICS and managed to deliver the nucleus anyhow, but during the delivery, this huge iridodialysis happened, which you can see in the nasal side. Patient detail, she was a 70-year-old female patient having history of diabetes, hypertension and asthma. She was on inhaler, her IOP was on higher side, corneal clarity was okay, retina was on. The second surgery was taken up at our center after 24 days of the first surgery. Now, 3 surgical steps were planned in a single sitting: iridodialysis repair, pars plana lensectomy and vitrectomy, SFIL with multi-piece foldable IOL. Now, you all know the common techniques for the iridodialysis repair, the routine mechanical technique or double flange technique for iridodialysis repair, which are done by double arm 90 non-absorbable suture having straight needles at the 2 ends. This technique appears simple in video, but actually it is very clumsy and requires a lot of patience and maneuvering in AC. Here the surgeon needs to have a guide needle from one side tucking the iris, which is then fed by the straight needles from the other side, then the 2 straight needles are exercised and other things are done. Now here is a simple technique of iridodialysis repair. Anybody who has done trabeculectomy and PI can do iridodialysis repair with this simple technique. This technique is a simple way of doing iridodialysis repair with non-absorbable 80 or 90 suture with single arm curved needle, which is usually available in our OT. This technique is handy, simple and different from the clumsy mechanical technique. Here you can see the video, you can see the iridodialysis, aphakia and cortical matter drop. Now adequate peritomy is being done. We will do for the 3 things: superficial crab-like flap and then 2 scleral pockets for tucking the SFIOL. Now this is the corresponding measurement to the iridodialysis, and this is how the superficial flap, just like trab, is being made. The iridodialysis was in the nasal side, so this part of repair will be done from the superior aspect. Now this is complete. This is Malenga's ring for marking of the scleral pockets, superior and inferior, since the surgery will be done from the temporal side, the lensectomy, vitrectomy and SFIL. Now this is the first vertical step with lance tip, and with 20 gauge MVR, the horizontal step for the scleral pocket is being done. And then marking is done so that we may not forget, and this is the inferior pocket. Now till this stage we have not entered AC. And now again, this is the first time we are entering the AC from the superior side, the visco infusion. We entered 1.5 millimeter behind the limbus, and this is the first time entering AC with forceps, shake-hand forceps, picking up the peripheral most part of the iridodialysis, and it will be exercised. Yeah. Now loose mattress-like suture with non-absorbable so 80 is given, and it will not be tightened to avoid the entrapment of the EVL tissue in the sclerotomy site. It will be tightened only at the end of the surgery. We will later on see the video. And now the AC entry from the other side, sweeping of the AC with iris repositor, and this is the most important part, pulling back all the iris content back into the AC, and there is no EVL entrapment, and finally tightening of the non-absorbable suture, and this is the tightening of the superficial flap of the trab-like flap. Now you can see a fairly round pupil available, and for the remaining part of the surgery. Now this is the sclerotomy for the externalization of the haptics, and this is same thing will be done from the other side. And you can see the anterior vitrectomy and lensectomy. I have maintained ACM for better stabilization of AC. You can go through the pars plana infusion also. This is the biome. And now we will do the core vitrectomy. Tricot wash, we have induced PVD in this case also, and complete vitrectomy is done. The most important part is anterior base dissection and same time peripheral inspection to rule out any break. Now you can see a fairly round pupil available. Now the esophageal part, the second forceps is waiting for the leading haptic. Now it has been caught and it will be excised. This is excision of the first haptic, and the same way the second haptic will be excised. This is the excision of the second haptic. And you can see the centration, it is well centered, and one by one the tucking of the haptics will be done in the scleral pockets. Same thing from on the other side. And now the trocars will be removed, ACM will be removed, and you can see now peritomy is being closed. You can see a fairly round pupil, stable SFIOL and well formed AC. This was first published in British Journal in 1983 by Stephen et al. Now I have done iridodylis repair of more than 100 cases with this technique with a follow-up more than 20 years. Never encountered any incidence of biodegradation of suture and repeat iridodylisis. No uveitis or vitritis other than a normal initial post-operative period was seen. Most important part of this surgery is all care must be taken to prevent the entrapment of the iris knuckle or the uveal tissue at the site of sclerotomy, and for that internal suture is kept, as you have seen in the video, is kept initially loose and it is tightened only after ensuring that all the iris substance has been pulled back into the AC through microforceps or Sinski hook. Thank you very much.
Thank you, sir. That was a really wonderful video. Like you mentioned that there was no, but when we saw the video, we felt that the iris had come out of the tunnel.
Right.
So that is my question actually, that you're taking out the iris first and then you're pulling it back. You're pulling it back by the forceps or by foot?
Microforceps. Here it was a Rexis microforceps. We pulled the iris back. You can do with the Sinski hook also, and it comes out easily. Once you see that your sclerotome is free of uveal tissue, you just close the superficial flap and tuck it with etovitril. Okay. So the crux is that there is no entrapment of the uveal tissue in the sclerotome, and that can be done. It hangs, in fact. It is the theory is.
So there is an entry site at the part where the iris is coming out. You have made an entry inside.
Yeah.
Okay.
That is how we go. We can.
But there's another, like sewing machine technique is also there.
You can do it, but it depends upon the. When we started our surgery, you see, I started from Van Graff's cataract knife. So there was no. You will not believe, though it is not advisable. We have done this thing with 80 Mersilk also.
Okay.
Which has some biodegradation, but we have seen because there was nothing available there at that time in our OTs. So there was no biodegradation, especially in the children having traumatic eyes. This has done well.
Okay. Thank you, sir.
I would like to have comment from Padmaja ma'am. Like in traumatic pediatric cases, where sometime if patient would be adult, you would like to do pupilloplasty. But in pediatric patient where we need to frequently review with peripheral retina, sometimes pupilloplasty, I feel personally, pupilloplasty hampers further frequent evaluation of peripheral retina in pediatric patients. So what do you think, whether we should do pupilloplasty in pediatric patients, or we should just try to avoid pupil shortening procedure?
See, I think with the advent of this wide field imaging that we are coming with the optos kind of thing, then when these things will become more and more common. Now all the machines have come everywhere, right? So with that, even 3 mm pupil is enough for you to get fairly good quality of imaging up to the periphery. So I think pupil size will not be making anything matter more for us, including the visualization during the surgery. Those were those days when we were doing with landers and off lenses where the view will become hazy after air exchange. Now with biome we see much more than necessary even with a 3 mm pupil. So I think pupil size should not be a problem, and definitely if you can do a good technique with a pupilloplasty, one should do it. Yes.
Thank you, ma'am. May I request Abhishek Anand again to present on ROP surgery dissecting membranes in limited
And the
posterior
earlier case of
polyartery.
Abhishek, especially the peripheral lattices and when they are adherent and all. So sometimes when I go even for a more wider belt buckle, that is 42 band, which gives you around 4 mm, when you are really cannot go beyond the equator, and those kind of things, when I want to support, I go with even 42 encircling band.
Ma'am, the question is that we have been taught in our fellowship days that in cases of pediatric detachments, try to support, even if you are not seeing an inferior pathology,
absolutely.
You try to support it. Ma'am, do you practice still? Or
Yes, absolutely.
So in your practice, ma'am, almost all cases of pediatric detachments have a band, encircling band?
Yeah, 240 minimum.
240 minimum is
Sometimes extra 42.
But you are a buckler, primary buckler for pediatric, no?
95 to 97% of my pediatric cases will only go for buckle. Even if I have to go vitrectomy, I will do first buckle as a first step and then go as a vitrectomy next.
So you explain the patient that it has to be a 2-stage procedure.
Always.
This is a one procedure, but I am doing it in steps, and you might be you might get successful in the first.
Correct.
One. Correct. Thank you. What about subretinal bands, ma'am?
Subretinal
Because
bands?
sometimes pediatrics have chronic detachments and they present with massive subretinal band. Do you, how aggressive you are?
I don't remove through choroid and all those things. So if it is, for example, if it is crossing over the macula or
Only
anything, that also, unless if it is like a long-standing chronic detachment, it is not just that fovea alone is responsible for your vision.
Right, ma'am.
So in these cases, what we are looking at is his field of vision to improve. It's
Right.
not that the 20/20 N6 or that fovea band.
Right.
So that,
Just segment it also, just breaking the band if it is necessary will suffice.
I will go for subretinal gliotic band removal only if there is a retina which has a lot of PVR changes and we have had to go inside, and then you do all this noodle technique and whatever technique and you try to remove all the bands, or you can just segment and remove, but not in a routine case of pediatric detachment where I am going for a buckle. If there are subretinal gliotic bands are there is no need to touch.
Absolutely.
Can I just add one point more? I mean, this is more of a query than a point, that chronic macular edema in retinal detachments is a big illusion. I mean, they can pose you like you have, when I have felt many a times that when we are operating and we find that there is a subretinal fibrosis sort of it, but which is actually a chronic macular edema. I have even tried few times, and I hope I have not tried to go and explore that there is a seat of subretinal fibrosis sitting.
Yeah.
But it's better to leave it. I mean, there is no better, less is more in pediatric cases, that goes without saying.
Same thing holds good for the macular cyst,
Yes.
big cyst.
Yeah, yeah.
And after you do a beautiful buckle and the macular cyst will disappear in a 1 month time.
Yes, yes. So
Please go ahead, Abhishek.
Yeah, so moving from trauma to, so these are few cases of sequelae of ROP, and in which they had some unusual presentations. So these are the video bouquet of those. So AROP develops in about 3.12% of all premature babies. About 22% patients of AROP ultimately develop TRDs despite treatment with anti-VEGFs or without laser, with or without laser photocoagulation. Now they can be of two types. One is the volcano detachments and one is the bleb or the blister sort. TRDs in AROP tend to rapidly present with fibrous tissue extending from the disc
towards the posterior lens surface, progressing to stage 5 disease without traversing the classical courses that includes progression from stage 1 to stage 3. And they are most often psychiatrician. Early seizure surgery before extensive fibrosis associated with better functional and anatomical outcomes. Patients often present late due to limited centers in our part, and extensive fibrosis noted preoperatively in AROP is often associated with residual retinal folds, traction and macular drag, which may again interfere with foveal development. So in the following videos, we will explore various surgical challenges associated with dissecting posterior pole TRDs post-ROP.
Hello everyone, on the outside I would like to thank Team X-Files to give me the golden opportunity to present this. And this I would like to emphasize by a series of 3 cases. And this first case is pretty interesting. It is a case of a persistent fetal vasculature along with a posterior pole TRDs. We begin by bisecting the persistent fetal vasculature membrane, and we are left with a posterior pole TRD. Now, one of the very important components that we have to do is to go and remove that central pucker which is holding the retina together. And for this purpose, the use of Sandial light along with the bimanual dissection becomes very important. In order to distinguish between the retinal tissue and the glial tissue, to pull on the apex of the glial tissue will help you to distinguish the plane of cleavage. Our second case is pretty interesting in the fact that this was a case of a diagnosed case of AROP injected outside and was sent to us in a very advanced stage. Now what we can see in this case is that there is a tenting up of the whole of the retina, and the whole of the retina is tented up, and there are bridges of vitreous fibers which is holding up this tent of retina. Now we begin by releasing all the tensions on which are holding this tent up, and it can be beautiful seeing that how well these vitreous membranes are adhering, and they are acting like a rope to hold this central tent of the retina. Once we have completely removed all the stabilizing ropes on the both sides of this central fold of the retina, we'll attack this central membrane. Now again this becomes very important and precarious in this fact that we are going to remove the central apex glial tissue. It is a point of contention that how much dissection we must do to remove it. The basic argument is that it is very difficult to distinguish between this apical glial tissue and the stretched out retina. So we have to be very tentative and precarious while giving the snips and the cuts to remove the central apical pucker which is holding up the whole of the retinal tissue. Although it is a very unusual manifestation and is not that commonly seen. So as pulling a bit on the central apical tissue will help you to distinguish the plane of tissue where the snip is to be taken and the normal and the stretched out retinal tissue. And here we can see that post-operatively at 1 week how beautifully the whole of retina has fallen back and some amount of anatomical restoration has been achieved. And our third case, this case was a case of an AROP baby injected and lasered outside who was referred in view of central TRD. Unlike diabetic TRD and absent PVD, establishing a plane of dissection is quite difficult in these eyes. After getting a feel of the tough epiretinal gliosis, we begin by using 23 gauge needle to create an opening on the 2 sides of the pucker. We thought that we might be able to create a plane between the pucker and the retinal tissue. However, we could not dissect underneath and rather we had to give a vertical cut in the middle of the pucker. Now, as we all know that giving a vertical blind cut with seizures, with retinal tissue almost averting the tip of the seizures, and intensity of sandlia illumination is least at the posterior pole, which poses another challenge. So this was the most precarious position. Once the bridge was cut open, a slight traction on the gliotic tissue would underscore the next profile point of the snip that we need to give. However, as we can note here that the color and hue of the gliotic and retinal tissue is almost similar. So all the snip grids were quite precarious, almost giving us a vibe of a laparoscopic surgeon in between. The zipper was opened till the optic disc on the nasal side, and the blade of the scissors were also used for blunt dissection whenever required. The temporal half of the glasses was also opened up and dissected in a similar fashion. Overzealous dissection was best avoided, especially on the temporal edge. So limited dissection was done till we could safely establish and dissect the epiretinal gliosis. Once dissection was complete, light cautery was used to prevent any bleeders. We did a fluid air exchange and we put a viscode bubble on the posterior pole. 1 week post-op, the zip-like closure had significantly opened up with a satisfactory result post-operatively. So, to conclude, limited posterior port TRDs of ROP is an unusual presentation. An apical gliotic pucker bridges the central TRD. Safe and limited bimanual dissection with seizures of central gliosis and stretched out retina can be carried out with sandlia illumination. Central gliosis removed can translate into better anatomical and functional outcome. Thank you for watching this video.
Thank you.
Thank you, Dr. Abhishek. And I'd like to welcome our past president, Arvind Jaiswal, sir, to this conference.
Thank you.
So, Abhishek.
I think
Yeah.
Deepak sir, we have another presentation on ROP itself by Ratnesh, so we can discuss simultaneously after Ratnesh presents. In the meantime, ma'am, what is your experience regarding these advanced cases of TRDs in ROPs?
I think the visualization of those membrane and the underneath cortical vitreous is all the game. And then, so I think that unless that gliotic band was cut, I think chandelier and the bimanual is the only way we can get that kind of a depth perception in terms of view.
I have few inputs from others colleagues who have shown the video. So I think case number 1 and 3, 2 is contentious. Should we have dissected that apical tissue? Because one bad cut and the whole of the retina is gone, right? So that is the contentious, whether you should go for such aggressive dissection or should you not go for such an aggressive dissection.
Good afternoon, everyone. So after a wonderful surgical video presentation, my presentation will be on medico-legal implications in bilateral simultaneous vitrectomy for ROP. And the presentation will be basically an interplay between bilateral simultaneous intraocular surgery, surgical management of ROP, and medico-legal consideration. So it is said that medico-legal implications begin when there is end of ethical treatment. And we have seen the number of medico-legal cases, especially in ophthalmology, has increased in recent times, and most of these cases are related to cataract and corneal surgery. Though the number of medical legal litigations related to ROP is less, but the amount of compensation which has been awarded to the patient party is very huge in these cases. In this table, you can see the compensation has been like 1.1 crore, 64 lakhs, 1.2 crore. So why such a huge sum is being awarded to the patient party in cases of ROP? So the reason is ROP can result in bilateral blindness, which is a life-altering disability. It leaves long-term impact affecting the entire life of child, education process, social development, and future earning potential also. So whenever there is negligence is proven in cases like ROP, the court considers the legal principles of restitutio in integrum, where before deciding the amount, it considers various factors including past and future medical expenses, loss of income, pain and suffering of child as well as family member, the need for future care, and also factors like interest and inflation rate. So it is very important for us to be medically aware to protect us against such medical legal litigations. So coming to the bilateral simultaneous surgery. So in this approach, the surgery of both eyes are performed in same surgical session. The advantage of such approach is like it's convenient for the patient as well as family member because it reduces the time commitment and disruptions of daily life. There is faster recovery and patient returns to the normal activities quickly, and it's also cost effective. And hence, with advancement in surgical technique and improved safety protocols, bilateral simultaneous cataract surgeries have become very popular in developed countries. But all these advantages are outweighed by the risk of bilateral endophthalmitis. And in countries like India, where the personal hygiene and awareness level of patient is poor compared to developed countries, these simultaneous procedures are usually avoided. Also, we need to consider the increased risk of anesthesia-related complications due to the prolonged session of surgery. Coming to the ROP. So we all know that ROP is a bilateral, symmetrical and sight-threatening condition, and it becomes very rapidly progressive if left untreated beyond a point. So treatable ROP needs an appropriate intervention in both eyes within a limited time frame. And the role of early vitrectomy in bilateral vascularly active stage 4 ROP is well known. So basically we can adopt between two approaches of vitrectomy. One is sequential vitrectomy, where surgery on the second eye is performed after a couple of weeks, while in bilateral simultaneous vitrectomy, both eye vitrectomy is performed during single anesthetic session. So when we compare these two approaches, the bilateral simultaneous vitrectomy basically carries the risk of bilateral blindness because of bilateral endophthalmitis. But according to a multi-center international study, the estimated risk of having endophthalmitis in both the eye at same time is extremely low. While in sequential vitrectomy, the risk of blindness in second eye is very high because the surgery is being delayed by a couple of weeks. In bilateral simultaneous vitrectomy, the surgical session is prolonged, so there will be apparently more risk of anesthesia-related complications. While in sequential vitrectomy, the child is exposed to the shorter sessions of anesthesia, but at short interval. And the same study says that cumulative time and anesthesia-related risks are greater for infants who are undergoing two separate sessions of anesthesia. So this is that international multi-center study which quoted that the risk of death in an infant due to repeated sessions of anesthesia at shorter interval is much more than the risk of bilateral endophthalmitis due to simultaneous surgery. This bilateral simultaneous surgery approach is feasible and safe treatment in pediatric cases where repeated general anesthesia is undesirable or impractical, and hence the indication for this approach can be safely expanded even beyond ROP. So since it is not an established standard care approach and there is no guideline as such given for such approach, we need to take various steps to defend ourselves against medical legal litigations. So these factors include meticulous documentation, pre-operative workup, intra and post-operative care. So whenever we explain the prognosis and the treatment options to the patient party, we must include the parent as well as legal guardian. The procedure should be clearly explained with the pros and cons of the bilateral simultaneous surgery. The option of sequential vitrectomy should also be given them to consider. The potential risk of bilateral surgery as well as the longer duration anesthesia related risks should be clearly explained. Also, the poor prognosis and uncertainty of outcome should be clearly explained. And all these findings should be clearly mentioned in the consent agreement also, and it should be signed by the parent or legal guardian. Also, important points like stage of disease, treatment options offered, and urgency of treatment should be mentioned in the prescription sheet which we are handing over to the patient. In pre-operative period, a fitness from neonatologist is must. A conjunctival culture and sensitivity can be performed. The antibiotic drop should be instilled in a pre-operative phase, and also 5% povidone iodine drop should be applied 3 minutes prior to the surgery, and this point should be clearly mentioned in the surgical note also. Another important point is to perform indirect ophthalmoscopic examination under anesthesia just before the surgery to determine which eye to be operated first. And this is basically done keeping in mind that sometimes anesthesia related complications can warrant to cut short the duration of surgery, so at least the eye with better prognosis can be saved in such cases. Intraoperatively, once the surgery of first eye is over, the fresh scraping and scrubbing and draping should be done for the second eye. A separate set of surgical instruments should be used. Reuse of surgical instruments should be strictly avoided. So basically the second eye of child should be treated as the eye of a new patient. In post-operative period, child should be shifted to an ICU. Again, a separate set of topical medication should be prescribed for 2 eyes to prevent cross-contamination. So when we compare our safety measures against medico-legal litigations to a defense mechanism of a fort, a good fort will be having a strong moat, guarded entry point, and high walls and inner defense mechanism. So equivalent to this, the meticulous documentation will act like a moat. The pre-operative workup is like guarded entry, and intraoperative and post-operative care is like other defense mechanism. Still, sometimes enemy can breach this defense mechanism and can reach up to you inside the fort. In such cases, there should be a secret escape tunnel to protect yourself, and in our case, it should be a professional indemnity insurance. So we all must have this good professional indemnity insurance. So to conclude, bilateral simultaneous vitrectomy is not an established standard care, but it is a justified and useful approach to prevent bilateral blindness in conditions like ROP where disease can progress very rapidly. After explaining the merits and demerits of bilateral simultaneous surgery, it is the parents who should be taking the final call. We should take care all the necessary precautions with proper and detailed documentation, and also it would be great help for us to mitigate any potential litigations if ophthalmic societies like VRSI or ISROP can come with some guidelines for such bilateral approach. So the same topic was published in the recent issue of AIS Times, and this is the fundus photo. C&D is showing, fundus photo of 4-year-old child who was operated for the, who underwent bilateral simultaneous vitrectomy for stage 4 BROP. And finally, when we primarily put the patient outcome first in an ethical and logical way, the medico-legal implications become secondary. Thank you.
Thank you, Ratnesh. In the paucity of time, we will have one-to-one discussion, and may I request Dr. Subhas Prasad sir to please come on the stage and felicitate our speakers, Ratnesh and Abhishek. Sivinder Sahay sir. Sivinder Sahay sir first.
Can I ask one question to Ratnesh in the meantime? Dr. Ratnesh, those medico-legal the awards that were mainly against the pediatricians.
That is true. Like those cases who have been, the table was showing cases where those cases were like against neonatologist because there was lapse in referral, or one of the cases like against ophthalmologist where he was not.
Abhishek.
I think conjunctival culture and sensitivity, I won't accept that everything is fine, because otherwise we will never be able to do surgery neither in adult or child, because commensals will
that
always
was kind of optional thing. It's not mandatory.
No, if we do it, we will not be able to do surgery
That's
further.
true, yes, ma'am.
Another thing, ma'am, the prognosis of these advanced ROP cases, like 4A, 4B, and 5, it will also depend on whether the disease is progressive or whether it is a late referral, because the stage can be, it can be progressive because of late referral, and another thing, it could be because of a progressive disease. So the outcomes may differ depending on that also.
So actually, as you said, like the prognosis is always poor in such cases. So when court considers the fact, there is a thing called causation, whether the loss of vision was because of the surgery or because of the disease. So most of the cases, it will be difficult to prove that it was because of the surgery we have performed. Only thing we should be worried, it should not be proven as case of endophthalmitis going to be in both eye. So that we have to protect ourselves from.
Thank you, everyone. Thank you, the speakers and the panelists for chairing the sessions and giving very good insights. May I request Shivani Sinha to take over the podium for the next round of presentations. Thank you.
Good afternoon, everyone. May I call the Enlightened Council onto this stage? Dr. Subhash sir, Dr. Salab sir, Dr. Vishal Agrawal sir, and Dr. Abhishek Kedia sir. Abhishek sir. May I call upon Dr. Padmaja ma'am, who has travelled from all over to Hyderabad to here, on tackling complex diabetic tractional detachment.
Dr. Padmaja is well-known vitreoretinal specialist from L.V. Prasad Institute of Hyderabad, and she has travelled all the way from Hyderabad to this conference. So thank you, madam, for coming and gracing this our society annual function. Thank you so much.
Thank entire VRSB Society of Bihar. For me, partner means synonymous with puja, and I'm so happy that I could visit first time today, and thank you Dr. Subhash Prasad ji and the entire VRSB team. And today let us talk about tackling complex diabetic vitrectomy. So when we talk about diabetic vitrectomy indications and non-clearing recurrent vitreous hemorrhage, tractional detachment involving the macula, because many times extramacular detachments can actually progress only 20% over the year, and combined retinal detachment, vitreomacular traction, peripapillary traction, macular hole, and neovascular and ghost cell glaucoma, and also sometimes when you cannot do laser because of media opacities like asteroid hyalosis. So what is the most important crucial aspect in diabetic tractional detachment is finding the plane. So this is something like we go in the forest, and the concept of vitreoscheisis and concept of second layer becomes crucial. So you can see that this is a picture taken by my friend Rajiv Papuru while on this thing. So you can see two ovals are sitting. That is how our first membrane and second membrane will sit. So you see the cortical vitreous, which will be the second membrane, this is the most important layer that we need to look whenever we look at the cleavage to start, not the first membrane. And that is what we learn. And that can be done with nowadays the multifunction instrument like our cutter, or it could be sometimes because of the pointed edge, the cautery also can be helped to find that cleavage, to create a cleavage into that. And then most favorite for me is the dye assisted, that the brilliant blue. So the brilliant blue is for me a favorite tool whenever I want to cleavage that stain that cortical vitreous and go into the membrane. So, and when we look at the membrane pilling, yes, we all know about the techniques like segmentation and or delamination. But all of us, we also know that these things, both membrane pilling, delamination, segmentation or lawnmower tape, they all go hand in hand when we tackle one membrane. So it's like a project mode. So this is a case of a 45-year-old gentleman who came with a significant vascular diabetic tractional detachment, and I usually give anti-VEGF within 7 days I take for surgery. Usually I wait for a week and then only fitness to be given. So this is a unimanual surgery, that is what I have attempted. So here you can see that after giving the anti-VEGF, the vascularity has significantly come down, and I actually initially I tackle with the brilliant blue to get the cleavage from the posterior pole. And whenever I want to do any ILM or anything brilliant blue, before touching the membrane, first I finish the macular work and try to get into the cleavage into the membrane. And this is a fairly thick membrane. So that is where you can actually, once you get the cleavage, the peripheral, that cortical vitreous, when you sheet, you remove from the macula, it is much more easier to get into the actual thing. And most important is these peripheral things. This is where our patients has to be there, where the peripheral, when it is vitreous into the peripheral, that is where one need to be very, very careful. And any thin areas that we found during the dissection, we should immediately cauterize, and then fluid exchange should be done before attempting the air exchange, because you want to remove this thick viscous fluid. And then the laser, I attempt always a continuous laser for the breaks, and then PRP for the other areas. So this is how the fate, for example, the right eye was done laser when he came presentation, and after that you can see after few months it is the right eye also he had a development. This is called natural crunch, and this is what we see many a times in diabetic patients. It's not necessary, we think that we have done, he was under our care, we did laser, but he developed natural crunch. So this is how a bilateral tractional detachment story goes. Now this is a case where you can see this is a detachments where you can see that you are seeing most of the retina clearly, and but the posterior vitreous detachment is completely absent. So here I am using actually bimanual technique, where I am using ILM forceps to hold the membrane because of the hold that is needed, because, and then our max grip, and then you use the cutter as a instrument to both as a scissors and also trying to this thing. And here you can see there is a peripheral, it's like a ring, and this is actually retina which is folded, over which is actually a thin cortical vitreous is there. So that is something one need to identify. Whatever the yellowish thing is not the membrane, but it is a retina that is folded, on which you are having a thin sheet which is actually folding it. So when you are trying to dissect it like a ring, it actually goes like a ring all around the membrane that is there. So that is why it is important to appreciate the tentacles that are seen around that. So you can see that whole tentacles are happening all around. You can see very clearly that all around it is actually that sheet is moving around, and one can actually, I put chandelier, previously I used to put actually at 12 o'clock, nowadays I put at 6 o'clock, and that way you are actually independent of any sister position, and the chandelier does not move, and you will have uniform better view all around. So I always prefer 6 o'clock, or you can this thing. And the clots, yes, some clots you can leave, and in the end you can leave it, but some of the, definitely cauterization should be done whenever you feel there are some points are there. So this is a case where we could reasonably achieve the whatever the membrane that is attachment is done, and then you do the laser. And this is the post-op, and then whenever we want to attempt silicone oil removal, I usually do OCT before and then try to remove oil after some time. So this is a case with a one-eyed lady who came with the tractional detachment. This is again a detachment where you are seeing that it's a fairly not a thick membrane, but you know there are thin tentacles with the PVD absent. So these are little more difficult cases than the membranes where we see thicker, because once you get cleavage you will be able to do that. So one second. So here again I am putting at 6 o'clock chandelier, and what we found is that the fairly adherent membrane, again you can see I put the brilliant blue and I try to remove the posterior pole, whatever the membrane you can appreciate. Here also I am trying to remove the membrane along with the cortical vitreous. That edge of the whatever the thing will be very nicely stained with the brilliant blue. So here again one need to be patient. So all these videos are edited for my talk accordingly for 8 minutes or 1 minute videos or 2 minutes videos, but the surgery will go up to 1.5 hours to 2 hours. So please don't think that we will do surgery so fast. So and here again you can see that one need to be patient in these areas. And the most challenging for me was in this case was the superior temporal quadrant, where the retina was pulled like that. So where I had to spend at least 15 to 20 minutes to get that cleavage into that area, because here the retina and the thin membrane are almost synonymous. So where you have to carefully work on that and then make sure that you actually remove the peripheral this thing. And after that, once you are clear that there is a vitreous, then only you make the drainage retinotomy and then settle the retina. This is almost done. So once you do the thing, sometimes you may not get laser all around, but because sometimes, and then before SOR also you can attempt to do laser sometimes, or during SOR also you can finish laser if you think there is a tendency for the recurrent vitreous hemorrhage, because in the tractional detachment you may not get the thing. Yeah. So again, this is a patient, she started with a good visual acuity, so there is a fairly good visual recovery is there. So I would like to say in nutshell that diabetic DRD and combined retinal detachment are challenging case scenario. It's a teamwork along with OR team, physician, patients and also the patient. Thank you.
Thank you, ma'am, for the wonderful surgical bouquet that you have shown us. Ma'am, there are three things which I would like to ask. Like, is there any importance of hemoglobin? Like, the patients come with CKD and they have a low hemoglobin, sometimes less than 5. So, what is that optimized? Do you optimize these patients to some level, or what is the norm in these patients?
So, there are two scenarios, Shivani. For example, this last patient video that I showed, one-eyed, she was detected to have CML during our workup. So that is also again another challenging scenario that you can appreciate. And what we found is 1/3 of cases when we do this complete blood picture and peripheral blood smear, they can have underlying blood hysterectomy also. So this is a case where we need to make sure that at least, 10 is an ideal, but anything above 8 at least we should aim for, because otherwise you will end up in recurrent that hemorrhage and all. And most important is, especially with the CML and all, the blood clot that happens during the surgery, sometimes it's very difficult to even remove it. Sometimes you may have to leave it, those clots and all. So that is where we need to definitely underline, and that indirectly signifies their nephropathy. So it's important that is done, but sometimes when we go on trying to find the fitness, sometimes we may not get fitness to do surgery as well. So this is that's why, as I said, physician should be coming in play role. So when we advise surgery itself, that from that day, when we are anticipating, from that time only the diabetic profile and the systemic status should be in touch with them.
And ma'am, how early do you remove oil in these cases?
So fortunately in diabetic patients, the emulsification and all we don't see so quite often like how we see in rheumatological retinal detachment. So I usually remove around 4 to 5 months time. When I do the again OCT and then everything, you see that everything is fine, then I will go for oil removal.
Okay.
No. No, I don't use any subretinal TPA, but in these cases, that's what, as I said, many a times when you give Avastin also, sometimes there can be a crunch that can happen during your TRDs and all. So that time also you might find sometimes subretinal hemorrhage and all. So once you have removed the membranes anteriorly, all the subretinal hemorrhage remnants, all those things will settle down within the time. So we need not be worried so much about actual subretinal hemorrhage at some components. So they will get displaced. As long as there is no subretinal hemorrhage sitting underneath the macula, we need not be worried about it.
Thank you, ma'am. Now I invite Dr. Vishal Kishore sir for his talk on diabetic macular edema and his protocol.
Good afternoon, everybody. So coming to my talk on diabetic macular edema, my protocol. Basically, it's macular edema is the most common cause of visual impairment in diabetic patient, and retinopathy is basically a result of abnormal retinal vascular permeability, and it is diagnosed by retinal thickening as appreciated on slit lamp biomicroscopy or on OCT. Angiography shows this breakdown of blood retinal barrier, which is manifested by retinal capillary leakage as seen as macular edema. We know this terminology CSME. This was coined by this ETRDS. We have marked this in our PG ship, but now with so many anti-VEGF in our armatorium and with so many studies supporting the efficacy of these anti-VEGFs, this has become practically too old for our practice. But as a PG, you have to remember this, you have to mark up because the examiner likes this terminology CSME. But for practical purpose in OPD, now we don't use it, because now the macular edema is basically classified on OCT like diffuse spongiform type of edema, cystoid type of edema, then we have serous retinal detachment type of edema, and then we have taut posterior hyaloid membrane type of edema. Now there are various studies in recent times which supports the efficacy and superiority of these anti-VEGFs when compared to previous treatment of laser photocoagulation and other therapies, like Protocol I study, RISE-RIDE study, VISTA study, then Protocol T, Protocol V study, and all these studies supports the shows the superiority of these anti-VEGF. So in 2018, this diabetic macular edema was further classified into only two types. One is the non-center involved macular edema and other is the center involved macular edema. So what is non-center macular edema? It is basically the retinal thickening of the macula where the central subfield zone, that is the 1 millimeter in diameter, is not involved. While in the center involved macular edema, that central subfield zone is involved. So nowadays we classify in this non-center and center macular edema. So with these classification and with these study support, this a stepwise approach was formulated for the treatment of the diabetic macular edema, which is commonly now followed in the OPD. So it's like if you see a patient with diabetic macular edema, you subject the patient to OCT and you just observe the macula. If it's not involved, advise the patient for tight glycemic control and just keep on a regular follow-up. But if you see the macula is involved, then you assess the visual acuity of the patient. If the visual acuity is 20/30, then either you observe the patient, or if you want to treat either with the anti-VEGF for focal laser photocoagulation, then you have to counsel the patient, you have to just explain all the pros and consequences why you are treating at this vision. But if the visual acuity is between 20/30 to 20/40, ideally you should go for anti-VEGF therapy. The choice of anti-VEGF therapy depends on the finances of the patient and the anti-VEGF in your armatorium. But if the visual acuity is 20/50 or worse, then as per the protocol study, you should counsel the patient to first go for aflibercept. But depending on the finances, he can go for other anti-VEGF also, but you have to give a choice of aflibercept. Now, if with any anti-VEGF, if there is failed or suboptimal response, consider switching to a different anti-VEGF in your armatorium, and after 24 weeks of anti-VEGF suboptimal response, either you consider corticosteroid or this laser photocoagulation for the treatment. So now this is a OCT picture of one of patient, elderly patient, 72-year, poor patient with uncontrolled diabetes and hypertension. Now in his right eye at the time of presentation, his vision was 18 and on OCTs where macular edema was there, and with just one shot of bevacizumab and photocoagulation, his vision improved to 6/9. So I haven't documented that picture of right eye, but in left eye at the time of presentation in this August 2022, he had a hard exudate plaque. We can just appreciate the hard exudate plaque. And at the time of presentation, the vision was less than 660. So we advised him intravitreal Ozurdex, but since the finance was a crunch, so he just wanted to have a conservative management. So we advised him strict glycemic control and tablet atorvastatin 20 milligram twice daily. And after counseling, we gave him this one shot of intravitreal bevacizumab. And in later follow-up in February 2023, we subjected him to laser photocoagulation because we are seeing that there's improvement in the edema and the plaque was decreasing in size. Again, the patient presented in August 2023 that this plaque has further decreased in size just with the conservative management. So we are just advising him to control sugar, control hypertension, and continue the same conservative management. Now patient came in August 2023. This time again the patient was happy, but slight deterioration in the vision, and we noticed cataract as the cause. And his subsequent follow-up in March 2024, his vision has deteriorated because of the cataract, so we advised him cataract surgery. He underwent cataract surgery, but he was lost to follow-up for 4 months. So on his next visit in August 2024, we could again see that the hard exudate plaque has increased. So we advised him IVTA, but patient wanted to continue with conservative management. So same glycemic control and atorvastatin was continued, and till date his vision is 636 in left eye and 69 in right eye post cataract surgery. Now this is the second patient who first came to our OPD. He was counseled outside for this anti-VEGF Eccentrix injection. At the time of presentation, vision was 6/9, so we gave him Eccentrix injection, and after 1 month of follow-up, his vision improved to 6/6 part. We could see that slight deterioration, this decrease in the macular edema, and we asked him for strict sugar control and regular follow-up. Again, this patient came in October 2024, and this time the macular edema has increased in size. His vision has deteriorated to 6/24, so we advised him to take aflibercept, and he was ready for it. So after 2 months of injection, his vision improved to again 6/6 part. We could appreciate on the OCT, the macular edema has gone, but this patient again reported in February 2025 with increased macular edema, and this time he wanted a cheaper injection, so we advised him for razumab. But after 2 months of injection, there was not improvement, but even we can see that slight increase in the macular edema, and we could appreciate the cystoid spaces. So this time we advise him Ozurdex injection, and we are waiting for the patient. Thank you.
So the gap between the 2 injections in your patients is pretty large. So
in which patient? First or
no? I mean all the patients, 3 patients that you showed. Don't you give monthly injections to begin with?
The second patient which I had shown, he after just one month only, his vision had improved to 6/6. So I was just advise him just try to glycemic control and observe the patient and regular. Again he came back after I think 3 months.
3 months.
3 months he came back with increase in edema.
No, what I'm saying is that either you give injection monthly or you see monthly. Even if you don't inject monthly, you must see patient monthly. If you give too much of a gap and wait for the patient to develop edema and then come back to you, there is a concept of whenever the edema comes back, that is going to cause some amount of retinal damage. So you must have a dry retina for a longer duration of time. Even if you don't inject, you must see monthly. So patient should not go with this impression that एक injection laga and then he can go off for 3-4 months, 6 months and then come back when his vision is worse. Okay. So every patient must be seen at least monthly. And the other thing is that the other patient you showed who took aflibercept.
The same patient. The second patient, first time he took Eccentrix, second time he took aflibercept, and third time he took razumab.
No.
Same patient. It was the same patient.
No, but every time he's getting a different injection. So
means it was basically first time at the time of presentation vision was 6/9 and he was counseled from outside for Eccentrix. So he took Eccentrix. Second time when he came, his vision had deteriorated to 6/24 part. So we advised him Eylea. Because it is as per the study, if the vision is means at the time of presentation.
Yeah, with Eylea he improved, then you switched over to Ozurdex.
He wanted a cheaper injection, finance issue.
No, but if he
and
improved
that's
with
why we advised
Accentrix,
him intravitreal Ozurdex, and till now patient hasn't returned.
no, if he did do well with Accentrix, you could have gone back to Accentrix, or you could have given any other ranibizumab. Why did you shift to Ozurdex? You said he improved with Accentrix, right? So he is
But
responding to ranibizumab.
After ranibizumab, steroid spaces were developing, so I thought I will just go for Ozurdex. That steroid will have a better effect.
No, but you have got a good response with Accentrix to begin with. So, which means that he was responding to ranibizumab. So why not stick to ranibizumab? If the ranibizumab was not going to work, then one could consider Ozurdex. Isn't it? I mean, in a recalcitrant diabetic macular edema, you would want to switch from an anti-VEGF to a steroid. But since you had a good response with the ranibizumab, I think it was it would have been.
No, there was not a good response. That's why.
I shifted because means after injection of 2 months of injection, there was no response. In fact, the edema was increasing in size, and I could appreciate that cystoid spaces were developing. That's why I advise him that corticosteroid.
With this much gapping or regimen, it will be very difficult one to decide whether the patient is responding to a particular drug or not. So the question of when to switch over will be very difficult to decide. And another thing is that do you have any place for IVTA in your patient, any of your patient? Suppose the patient, because of the financial reason, wanted some cheaper drug. If any patient comes who cannot afford anything, nowadays even bevacizumab, the Indian made company, are very cheap. But even the patient is not able to take that. Do you offer any patient IVTA?
Means one of the first patient I had offered IVTA.
So,
in the first patient.
Did he take the?
No, he didn't take, but I advised him for IVTA.
No,
initially, at the first time when he came to OPD, since he was having cataract, even if you can appreciate that disc was glaucomatous, so I didn't advise him IVTA. But after cataract surgery, first patient, means I had given him the option of IVTA, but he refused IVTA. He just wanted to continue with the conservative management.
His pressure already was high?
Pressure was high on the anti-glaucoma.
And he was on anti-glaucoma medication?
Anti-glaucoma medication.
Then I think you should not offer Tramslone at all. Or maybe just 1 milligram of Tramslone. Okay, thank you. Would you want to say anything, Dr. Padmaja?
I actually, in diabetic patients, I do also tell him that I agree that systemic management sometimes gives very good results. So that's why it is never a wow factor with the anti-VEGF. But when we are giving anti-VEGF on a continuous, I do also agree that the patient should be at least should be there with us 6 months, and should not see OCT for the response. It should be seeing visual acuity, both distance and near visual acuity. So, and then also we should listen to the patient. They also feel it. Not just cysts and spaces in the OCT alone will not give us the response.
Madam, when do you prescribe lipid lowering agent, even if the patient lipid profile is good? But if the patient having lot of heart exudates, or in that situation, do you give your patients?
Definitely, there are a lot of trials that even the lipid lowering, like even if there is no dyslipidemia, the lipid lowering drugs will do a good. It all depends on what kind of internist physician support that you have, because those drugs are not without side effects as well. So we will not be able to prescribe, but definitely if you have a good physician support, yes, they do help. I think multi-prong, we should do diabetic profile and CBP peripheral blood smear as a first baseline investigation, and refer to the physician and work with them together.
The problem is that many of the physicians are not ready to start atorvastatin if the patient does not have dyslipidemia. So, and then it becomes very difficult for us to convince them that we would want you to start atorvastatin because of the exudates.
We have to find the right physician also.
In 2 of my patients, I have seen recently, even though the lipid profiles were normal, I started atorvastatin on my own.
Yes, and that is what we need to do. We
because
need to
they were
start them on our own.
They were from the very rural background. I knew that they were not going to have good follow-up. And I was surprised in 3 to 4 months' time, the lipid heart exudates were decreasing. there was also, I had also given anti-VEGF, so I cannot be completely sure what was the reason, but the exudate clumps had decreased, which was a very good sign.
It does help.
This is a very common problem. Physician doesn't start these things. But in my practice of 30 years, if the physician doesn't give, then I prescribe. At least 10 milligram. This is my principle. Thank you.
So the end-stage renal disease and then anti-VEGF. Again, there are some physicians that are very wary because it's all like some case reports and some literature review. But systematic review and meta-analysis have proven that there is no clear-cut role that end-stage renal disease you will have anti-VEGF causes depression. But at the same time, we should also be wary whether we are giving just you see a small recurrent hemorrhage and then you give anti-VEGF. We should not be also giving in those patients when they are going for repeated dialysis and all. So we don't have clear-cut prospective studies, but it's more of a systematic meta-analysis studies proven that it has not. We can give them. We prescribe, but some physicians they will write also say that please be wary. We don't give anti-VEGF because some nephrologists are very afraid of. No, I think for all the cases, the first line of thing should be anti-VEGF. Anti-VEGF will not give you a good dramatic response like steroid in the OCT wow factor, but the visual acuity in the long run, if the patient is with you for at least 6 months, will be definitely a better picture.
Thank you, ma'am, for the inputs. Next, I would like to invite Dr. Deepak Agarwal sir for his talk on aflibercept and diabetic macular edema.
Good afternoon, everyone, and this is a sponsored talk by Bayer. So I'm going to talk on aflibercept in diabetic macular edema. I have no financial disclosures. So as we know, it is expected that the global burden of diabetes will continue to rise, and in Southeast Asia, we are expecting that it's going to increase by 74% by 2045. And since diabetes burden is going to increase, and so will be the complications of diabetes. And in a survey in the US, it was found that the most feared complication which they had was vision loss. And therefore, we need to address this particular diabetes-related complication. So effective treatment options provide the opportunity to improve independence, productivity, and ability to perform daily functions. And it was found that a one-line vision gain will help patients to read a newspaper and drive at night. A two-line gain will help them to perform near vision tasks, and a three-line gain will improve the color perception. So, as we were talking about the regimens, like Sir said, that one dose may not be enough. There are several regimens which are available, like one loading dose with PRN, 3 loading dose with PRN, a fixed dosing of monthly injections, 5 loading dose plus bi-monthly dosing, and a loading dose along with a treat and extend. And it is found that, yes, that a loading dose along with the treat and extend would be a better option if we consider regarding the visual rehabilitation and disease regression. So when we come to diabetes, we know that diabetic retinopathy, the 2 important mediators are the VEGF and placental growth factor. And we know that the VEGF will bind to VEGF1 receptor and VEGF2 receptor, and placental growth factor will bind to the VEGF1 receptor. So it is important to note that even if we block the VEGF, the placental growth factor will be available to bind to the VEGF1 receptor, and it will lead to the pathogenesis of diabetic retinopathy. So this is another slide which is showing us that both the mediators are important to tackle if we want to actually control the pathogenesis of diabetic macular edema. So you can see here that the VEGF-A acts on the VEGF1 and VEGF2 receptor, the placental growth factor will act on the VEGF1 receptor, and there's also a dimer molecule which can be present. That is the heterodimer of a VEGF-A and placental growth factor. So guidelines recommend that anti-VEGF is the first line to treat center involving diabetic macular edema from so many studies which have been published. Again, for aflibercept, we have the VIVID and the VISTA trial. The VISTA was done in the US and the VIVID was done in the UK. And the important thing to note here is that it shows that in both the trials, if we start the treatment early, the number of letter gain will be much more and it would be more sustained. As you can see here, as soon as we have given the treatment here, the steep rise in the number of letters which can be seen here is sustained over 1 year time. And the dosing also, as you can see here, that it is almost comparable. If you give aflibercept for every month, the number of injections needed were 12, and if it was given every 2 months, it was 8.7. That means almost 9 injections, and that was sufficient to maintain that plus 10 letter gain. And this was also seen in the protocol T trial in the DRCR net, where aflibercept showed superior visual gains compared to ranibizumab and bevacizumab. So this is one of my patients very recently. He had presented with a vision of 6/60 in one eye, and you can see there was subretinal fluid, and he received aflibercept, and this is the OCT after 1 week, and the vision had improved to 6/9, and you can see that the subretinal fluid had decreased. So this is what it was showing, that if you if you give it earlier, the treatment, the response would be much better also. So this is another patient here who had bilateral center involving diabetic macular edema, and this patient received 1 injection of aflibercept, and after that she disappeared and she came only after 2 months. And this was the OCT I have taken just on the 31st of July, that is 2 days back, and you can see the fovea is absolutely normal, and this patient had actually with just 1 injection had improved to 6/6. So the durability of the molecule is also very good. So another arm of the VISTA trial was the endurance trial, which showed the efficacy of the drug even after 5 years, and that the number of injections needed to maintain the visual gain was only 3 injections between the 4th and the 5th year. So again, the protocol T showed superior visual gains with aflibercept with a 18-letter visual gain. So the international recommendations and guidelines recommend that aflibercept should be the first line choice of drug if the visual acuity is less than 20/40. That means it is less than 6/18. So aflibercept is the drug of choice if it is less than 6/18, and superiority of aflibercept was noted in a group of participants with worse baseline activity, baseline visual acuity. So regarding the complications also, the rate of IOI was very less, 1 in 10,000 doses, and the endophthalmitis was also just 0.6 in 10,000 cases. So the safety and efficacy of Eylea is also is very good worldwide. So now we have the clinical trials, the VIVID and the VISTA and the DRCR net, but we have to actually see the real world experience, and studies like the Apollon, which is a real world study done in France, also showed that there was a 6.5 letter gain in the real world study, and only 52% of these patients receive 5 monthly loading doses. In the Moorfield real world study also, there was a 6.9 letter gain. So the Draco study done in England also showed that if the baseline visual acuity is less, the visual gain was more, which means that if the vision is less, we must give aflibercept, which will improve the vision, and it will sustain the vision. So again, the international guidelines say that if the visual acuity is less than 6/18, we must give aflibercept. And a Cochrane meta-analysis also showed that the efficacy of aflibercept is much more compared to ranibizumab and bevacizumab. So to summarize, aflibercept can achieve clinically meaningful vision gains and maintain it. Early intensive treatment followed by treat and extend regimen will reduce the treatment burden. And aflibercept is the only bispecific VEGF which will bind to VEGF and placental growth factor. And early intensive treatment will maximize the vision gains in the first year. So thank you very much for your patient hearing.
So I think although the aflibercept is probably a superior drug and the drying effect lasts for a longer time, the cost is the only problem I think for us.
Definitely,
in our
sir.
patients.
But if you look at the cumulative costs, I believe now with the company also giving us the schemes and if you look at the interval, I feel in the long run it actually turns out to be cheaper because after the loading dose we can actually extend our duration. And we have also seen that it need not be monthly also. A patient does well for 1.5 to 2 months in some cases, definitely. And after the loading dose, actually we can wait for 2 months before we repeat the injection.
Yes, I mean if you calculate for a 1 year duration, you would say that the cost is similar to a ranibizumab or a bevacizumab, but giving that 50,000 rupees
in one
upfront is not possible for everyone.
Yes.
So I think that is the only issue for our patients, at least in Bihar. Not everybody can afford it.
For that, I think you have the option, Salab sir. You give your patients.
That is a different story.
Will 8 milligram, once it becomes available, make any difference in the overall
Yeah,
scenario?
definitely. What we are reading now also that I think they're going to withdraw the 2 milligram in future, and now only the 8 milligram will be available. And because of this, because the molecule, the molar concentration of the drug will be more, so the duration of action of the molecule will also increase. So the cost effectiveness will definitely also improve with the 8 milligram dosing, which is available outside. And I think next year they are planning to bring it here in India.
So this 8 milligram is going to come by Aglia HD. So thank you Deepak sir for your talk. And again I invite Dr. Padmaja ma'am for her talk on wide angle octa in diabetic retinopathy.
So OCT angiography is a dye-less visualization of both retinal and choroidal vascularization. Today we will look into how it can help in diabetic retinopathy. So the advantage of OCT angio is, unlike fluorescein angiography, is where we can segment retinal structures. I think superficial, deep and outer retina and choriocapillaries, like that segmentation is only possible with OCT angiography. And that is what actually differentiate from what we can observe the information from the fundus fluorescein angiogram, apart from being non-invasive and dye-less visualization. So let us look at how it can act as a guide in the diagnosis, and also how we can help us in differentiation of new vessels or collaterals in optic disc vessels, and how it can help us in especially in prognosticating what type of proliferative diabetic retinopathy we are dealing with, and also an importance of targeted therapy, and also an excellent follow-up tool. So let us look at, we have done a study where we prospectively imaged all cases of diabetic retinopathy with wide angle OCTA, and what we found is that 1/3 of what we have diagnosed as a moderate NPDR on fundus photography imaging grading 1/3 of them we turned out to be having new vessels on wide angle octa. So it can actually pick up the new vessels which you can miss on on a color fundus photograph. So 1/3 of the patients will. So nowadays if you see a patient, for me anything above moderate NPDR or severe NPDR where I expect some sclerosed vessel or anything where I am thinking that there could be an underlying PDR, so I go for wide angle octa as a immediate investigation. And similarly, if you see a small sign of some preretinal hemorrhage and you suspect that there could be an NVU, what happens with the wide angle octa is not only it will tell you where is the, because it is there is no dye, there is no leakage, it gives you a very clear cut how much capillary non-perfusion is there, and also the NVE can be also seen very clearly. And in a case of asteroid hyalosis, the gold standard has been always for us doing a fundus fluorescein angiogram, mainly to know the underlying grade of diabetic retinopathy. But if you can pick up wide angle octa and you can pick up a new vessel underlying the asteroid hyalosis, you know that you are actually dealing with proliferative diabetic retinopathy. And then what is important fascination is what type of new vessels you see actually in the fundus photograph. So the Chen et al, actually Pan et al, they have actually found that there are 3 types of new vessels that you can find while using wide angle OCT angiography. The type 1 is something like a tree-like neovascularization. Type 2 is something like an octopus which actually go towards the capillary non-perfusion area. And type 3 is a C-fan type of neovascularization which is actually arises from the IRMA. So when we look at as a diagnostic tool, for example, in this case, fellow eye is very clear cut. It is a proliferative diabetic retinopathy. In the normal eye, whatever we are suspecting when there is a new vessel, with an octa you can not only clearly know that there is a new vessel here, but also you can quantify the CNP area. So you can diagnose PDR very confidently with the octa. Now look at this fundus picture. So when we look at this fundus picture on a casual glance, you might think that it is a probably severe neovascularization, severe NPDR. Just imagine the amount of new vessels that you are looking at here. So this is the same picture if you see carefully, and when you go carefully you look at, yeah, there is some fibrosis there, maybe some new vessel is there. But you will never think that this is the kind of neovascularization that we are dealing in this case of fundus picture. So you will know what amount of neovascularization and also amount of CNP area. Similarly, this is a case. Again, it might think that, okay, it looks like severe NPDR. Yeah, here it looks like NVE and maybe few new vessels are there. This is what the impression we will get, and we will go for preoperative photocoagulation. But when I see this patient, when I see the kind of neovascularization, I was amazed, and I was again going back to the fundus picture and see how much is the extent of the new vessels. So what it helps is, whenever new vessels are seen wide angle octa, when we image like this, we also look at the flow signal. So if they are bright signal, bright white flow, means they are more active neovascularization, and this will help us to know how it will act as a follow-up tool. And this is a patient again with optos imaged, and I did a wide angle octa. My friend imaged with the ultra wide field fundus fluorescein angiography. I just want to show you that wide angle octa was able to detect all the NVE that are required, and what additional we got in the ultra angiogram is only by showing the leakage. So this case is mainly to show that by just having an octa you can actually image all or quantify your PDR severity. And then there is also an interesting concept when there is a neovascularization and when there are hard exudates like this. If you do an angiogram, you will only find diffuse leakage. But there is a concept called foveal neovascularization. Sometimes you do see this foveal area, you may not be able to appreciate because of exudate, but when you do octa, you can have foveal neovascularization. And this is what it signifies is, these patients usually have nephropathy where there is a both retinal as well as choroidal circulation which is actually defective, and these patients we need to be careful in terms of the prognosis, and sometimes you may have to combine with anti-VEGF and steroids also. And then another interesting aspect is the collateral versus neovascularization. This actually many a times we can get dilemma, especially in a patients with diabetic papillopathy or where there are a lot of telangiectatic vessels, and FFA may show some leakage also. So you will be doubtful whether are you dealing with new vessels or maybe a telangiectatic vessel. What is important is that you have in angiography of the disc, when you do octa, you can again differentiate between nerve head, vitreous and RPC complex. So this kind of differentiation, if there are collaterals, they will be like loop-like vessels and they will be within the disc substance, and that indicates very clearly that what you are dealing with is actually collaterals but not the NVD. If it is NVD, it will go nicely, it goes beyond the ILM breach and they will be seen more clearly in the vitreous phase. So again, collateral versus NVD differentiation is more objectively possible with octa. And then if you don't have wide angle octa, even by just looking at the foveal avascular zone in terms of the dropout, one can quantify are you dealing with a mild or moderate, severe or a proliferative diabetic retinopathy, because the more severe the stage of retinopathy, FAZ loss, and not only that, qualitatively you can see the capillary non-perfusions also. So you can see the amount of capillary dropouts that can be seen in the peripheral to the FAZ as the severity of retinopathy progresses. And for example, in this patient again you can see this is a vitreous hemorrhage, there is no problem. If you see here, it is more like a featureless retina, and when you do octa, the amount of CNP will give you an example. Okay, this is the patient where I have to do much more significant PRP, and not only that, may need also to closely follow up this patient. And this is again a tool where it can help in prognostication. So where you can see the new vessels are there and you have given anti-VEGF, and you can actually see that this is again a patient with a NVD, and you can see in angiogram, you can see the amount of ischemia, but octa can actually tell us without even doing an angiogram, you can quantify the ischemia very, very clearly. And this is again a targeted therapy again possible. A patient came with a laser done already, and where I have to do again PRP. So this is where you can actually observe if the new vessels are actually actively they are regressing, they show something called pruning. The vessels will become thinner, the flow will become smaller, and you can actually see the CNP and target those areas rather than again doing laser all around or just doing few laser burns. Then this is a patient, you can see the NVD, you can see so clearly in octa, and after you give an anti-VEGF injection, you can actually see the disappearance of NVD. So quantitatively you will be able to appreciate. Now let us look at a few examples of follow-up tool. So this is a patient post underwent laser, and you can see here the same patient which I am telling where you have the new vessel. And you can see that the new vessel, the initially pre-op, it was so significant vessels were there. In the post-op, you can actually see that you can actually see that the vessel density will become reduced. This is what I meant as a pruning effect. So this is again a patient where you have given new vessels and before panretinal photocoagulation. And after panretinal photocoagulation, you can observe that there will be decrease in the density of the vessels, and also decrease in the density of the vessels. You have to appreciate, here is the bright signal and here vessel disappeared. Here again the bright signal, and here you can see that the vessels are disappeared. So this is something you can quantification only possible with the octa. It will never be possible with an angiogram. So similarly, if you see here a new vessel was there, it was disappeared. So I think with advent of usage and everything, these techniques will tomorrow machines will give the quantification. They themselves can give you the indication about it. So this is again another case where you can see as a follow-up tool, it will be very helpful. And after PRP laser, you can see that this is the pre and this is the post. And the vessels will become thinner. You can see that there is a increase in the space between the vessels. So the pre and post one will be able to appreciate. So here it is like a mesh like work with a bright signal, whereas here you can see like a thin caliber. So, and very important that sometimes the vessels can increase in the size also after laser. So you can see that the new vessel has increased, and everything. So based on that, and then there could be an appearance of new NV, then you can actually appreciate to need for the more laser as well. So this is the last slide which we published just in this month. We discussed about type 1, type 2, type 3. What we found in 1 year follow-up is that the type 3, even though there was a lot of ischemia and everything was there, they actually probably maybe based on the octa we given more targeted therapy, I cannot guess because it is a retrospective study. But what we found is that they required actually least number of additional interventions. So I think based on the type of neovascular degeneration we found on the octa and the amount of CNP areas, we can give more targeted therapy and we can expect a more optimal response for our patients. Okay, thank you.
Very well presented, ma'am. Ma'am, I have two questions. Yeah, ma'am. I have two questions. So, like the classical teaching is that any patient of diabetes coming to you, you should have a baseline fundus fluorescein angiogram. So, do you think with the availability of wide angle octa, can we replace this traditional
Absolutely.
angiogram?
I have not done probably last 4 years. I have not done maybe 1 or 2 cases of severe osteoid hyalosis where I could not get idea. But even in the moderate osteoid hyalosis, we will try always first wide angle octa if I cannot get the picture. So there are some learning curve. So your operator also will become more and more, our optometrists have become more and more confident of things. So there is a learning curve for the taking thing, but it's still, it will not take more than 15 minutes or 20 minutes to get a picture. So in terms, sometimes you may not get the montage if the patient is moving or anything like that, but you will get quantification of each individual image. That is also enough for us to understand what we are dealing with.
And do you advocate this for mild, moderate or severe NPDR cases as well?
So anything moderate and above where we want to accurately classify. So this 1 year follow-up study, we found that almost 30% of moderate NPDR, which we classified on fundus photograph, turned out to be having underlying NVE on wide angle octa. And this is very common, especially when you deal with young diabetics and everything. It looks like almost like a featureless retina. So you, with wide angle octa, you will actually can know nicely the extent of capillary non-perfusion also. And it is not only in diabetic retinopathy, even in case of NVG cases, I found it extremely useful because our glaucoma colleague will tell, do PRP. And we think that where we will do PRP, because it will look like few hemorrhages like ocular ischemic syndrome. In wide angle octa, you can see how much ischemia is there and you target it.
And the next question is, like, do you still see the role of focal lasers and doing FFA for that?
So FFA is not really, you see, when we do focal laser, so the clinical examination is the cue. So because we have come, Pooja and me, we came from the area of lasers only. So, and the important is that we see with the ultimately 78D biomicroscopy and do all the leaking microorganisms in the area of retinal thickening, ideally observe and do it. For that, I don't think you require really angiogram to identify and leakage and everything. So I think areas of thickening, wherever you have microorganisms which are contributing, you do the laser. So for that, we don't require angiogram.
More like a grid PHC rather than focal.
Excellent presentation, Dr. Padmaja. We were actually discussing, Dr. Padmaja was saying that after my presentation, you will know what I mean by the wow effect in octa and why you should invest in it. Just had one question, like you said about the pruning effect after PRP. So how do we educate ourselves that this patient doesn't require more laser? Because those new vessels, do they get pruned or they totally disappear? What happens?
So,
what is the end point?
So this is something following regression pattern. Only with prospective studies I can confidently say this is what happening. And these are all observations of last 2-3 years, because first of all, when I saw those new vessels like the tree type of new vessel, it is a shock for me, because we are seeing PDR fundus for last 20 years or something. But I never thought under PDR this many types of new vessels were there. And I have never prognosticated my patient based on the type of new vessels I am seeing. So now only we are getting that insight that okay, I am having C-fan type of neovascular digestion, I am having octopus, I am having lot of tree type. So I think the bright signal when it is coming down, when we know that the patient is doing well, and other clinical signs anyway we have fundus picture. So, but I think it is still a little more time it will take to understand that, okay, unless we quantify the pruning and everything. These are only qualitative signs that yes, your new vessel is disappearing. But there are new vessels which disappear also on the fundus picture, because you have to observe, because there is no overlay is not available. We have to really carefully see this pre and post side ourselves and try to appreciate in a different frames.
So ma'am, which machine are you using for this?
Zeiss Plexelite.
Okay. I have recently bought an Octa, not the wide angle one. What I find is that even getting a small 3mm to 3mm size Octa is so difficult for the patient to focus and keep focusing. How do you manage to get such a large area? I mean, it has to be a lot of patient has to really keep his eye open. And
no,
how long does one shot take?
So, because in my OPD at least they get around 15 wide angle Octa I will send for them. So they know that Dr. Padmaja that day is there, that means we get lot of it. So at least it will not take not more than 10 minutes for getting these images. Sometimes, yes,
these
there are
images
few patients,
yes.
they take, this is 12 into 12 mm, 15 into 15 mm, they do like a picture and then in the end they put the montage option and it will all come. So if the patient doesn't cooperate, sometimes you may not get the montage, but you get those individual frames.
Ma'am, it's very difficult to ask the patients to focus in that area. Like, so the images definitely come, we ask the patient, but still there are a lot of artifacts.
Yeah, artifacts will be there. For example, whatever pictures I show also, there are artifacts. But it's like a qualitative information that your brain will sense. For me, it doesn't matter as long as I pick up NVE in a moderate NPDR and also CNP area. So even few artifacts here and there is not going to change my decision making or my what I am going to do with that patient.
Ma'am, is it Plex Elite or OCT 6000 angio?
This is Plex Elite.
Plex Elite, they have kept it only for research purposes, probably only at few of the institutes all over India. It's not available commercially.
Not sure about that, but I can find out. Yeah, but recently I saw Dr. Sangeet Mutel also had some other type of wide angle Octa.
That's Chinese one, ma'am.
Chinese one, yeah. That is also giving beautiful pictures.
Thank you, ma'am. You truly inspired us to have a wide angle Octa.
Yes. Spend 1.5 crores or 1.7 crores.
Sir, that is a government institute. We can still. I think when everyone buys the machines, the rate will come down. When everyone buys. Now I would like to call upon Dr. Arvind Jaiswal, sir, to felicitate our speakers. Sir, please.
Padmaja ma'am, please. Ma'am, please come on the dais to receive the token of respect. Dr. Vishal. Dr. Vishal. Dr. Deepak.
Now I would like to call upon Dr. Vishal sir to take over the next session.
So for the next session, I would like to invite our enlightened counsel, Soni Sinha ma'am. Dr. Soni Sinha ma'am. Abhishek. Dr. Volesh, and Dr. Rajesh Agarwal. And I would like to invite our first speaker, Dr. Shivani Sinha. Her talk is on ocular TV. We are already running half an hour late.
So, good afternoon, everyone. At the outset, I would like to thank VRSB for giving me a chance. So, I'll be speaking, having a brief on ocular TB. So, this is a case of 22-year-old male who presented to the OPD with diminution of vision for the last 15 days. And as we can see, in the inferotemporal quadrant, a subretinal abscess and the hemorrhages on the top of it. And the left eye had multiple tubercles over here. So this is the OCT running through the particular lesion, and we can see the choroidal elevation in the patient. So the patient had just was just MON2 positive of 25 mm, and all other worker was negative in this patient. We had started ATT in this patient on the suspicion of ocular TB. And this is the photograph of the right eye after 2 months of ATT. Steroid was also started in this patient after initiation of ATT after 48 hours. So next, we had a 22-year-old young male presenting with recurrent anterior scleritis. He presented to us after he had already been started on NSAIDs and shifted to steroids. He complained of 1 to 2 episodes per year, and again, his MON2 was in the range of 20s. All other investigation for connective tissue disorder was negative. And in this patient, we had just started ATT 3 days back. This is a patient of HIV who had disseminated TB and also had neurosyphilis in this patient. So this patient was sent to us for evaluation of this lesion in the at the posterior pole, and this was again a choroidal tuberculoma. This is a case of multifocal choroiditis in again a young patient in whom the MON2 was positive with a MON2 of 21 mm, and this was a healed multifocal choroiditis. We had already started and stopped the ATT in this patient. So ocular TB is not as infrequent as thought. It is approximately 30% in our part of the country. It can present with posterior uveitis, anterior uveitis, panuveitis, or intermediate uveitis. So in anterior uveitis, one of the most characteristic feature is the broad-based posterior synechia. So this is the copies and the basacas, and broad-based posterior synechias are one of the most sensitive specific markers for ocular TB, anterior uveitis and ocular TB. So in intermediate uveitis, they usually present with large snowballs with no snow banking. So in posterior and pan uveitis, the presentation can range from choroidal tubercles to tuberculomas to abscess, and serpiginous like choroiditis and multifocal choroiditis. So the choroidal tubercles, they are mostly found in the posterior pole, and they are grayish, white to yellowish lesions, and it can also be associated with overlying serous RDs. So they can also increase in size to form tuberculomas. So they are usually large solitary mass, the tuberculomas, and they have a yellowish subretinal mass with surrounding exudative RD, and they can mimic mets, nocardias, or melanomas. So we need to have a specific DDs when we are seeing tuberculomas. So subretinal abscess can present with mild vitritis, and they are yellowish with very important sign with overlying retinal hemorrhages. So SLCs, the SLC is a chronic recurrent inflammation. It is basically autoimmune in nature, so corticosteroids has to be started in these patients, but ATT has to be given because they tend to recur. So there is a confusion between serpiginous and serpiginous-like choroiditis. So serpiginous choroiditis is usually autoimmune in nature, and it is usually bilateral. They begin in juxtapapillary areas, while SLCs, they begin at the posterior pole. And it is usually multifocal. The SLCs are multifocal, but serpiginous are not multifocal. They ascend in the form of serpentinous. So one of the common presentation which we deal with in our OPDs is the retinal vasculitis. So it can either present with or without associated focal chorioretinal lesions, or other features of ocular TB like intermediate uveitis, multifocal SLCs, or neuroretinitis. So we have to be sure that we have to rule out EELS, which is usually which we usually exclude when everything is negative, and EELS is usually in a young male with recurrent vitreous hemorrhage. Ocular TB can also present with neuroretinitis and optic neuropathy, and we have to start empirical ATT if we are suspecting. So one of the important features of ATT is ethambutol related toxicity, or sometimes linezolid also results in optic toxicity, so we have to monitor this by doing color vision and contrast sensitivity. And when we start suspecting ATT related optic nerve toxicity, we have to write to the pulmonologist to stop those drugs and start on alternative drugs. So scleritis, as discussed, it is usually anterior scleritis is more common in them. It can rarely present as endophthalmitis and panophthalmitis. So we have various diagnostic tools which can compromise a specific ocular imaging like fundus autofluorescence, OCT, ultrasound, FFA and ICG, and other corroborative tests including MON2, interferon gamma release assay test, HRCT, gene expert, and biopsy. So basically it's a paucibacillary infection, so so it is difficult to document. So FAF is basically non-invasive method, and it indicates RPE health and can be used to monitor whether it is active or inactive choroiditis. So in OCT we can, like in the EDI OCTs, we can see the elevations on OCT. Ultrasound, when we have to differentiate it from malignant melanoma and other mets, we need to have a ultrasound running through that particular lesion. In FFA, we have various characteristics of choroidal tubercles where we get early hypo with late hyper, and in inactive healed tubercles, we can get transmission defect showing early hyperfluorescence. So we have very particular characteristics in every ocular TB manifestations. So in ICGA, it can be used to diagnose subclinical choroidal lesions in cases of presumptive ocular TB. So basically tubercular granuloma is usually single large, and surface vascularity is more compared to the, and the outer retinal involvement is more when compared to the multiple discrete and less of surface vessels as in sarcoid. So we have got a paradoxical worsening which sometimes happen when we start the patient on ATT. So MON2 is very important, and we have to see whether it is done with the amount of dosing. So we have to be aware that in severe TB, inadequate doses of PPD and immunocompromised test, it can be a false negative. So IGRA usually known as quantiferon gold is also done, and it is not affected by the BCG vaccination status. Chest X-ray can also tell us about the status of the pulmonary TB. HRCT chest is also done to evaluate the status of the active pulmonary TB. So gene expert is basically a CB-NAT, is also known as CB-NAT. It identifies the RNA polymerase beta gene, and so this can also be used. PCR can be done on the aqueous or the vitreous, or from the biopsy taken from the lesions, but it is rarely used because it's very difficult to have the sample and get it tested for PCR. So to manage, we have the HRZD regimen, where we can start, where we do not start, we just write that we are suspecting or this is a presumed ocular TB to the pulmonologist, and request the pulmonologist to start on ATT rather than us starting the ATT. So we need to start steroid after 48 to 72 hours to come over the inflammation part also. So one important thing is the cost calculator which we have, and it's a very simple calculator available online in which we have the patient details and also the clinical phenotypes. They have written anterior uveitis, intermediate, and also they have in choroiditis they have written some multifocal. So everything is categorized, and in this endemicity of the patient, it has to be specified. The patient is coming from endemic or non-endemic. Tuberculin skin test is positive or not, IGRA is positive or not, or chest X-ray is suggestive of pulmonary TB or not. So according to that, they have a median score and the interquartile range, and then they give us whether there is a consensus regarding starting of initiation of ADT or not. So this is a very simple cost calculator which can be used when we are sitting in our OPDs also. Thank you.
Thank you, Dr. Srivani. So I'd like to invite Dr. Vida, because of the paucity of the time, so we'll have the discussion at the end. I'd like to invite Dr. Vidata for his talk on approach to a case of retinitis with vasculitis.
So whenever you, good evening everyone, actually I was in a bit of hurry. So whenever you get a case of any retinal inflammation, the first thing you need to differentiate is whether it is a choroiditis or a retinitis, because it changes the perspective how you are going to proceed further in the case. Like if it is a choroiditis, you are going to move more towards the immune mediated lesion, and if it's a retinitis, you are more inclined towards a infective etiology you are dealing with. So today I will be discussing a case, very interesting case of retinitis and vasculitis. So she was a 40-year-old lady. She had a painful diminution of vision since last 3 days, and BCVA in the right eye was 618 and the left eye was 1 finger count. On examination, the right eye had corneal scar. Right eye had corneal scar, arrow. So you can see there is a corneal scar here and there is a corneal opacity. On retroillumination, you can see some of the ghost vessels very clearly. And further, when we looked at the fundus, in the right eye there was a CRA patch superiorly, and the other eye showed vasculitis, lot of hemorrhage around the vasculitis area, suggestive of occlusive vasculitis. Inferiorly also there was a patch of retinitis here. The retinitis actually looks like cotton loose spots, and there is a hemorrhage, and beyond that there is a vasculitis here. So moving further, we did a FFA in this case. These are the closer pictures of the vasculitis and the hemorrhages in all the quadrants, the superior and the inferior one. So the OCT showed a cystoid macular edema which was passing through the macula. If you look at the lesion, the scan passing through the lesion, there is a full thickness retinitis. The choroidal involvement has not yet set in, so it is basically more of a retinochoroiditis, or rather you can just say retinitis. The FFA was done, showed a lot of hypofluorescence, like block fluorescence in superior inferior quadrant, and there was a leak at the inferior half near the arcades. Disc was hot in this case, so we were dealing with a probably inflammatory lesion. So based on the investigation so far, my differentials were, if you get any case of phlebitis with retinitis, the differentials comes to be Behçet disease, TB, syphilis and toxoplasmosis. So as per the uveitis, any uveitic case, we investigated the patient. CBC was normal, ESR was normal, HIV again came to be normal, and then VDRA, TPHA came to be reactive, and the Montaux and the HRCT were normal again. So the diagnosis of the ocular syphilis was made, and we already had a corneal scar in the cornea. Patient had vasculitis. One eye had a CRA patch in the fundus, the other eye has a vasculitis. So how we managed the case was, we gave injection 1 gram BD, ceftriaxone 1 gram BD for 14 days, and PT-INR along with CFS analysis with VDRL titers were done. This is the picture after 14 days. We can see the resolving hard exudates at the posterior pole, the vasculitis is going down, hemorrhages are getting resolved. And this is the OCT after 2 weeks of time. Still there is some amount of fluid in the fovea, there is a vitreomacular traction, but the retinal edema has gone down. The OCT through the lesion which I showed earlier, the retinitis had reduced, although still we cannot differentiate the layers, but we can see there is thinning of the layers here. Also the vitreous cells can be seen here in both the OCT. The FFA was repeated again, disc was still hot and there was leak inferiorly. You can see there is CNP area also in the periphery. So what we did was, seeing at the level of inflammation as it was more than what we expected, after 14 days of injection we started the patient on steroids. 60 milligram steroid was started in the patient, and this was followed by the tapering of the steroid. Further, there was further improvement in the patient and we reduced the steroid gradually. But after few days the patient was lost to follow-up, and when the patient came back, we can see there the hydroxide had resolved. There is a regression of the NV and the vasculitis has improved. So this was the OCT at 3 months post injection. Ceftriaxone injection, the foveal contour has become good and the retinitis lesion has almost resolved along with the thinning of the involved lesion. The FFA showed there was a NV inferiorly and was a peripheral CNP. Now the VDRL was negative, so we just observed the patients and reviewed after 2 months. So this case shows that the rare association of phlebitis with retinitis, and I want to discuss the role of steroids in these kind of patients, whether I want to know the house, whether they give steroids if they do get the patient of ocular syphilis or not. So just wanted to show some literature on this. The association of phlebitis with retinitis is quite less. The most common lesions that you get in posterior segment in cases of syphilis are the vitritis, iritis and keratic precipitates and retinitis. The vascular sheathing comes down around 30% of the eyes, it can be seen. So this can be retinal vasculitis, syphilitic uveitis can sometimes be confused with malignancies. It is also called as great mimicker. So it can be confused with ocular TV, malignancies, etc. Regarding the role of steroid, there is not much of available literature, but we do give steroids if there is a lot of inflammation, and still there are studies needed to be done to establish the role. So the take-home message is, it is a great mimicker. Early diagnosis of that and treatment by a high level of clinical suspicion and through thorough investigation can help with good visual rehabilitation of the patient. Thank you.
Thank you, Dr. Vidata. We'll have the question later. And thank you for finishing in time. I'd like to invite Dr. Rajiv Kumar Singh for his talk on breaking the barrier anti-YAG laser unleashes vision from sub-ILM prison. Dr. Rajiv.
Thank you, VRSB, for giving me a chance to speak. This study was done, actually it was done under the guidance of Dr. Shivani ma'am. So what is Valsalva retinopathy? It is a premacular hemorrhage due to the sudden rise in the intrathoracic pressure after acute coughing, vomiting or lifting. So here the hemorrhage is often sub-hyaloid or sub-ILM, and the visual outcome depends upon its location and the extent. So NDAG offers laser membranotomy is a minimal invasive and enables a rapid clearance. So in 2 cases we report a dense sub-ILM hemorrhage in the Valsalva, secondary to Valsalva, in which we did a NDAG laser membranotomy and we evaluate the anatomic and visual outcome. This was a photograph captured using the smartphone in the case 1 and case 2. In the case 1, it was a 23-year-old male presented with sudden vision loss unilateral after the Turner's gene activity. Right eye vision was 6/6 and in the left eye it was vision drop, significant drop to the counting finger close to face. There was a dense dome-shaped hemorrhage of around 4 disc diameter. It was a sub-ILM and on OCT it appears a convex hyperreflective lesion under the eye lamp. Coming to the case with the similar presentation in the 37-year-old female, it was also a sudden painless vision drop after vomiting episode. In the left eye, vision dropped was to 3/60. It was a small prefoveal hemorrhage of around 1 inch diameter. It was a sub-ILM conclusive by OCT. We have done other investigations to rule out like the CBC with PVS and PTINR, which came to be within normal limit. So we performed the laser protocol in this patient. We did NDAG laser membranotomy in the inferior edge of, we provide a laser of 2 to 5 millijoules in the burst manner in the inferior edge, and this laser was given in the diamond fashion, and overall the hemorrhage dispersed into the vitreous with the gravity assisted dispersion. This was a sequential representation of in case 1, case 2, where the blood is trickling down in the vitreous cavity, and we got a resolution after 7 to 10 days. Similarly, it was documented in the OCT that we attained a normal anatomical configuration and a good visual acuity after the laser. We are comparing our management protocol with other studies available, like the Ubig et al. And the Khera et al. That shows the similar good visual outcome with least complication. So discussing why the why to do a laser in such cases, because NDAG laser membranotomy enables a prompt visual rehabilitation. It avoids the in need of the invasive vitrectomy, and early drainage provides a good visual outcome, and it prevents the risk of secondary changes like ERM development and toxicity by the dehemoglobinized RBCs. So concluding, it is a safe, effective and non-invasive tool we can do. Patient can get a good and rapid visual gain and normal anatomical restoration. Particularly it is suited for young patients, and so we can conclude our statement that vision restored without a blade. These are my references. Thank you for giving me a chance.
Thank you, Rajiv.
Salam, sir. Any question?
Hello. I wanted to ask, was this actually sub-ILM or subhyaloid?
So it was
looked like subhyaloid rather than sub-ILM.
So it seems like a subhyaloid, but it is a sub-ILM. We checked the mobility also.
No, on the OCT, it was the second case, especially the second case,
yes,
it was
sir.
difficult to say whether it was subhyaloid or sub-ILM. But in the first case, it was subhyaloid. And in any case, I don't think you can break the ILM with laser.
NDA.
And the second case, I think it was very, very risky for you to have even tried laser for such a small hemorrhage.
So
because the major side effect of doing a laser,
we can hit the fovea.
No, you can create a macular hole.
Iatrogenic.
Yeah. The effect of the laser can create a macular hole. So trying to do laser in such a small subhyaloid hemorrhage.
Because it was a very small sub-ILM thing, and in the first case it looked more like a subhyaloid rather than a sub-ILM thing. So it was a subhyaloid, and the other case it was very small. So like we did try, but yes, it had an associated thing.
I think in a very small hemorrhage, if you leave it just to resolve on its own, that will resolve. It will take about 2-3 months, but a small hemorrhage like that generally
So
resolves.
for what about the significant visual loss?
It resolves. You have to just counsel the patient that it's a very small hemorrhage. the risk to benefit ratio
is very.
I mean, you have to always calculate what is best for the patient.
Yes, sir.
So my take is that you would rather allow the patient to get well on its own rather than take the risk of creating an iatrogenic problem.
Sure.
Dr. Shalabh, I fully agree with you, but let us hear what were the parameters they used to, create a hole in such a small hemorrhage without seemingly harming the rest of the retina.
So
Did you take any precautions about the spot size or the parameters that you use for laser in that case?
Ma'am, we started with titrated dose with small dose, with the minimal setting of 2 millijoule and titrated when the blanching effect is seen, and in a diamond fashion at the inferior edge.
So what did you get actually that blanching pattern? 50 से तो start किया, 20 से start किया आपने?
No ma'am, 2 millijoule.
2 millijoule, sorry, 2 millijoule से start किया.
I started with 2 millijoule.
And then at what level did you get actually?
Around 4 millijoule. It was blanching. Blanching effect was good.
Okay.
So, Dr. Pooja Sinha, next talk on role of Nipafenec in pain and inflammation management. Pooja ma'am.
A very good evening to all. This is a sponsored talk. So, as we all know, management of inflammation is a mainstay in modern cataract surgery. So, in the last 6 months, I have had at least 2 patients who were operated elsewhere, and they came 3 to 4 months post cataract surgery. There was normal surgery was done, but the only thing was that there was grade 3 to grade 4 cataract, and even if it was uneventful, the patient came with, one patient had cystoid macular edema and one patient had an ERM. Currently 2 drugs are available to control ocular inflammation: steroids and non-steroidal anti-inflammatory drugs. Steroids, as you all know, are potent anti-inflammatory agents that work by acting on a number of intercellular inflammatory mediators, and NSAIDs work by inhibiting the cyclooxygenase enzymes. So NSAIDs are anti-inflammatory drugs that inhibit cyclooxygenase activity and decrease the synthesis of prostaglandins. They act by altering the cytoskeleton structure of the epithelial cells, decreasing corneal sensitivity by altering the flow of ions at the neuroreceptors, thereby impairing corneal epithelial healing. They cause aberrant expression of matrix metalloproteinases in the cornea, leading to ulcerative keratolysis. So, the non-steroidal anti-inflammatory drugs versus corticosteroids for controlling inflammation after an uncomplicated cataract surgery, there were 48 randomly controlled trials in 17 different countries. And there were 2 groups: NSAIDs alone versus corticosteroids alone, and NSAIDs plus corticosteroids versus corticosteroids alone. So, coming to Nepafenac's 0.3% potency and convenience, the Nepafenac ophthalmic suspension of 0.3% is powerful post-operative pain and inflammation control. There is a unique prodrug formulation, increased retention time, and enhanced bioavailability. Along with that, it gives the advantage of once daily dosing, which is important to many patients. So, as a retina expert, many will agree, sitting in this forum, that Nepafenac is sometimes very loosely used by us. In my practice also, sometimes if it's a very thin ERM, nothing to be done, no vitreomacular traction, the vision is good, we just write Nepafenac for 2 weeks or 3 weeks. If it's a cystoid macular edema, which is resolving, very minimal fluid, we add Nepafenac. Sometimes not in my practice, but many times after an aggressive laser therapy, we also add Nepafenac. So, Nepafenac is very commonly used in our practice. But if you come to the real indications, prevention and treatment of post-operative pain and inflammation associated with cataract surgery is the mainstay. and reduction in the risk of post-operative macular edema associated with cataract surgery in diabetic patients. So, according to the guidelines for pain and inflammation, 1 drop is instilled into the affected eye once a day, beginning 1 day prior to cataract surgery and continuing through at least 14 days post-operative period. After that, an additional drop can be administered 30 to 120 minutes prior to surgery. Treatment can be extended to the first 3 weeks of the post-operative period as directed by the clinician. And for the reduction in the risk of post-operative macular edema associated with cataract surgery in diabetic patients, we can put 1 drop in the conjunctival sac once daily, beginning 1 day prior to cataract surgery, and it has to be continued up to 60 days of the post-operative period. Guar gum is it's a natural water-soluble compound, which is the main ingredient. And this is another multi-center randomized double-masked trial where it was done across 65 countries, where male and female patients aged 18 years or older who had planned cataract extraction by phacoemulsification with implantation of a PCIOL were eligible for inclusion. There were 2120 patients. In the intervention group, there were 2 different concentrations which were used. 817 patients were in the 0.3% group and 819 were in the 0.1, whereas in the control group we had 200 patients in the 0.3 group and 206 in the 0.1 group. So you can see so beautifully the Nepafenac 0.3 is effective at clearing inflammation, and you can see here that at least 68.4% patients had 0 cells and 0 flare. And it is also effectively resolves pain, and you can see that the pain is only 49.7% of the patients. So cystoid macular edema is one of the most common preventable causes of vision loss after cataract surgery. Pathogenesis we all know. These are 2 patients which I had treated, a 54-year male patient diagnosed with CME 4 weeks after an uneventful phacosurgery. And since there was a massive intraretinal and subretinal edema and fluid, I injected ranibizumab, and there was a real wow effect. After 2 weeks, when we did the repeat scans, the fluid had completely disappeared. And this, on the contrary, was another case, 60-year school teacher, 3 weeks post phacosurgery. I offered her anti-VEGF, but for some reason she was lost to follow up. She couldn't afford it probably, and then I wrote Nepafenac. I said, okay, if you're not willing for injection now, just use Nepafenac and come to me in 2 weeks and we'll take a call. And I think she came to me after a month, and you can see that the fluid had more or less very nicely disappeared. Only few fluid cysts were remaining. Nepafenac, as I mentioned, that we can use it in most of our settings where we want to use it, but it is not without adverse effects. And we have to be very wary of this when we prescribe Nepafenac, especially for very long intervals, for very long duration of time. So there is, it can, there can be impaired corneal sensation, persistent epithelial defects, the SPKs, stromal infiltrates, subepithelial infiltrates, and corneal complications, including corneal metals. So they have to be avoided in patients with an impaired ocular surface, that is diabetics with an impaired ocular surface, rosacea, neurotrophic corneas where the sensation is impaired, previous chemical burns, graft versus host disease, epithelial, dry eyes, and rheumatoid arthritis. So in conclusion, topical NSAIDs have a great role in reducing inflammation in certain indications, but they need to be administered with caution in patients with ocular surface disease. A close follow-up and minimal dosing is warranted, and the prescribing clinician has to keep in mind the possible catastrophic events, including melting and perforation. Thank you so much for your kind attention.
Thank you, ma'am. I'd like to invite Sivinder Sai sir for felicitating our speakers. Dr. Shivani. Shivani. Dr. Vidata.
Ma'am, Padma, I had a question. Like, if we have a single episode of retinal vasculitis or
Dr.
like recurrent scleritis, so should we start ATT or what should be the protocol in a single episode of vasculitis? If the MON2 is, because we are an endemic country, MON2 invariably comes positive in these patients.
Correct, but if you are suspecting that it could be unlike the other, see, retinal vasculitis, the other telltale signs is you will have those subretinal pigment. So TB vasculitis also now we have much more clear. So initially when we started fellowship, we used to classify as a periphlebitis and we used to keep under Eales disease. Now it is not. So we have TB vasculitis, those features. If you see, if you are confident that you are dealing with TB vasculitis, I think you should definitely go in combination therapy rather than only steroids. Yeah,
Okay.
steroids you are tend to get some effect, but again recurrences will be more common.
Okay, ma'am.
Pooja ma'am.
Thank you. For the next session, I will hand over the mic to our next moderator, Pooja ma'am.
So we'll go on to the next session, that is Taming the Untamed. And for this, I would like to invite on stage our enlightened counsel, Dr. Pranav Ranjan, sir, Dr. Sudhir Kumar, Dr. Nagendra Prasad, and Dr. Padmaja. So I would like to invite our first speaker, Dr. Deepak Agarwal, who will be speaking on diagnosing the Sinster. Is Dr. Deepak here? Okay, can we request Dr. Shalabh Sinha to come forward with his presentation, When Old is Not Gold.
दीपक कहाँ चला गया? Thank you, Dr. Pooja. It's basically it's just a video presentation.
Surgery in the past and had basically given up on this eye. He presented with secondary glaucoma, a complicated cataract and posterior synechiae. So you could see that we removed the emulsified oil from the anterior chamber and tried to stain this anterior capsule with Trapan blue, removing some of the synechiae. Now putting in the trocar cannula system 4 millimeters away from the limbus and leaving it open, making the incision for the cat phaco. Now using this pupil expansion device. This device basically has scrolls, and each of these scrolls is engaged in the pupillary margin, and it dilates the pupil using a two-handed technique. This was accomplished. You can see forceps in one hand and the Sinskey hook in the other. Next, we restain the anterior capsule as the staining was insufficient, and putting in viscoelastic. Now you can see that the anterior capsule is well stained, and you can safely do a good rhexis. The rhexis is made large because this is a pretty hard cataract. Using the cystotome, we've done that, and then a multi-quadrant hydrodissection is done, followed by using the Sinskey hook to rotate this nucleus in the capsular bag. And then we are going to do a direct chop using a sharp chopper. So you can see that this is a pretty hard cataract, and we are doing a multi-quadrant type of direct chop so as to create multiple fragments. So you can see that once we've created multiple fragments, now we are trying to pick up each of these segments and emulsify each of these segments one by one. The nucleus is rotated so as to bring the pieces in front of the tip of the phaco. Now, since we are coming to the end of the emulsification of the fragments, we have replaced the sharp chopper with a blunt one, just in case we wish to, prevent any injury to the posterior capsule. But once we've done that, lo and behold, we find that there is a big and a thick PC plaque sitting on the posterior capsule. So irrigation aspiration to remove whatever cortex that there may be in the capsular bag. And then using a Sinskey hook, we are trying to create an edge so as to peel this plaque from the posterior capsule. And one has to be careful in doing this because we don't want to put too much stress on the zonules. So you can see now that the Sinskey has managed to pick an edge, and that edge we are trying to enlarge with the irrigation. So we will change this Sinskey hook now to a forceps, a capsular rhexis forceps, which will hold the plaque. And now you can see that sweeping motions of the irrigation, how beautifully it separates the PC plaque from the posterior capsule. And this plaque now comes out in toto. Now once we have a clear posterior capsule, now we are implanting a hydrophobic intraocular lens into the capsular bag. So then the infusion is placed in the anterior chamber, and the pupil expansion device is now going to be removed. So it is disengaged from the pupillary margin, and we are holding one of the edges and protecting the endothelium with the Sinskey hook. The screws can sometimes get stuck. Since the intraocular pressure had been raised in the beginning, we are also doing a trabeculectomy. You can see the conjunctival peritomy has been done in the superior part, followed by retinectomy, and some wet field cautery is done to the sclera. And a crescent blade is used to create a triangular flap. So this triangular flap is now fashioned, and the oil is almost out, and the cannula is removed. Ostium being made with the punch, followed by a peripheral buttonhole iridectomy, and the scleral flap and the conjunctiva are sutured with a 8-0 vicryl suture, and this patient did well with a well-controlled intraocular pressure.
Thank you, Dr. Shalabh. I think for paucity of time, we'll go ahead with the next.
Yes, sir.
I mean, just two questions I'll ask quick. The use of an iris hook, because this was a posterior synechial case. The self-retaining retractors, iris retractors at times do not engage well and do not dilate the pupil also well. So probably such cases, had I been in your place, probably I would have used an iris retractor, number one. And number two, regarding the plug. I mean, plug, manipulating the plug just because you're a VR surgeon, so you could have managed if anything would have happened. But for an anterior segment surgeon, managing and manipulating the plaque in that way seems very dangerous, because had there been a PC defect in that place, then things would have been different.
Already it's a vitrectomized eye and there is silicone oil behind.
Yeah.
Even if during removal of the plaque, if the PC rent, even if it happened, it doesn't matter.
It came out very well.
Yes, it came out very well.
Yeah, it came out very well. That was just like the posterior polar cataract kind of a thing, which we do an anterior segment OCT to see whether the plaque is adherent to the posterior capsule or not.
The reason I use the iris expander devices is because in the post-operative period, you always get a very round and a regular pupil. But in iris hooks, it is always irregular, and you can tear the sphincter of the iris. So it's always better to use a pupillary expansion device. It gives you a very nice pupillary size per op and doesn't cause the disfigurement of the iris.
Personal communication.
So I'll be sharing a very interesting case I recently encountered. This was a 24-year male patient who complained of diminution of vision in both eyes, left eye more than right eye, 15 days duration. He had a history of fever with a severe headache 1 month ago. On examination, his right eye was 6/6 and left eye was counting finger half meter. And this was his fundus picture. Both the eyes had multiple cotton wool spots all along the peripapillary area, and in the left eye they were also along the superior arcades. This was the OCT picture. There was retinal thickening along with the intraretinal edema and cystic spaces. And the left eye, there was definitely much more ischemia. There was a thickening along with massive edema at the intraretinal and the subretinal spaces. So this was the FFA. There was florid neovascularization and causing leakage. So on investigations, BP was normal. RBS was also okay. The Vidal test, there was S typhi A was reactive, and the rest of the tests were non-reactive. So I had made a diagnosis of post-fever retinitis secondary to typhoid. The patient was started on systemic steroids, starting with 50 milligram per day in weekly tapering doses. Along with that, I added oral ciprofloxacin 500 milligram BD for 5 days. But after 15 days, the vision in the right eye had decreased to 6/18, and in the left eye, there was marginal improvement only to counting finger 4 meters. And this was 15 days after starting systemic steroids. You can see that there were cotton wool spots such as retinitis lesions in the peripapillary area, and the left eye also had a macular fan suggesting a resolving macular edema. So this was the OCT picture. There was thickening of the inner retina, and after shadowing, the fluid had disappeared, but the retinal thickening was quite significant. And this was the left eye. This was the FFA, which showed a lot of CNP areas along the arcades and the peripapillary area, along with neovascularization and leakage. So because there were CNP areas, and I thought that the patient had the ischemia was increasing, I gave injection ranibizumab in the left eye followed by right eye after 1 week. And this was 15 days after the first injection. The edema had decreased and the cotton wool spots though decreased but not very significantly, and this was in the right eye. So these are both eyes put together. You can see that on OCT the edema had decreased, but the vision was not very significantly increased, and this was the left eye, which was the worst of the two eyes. So this was the octa. This showed some CNP areas, but it was nothing significant. So in discussion, post-fever retinitis is an infectious or a para-infectious uveitic entity caused by bacterial or viral agents. It usually occurs in the 3rd week after the onset of typhoid fever. This is referred to as the week of complications. Typhoid retinitis may be secondary to direct invasion of Salmonella typhi bacillus, or it could be an immune-mediated reaction. In most cases, the prognosis is good. The fundus lesions resolve, leaving pigment epithelial changes and some amount of foveal thinning. There was no endophthalmitis secondary to typhoid in my case, but the vision was very poor, unfortunately. This was owing probably to the retinitis lesions sitting directly on the papillomacular bundle. Thank you so much for your kind attention.
Very interesting case. We do see varied response in terms of visual response in this patient. Maybe the amount of ischemia, but otherwise it's an immune complex type of mediated disease there. You rightly started, I think, systemic steroids along with some people, when they see an angiogram, when they see vascularization pattern or something, they also suspect sometime Bartonella Hanseli, and then they also add doxycycline to this regime. But whatever it may be, the visual response is, we cannot really assume whether anti-VEGF we give or not. Sometimes I think in 3 to 4 weeks they respond with whatever the recovery of vision.
Yes. In my patient, there was a lot of ischemia right from the beginning because of these multiple cotton wool spots. So
yes,
prognosis was not very good.
Yes.
One must take caution about starting a steroid in typhoid.
So that is one of the concerns with an ophthalmologist, whether to start a steroid. I think these kind of patients should also be treated by a physician simultaneously, so that we get a clearance in case.
Yes, sir. The patient had come to me after 1 month. He had already recovered from typhoid. He was asymptomatic, only that his vision was very poor. So he had come to take care of his eyes.
The PFR usually comes at 1 month, sir. So the steroid doesn't place much difference if you are giving it a typhoid or whatever the etiology is, because the fever has already resolved after 1 month. So, and the role of steroid is very controversial. Also the role of doxycycline. But we do give steroids as mostly it is mostly it is inflammatory, and also on the other hand it is self-limiting disease. Even if we don't treat it with steroids, it is going to resolve in the due course. But as a clinician, we have to give something, so we do give it. Padmaja ma'am.
Thank you.
Next we have trailblazer.
Can I request Dr. Shivendra Sahay sir to come forward with his case on trailblazer in retina case.
Good afternoon, everybody. Today I am here to discuss revisiting ranibizumab biosimilar through Macubrite trailblazer in retina care. In Indian scenario, because of cheap cost price, ranibizumab biosimilar is proving as a trailblazer in retina care. It is a sponsored talk for one of our conference partners, Zydus, which has brought Macubrite, which is ranibizumab biosimilar. Now, credibility of Zydus Cadila, when the entire world was suffering from COVID, and this COVID epidemic, they produced world's first COVID-19 DNA vaccine developed in India under Mission COVID Suraksha as JICO-D. Now Zydus has brought Macubrite, a ranibizumab biosimilar which matches the safety and efficacy of ranibizumab's innovator brand at a very cheap rate, helping the poor lot of our nation. Now Macubrite kit contains a single vial dose, 1 ml syringe, filter needle, 30 gauge needle. Now the dose of Macubrite is just like the ranibizumab, but it should never be given within 30 days gap. Then ranibizumab, the original molecule comes in single use vial, dose 0.05 milligram per 0.05 ml. Drug detail: ranibizumab is a sister molecule of humanized murine monoclonal antibodies with affinity for binding all VEGF-A isoforms. Indications: it is mostly used as anti-VEGF agent and commonly used as first line drug in condition, not drug of choice. First line drug in conditions like neovascular AMD, DME, RVO and ROP. Now coming to the ranibizumab biosimilar, in a biosimilar of ranibizumab, the companies do a minor change at the molecular level without changing the efficacy and safety of the drug to have protection from patent loss. Indications almost same as that of ranibizumab, except ROP as trial vitritis have been observed in biosimilars, especially initial stages. These are the competitor brands: Macubrite, Rajumab, Ocivia, Visumab. Now among all, this is Macubrite comes at a very cheap rate. Now these are some slides from my clinic. In diabetic the performance of Macubrite in DME, pre-injection OCT on the first day of injection, then OCT, you can see the regression of CMT, OCT before second injection, that is 30 days after injection, and OCT before third injection, that is 60 days after the first injection. Now in CNVM, pre-injection OCT on first day of injection, then OCT before second injection, that is 30 days after injection, and OCT after fourth injection, that is 120 days after the first injection. You can see the regression. Now in CME of RVO, pre-injection OCT before first injection, you can see the huge CME. Then OCT before second injection, that is 30 days after first injection, and OCT before third injection, that is 60 days after injection. So the key takeaways: Macubrite is made in India product brought by Zydus, a trusted pharmaceutical house. Macubrite is a Rajumab biosimilar having anti-VEGF activity same as that of the innovator brand. Macubrite is equally safe and efficacious as that of innovator brand. Macubrite plays a crucial role in the treatment of neovascular AMD, DME, CME of RVO, and among all the available biosimilar counterparts, it is available at a cheaper rate. It is a made in India product. Thank you very much.
Thank you, sir. Now can I request Dr. Shishir, who will be coming forward with his talk on steroid, no steroid, please.
Good evening, everyone. I think this is the last talk for the day. All of us must be tired after an exhausting day of very scientific sessions, very scientific information. I'll be coming up with two very simple routine cases we often see. We have seen very high-end surgical videos, very rarest of rare cases. I'll be presenting two simple cases which probably we often come across. The topic is steroid. Most of the times, many times it helps us, can be a treatment for life-threatening conditions, can be a treatment for multiple visual threatening conditions. Sometimes for the fear of not giving steroids, if we delay steroids, that can be extremely bad for the patient, extremely bad for the visual recovery. At the same time, sometimes it can land up our patients in extreme troubles as well. So we have to be careful, but understanding that its usage also is equally important, as sometimes it is the fear that comes with the use of steroid use. I had read somewhere that in ophthalmology, not giving steroid and letting the patient have a visual recovery, a prolonged visual recovery which could have been stopped at a very early stage, is far more an error of omission then rather than a few of the complications of overly used steroids. So it can be a situation. I'll be presenting 2 cases of serious retinal detachments. I would like, if the audience can interact, if there is any resident in the audience, if they would want to interact for these cases. The first case is a 37-year-old male who presents with visual loss since 3 months. His vision at presentation was 6/18. We see this posterior pole fluid, a yellowish lesion temporal to fovea. The OCT passed showed subretinal fluid, and a PED was seen as well. The second case is a 14-year-old female, young female, who comes with dimness of vision since 10 days. Her vision was 6/9. On OCT, we see on the fundus examination, we see posterior pole RD, posterior pole serous RD with OCT showing subretinal fluid, and we see a septa-like partition in the fluid. A yellow lesion is seen here as well, just temporal to the fovea. So what do we do next for these 2 cases? Can we start any treatment at this stage? Do we get an FFA done? Do we get any other investigation done? Or based on the clinical judgment, can we give any treatment? I would like to put the pictures again if anyone from the audience or anyone would like to point out what.
Yeah, case 1, the symptoms are since 3 months.
Yes, ma'am.
And clinically, this looks to me like a fibrin CSR.
Yes, ma'am.
So I would definitely do an FFA in this patient.
Yes, ma'am.
And see where the leak is.
Yes, ma'am.
And if the leak is extrafoveal,
yes,
then I can even laser it.
Yes, ma'am.
That is my usual protocol. And in the case 2, of course, if it's like if she is a 14-year-old, so that's like a little unlikely age for a CSR.
Yes, ma'am.
So we can definitely investigate in her case. We can ask for history, what if she's taking on any medications or any other steroid history or something like that.
Ma'am just nailed both the cases. I was expecting.
That first case, what Pooja said about fibrin CSR,
yes,
right?
Ma'am.
So if you see in that fibrin, there is a equiescent space is there, the central.
Yes,
that is where usually the leak will be there.
Yes, ma'am. Yeah, so not much to discuss any further. Both the cases have been nailed. We got FFAs done for both the cases. The first case had 2 hyperfluorescent areas, one small dot and a large round. The small dot increased in size and intensity. That was an ink blot leak of the CSR. The larger hyperfluorescence, which increased in intensity but not in size, was the pooling in the PED. The second case had a hypofluorescent lesion just temporal to the fovea, where we see the yellowish lesion dot, which eventually leaks in the late phase. So this is very typical of an inflammatory pathology. The first case we diagnosed as old fibrinous CSCR, and the second case as the retinochoroiditis. The first case focal laser we did because the leak was far away from the central 500 microns of center of fovea, and steroid is contraindicated definitely in this situation. The second case, we found a history of fever was there in the young female. We started, this condition is a post-febrile retinochoroiditis. These conditions are mostly self-limiting, but faster visual recovery will always be good for the patient. We started the patient on steroid under an oral antibiotic cover, and both the patients responded. So most of the take-home, the first case after after focal laser, patient his vision improved to 6/9. The lesion is decreasing in size on OCT and fundus photo. Further, the patient did not follow up. I suppose the patient must have recovered. The young female also, after 2 weeks of systemic steroid therapy, she regained her full vision, and the OCT showed complete resolution of the subretinal fluid. So the take home from this, I would say, is that for any posterior pole subretinal fluid cases, jumping to conclusions sometimes before an FFA can be a problem. So FFA definitely helps. Further investigation in the second case was done. All her blood profiles were normal. So take home, I would say, is angiography is, although we read about newer investigations, OCTA, many others coming, but an angiography sometimes is very, very crucial, especially in such simple cases, differentiating whether it is a CSR where steroid is contraindicated or it is an inflammatory condition where steroid is the mainstay of treatment does help. Thank you so much. Yeah.
Thank you, Dr. Shishir. So,
why do you say it's a retinochoroiditis and not chorioretinitis in the FFA? Because the early phase is hypo.
Yeah.
And so, why do you say it's a retinochoroiditis? Why is it a retinitis?
It could be a retinitis, sir. It could be a febrile retinitis as well. Retinitis or choroiditis, both on FFA will have a similar early hypo because the inflammation will mask the initial choroidal flush, and eventually both the lesions would leak and lead to a similar FFA finding.
I think the FFA findings would be different in chorioretinitis and retinochoroiditis. In retinochoroiditis, we will see that the retinal vessels, the arteriole or the venule, the arteriole over there will be fuzzy in the early phase act. So that is what I think will happen in retinitis.
Yeah, I think.
So actually we have to start with inauguration and we have one paper remaining.
Difficult question put up by Deepak sir, maybe.
No, because I think OCT will tell you also exactly the layer of, if we pass through that lesion, we will know the length of the involvement. But I think both cases are very good. Yeah.
Thank you so much.
Our last speaker for the evening, last but not least, Dr. Deepak Agarwal. He'll be speaking on his case of diagnosing the sinister.
So I'll be a bit fast in this. So I'm going to present a case of a young male, a 28-year-old male who presented to us with sudden loss of vision in his right eye of 5 days duration. There was associated redness and mild pain. He gave a history of chicken pox 3 weeks before. So as you can see here, the pupil here, you can see here the chicken pox lesions are seen, the healed one. The visual acuity in the right eye was PL negative. The left eye vision was 6/6. Anterior segment actually showed an afferent pupillary defect. The anterior chamber showed 2+ cells and flare. The fundus, however, showed no vitritis. And as you can see here, there was disc edema and there was presence of yellow-white discrete patches of deep lesions involving the posterior pole and also involving the peripheral retina over here. So what could be the diagnosis? Anyone would like to volunteer? Okay, so actually it's a necrotizing herpetic retinopathy, and in that we can have ARN, acute retinal necrosis, or PORN. So in this particular case, since the patient had no vitritis, there was involvement of the posterior pole initially. So I was very suspicious of a PORN in this particular case. So I sent the patient for investigations where we investigated for HIV basically in this young patient, and immediately we gave the patient intravitreal ganciclovir 2 milligram in 0.1 ml and started him on oral valacyclovir, although intravenous acyclovir would have been better, but I referred the patient to a physician also later. So when the investigations came, he was HIV positive, and the patient actually did not know that he was HIV positive. Then we referred him for heart therapy and for CD4 counts, which came to be 44 cells per millimeter cube in this particular case. So after 2 doses of intravitreal ganciclovir, this was after the first injection, you can see that the lesions, deep yellow lesions, have regressed. The arterioles, the vessels have been occluded. And this is after the second injection, where you can see the disc edema has also disappeared and the disc is appearing much pale, and the lesions have completely almost disappeared. But the thing is that the visual prognosis in these cases are very poor, and the patient already presented with a PL negative. So this is the case here, the initial presentation and then after the 2 injections. So basically this was the case of PORN, that is progressive outer retinal necrosis, and it falls under the spectrum of necrotizing herpetic retinopathy. So initially it was considered to be 2 distinct entities in literature, and PORN is characterized by a rapid progression of necrosis of the outer retina in immunocompromised patients, and the most common etiologic agent is varicella zoster virus followed by the herpes simplex virus. So ARN is a clinical syndrome of acute unilateral panuveitis with retinal periarteritis and necrotizing retinitis, and it affects healthy individuals, whereas PORN affects immunocompromised patients, and there is limited intraocular inflammation, like in our patient where the vitritis was almost absent. So etiology, again, as I mentioned, 71% varicella zoster, HSV, and rarely CMV has been found to be the cause. And the CD4 counts at presentation in patients of PORN was found to be around 21, ranging from 1 to 130. And 22% of them definitely gave a history of cutaneous zoster prior to the onset of the PORN. So I'll skip the pathogenesis, and I'll just move on that retinal detachments also can occur in some cases, and we have to note that in these cases, since the retina is very thin, the number of holes, the number of atrophic holes may be multi-level also in these particular cases, and diagnosis is made based on history and clinical examination, and retinal investigations are not actually very useful or essential to diagnose PORN. So in some cases we can see that after the scarring there can be a cracked mud appearance. This is because of the atrophy of the RPE and neurosensory retina, and this is a typical cracked mud appearance in PORN. And the visual prognosis is grim and may correlate to the visual acuity at presentation. And approximately 66% of these patients are treated with only systemic antiviral therapy are shown to progress to to PL negative, whereas those receiving prompt intravitreal antiviral therapy regain some better vision. Thank you. But in our case, since the patient already presented with a no PL, we landed up with a no PL later on also. But the important thing is that the disease had regressed following the treatment. Thank you.
This concludes the session. Very well presented, Dr. Deepak. You managed the case yourself.
Yes.
You injected
intravitreal GAN cyclone.
Okay, nice.
Only one thing which comes to the mind is, I mean, how early the treatment can start. Then only you will get a better visual prognosis. What you said, the patient was count finger.
Yeah,
or PL
no,
negative,
not,
right?
he presented with PL negative only,
yeah.
And we had a clinical suspicion that this is PORN because the inflammation was less, the involvement of the posterior pole first. And if it had been ARN also, we can give intravitreal GAN cyclovir, and it has been shown that patients who are treated with intravitreal injections do better than those patients who are just treated on systemic therapy.
Okay, right. The only concern is how to take that patient at an early stage, how to detect and how to decide whether this patient is going to benefit early. That is the main concern, right?
I think once the diagnosis is made that this is ARN or PORN, it has to be done immediately. It's the diagnosis which is important, that we diagnose it's a herpetic retinal necrosis.
Okay, right.
So this concludes our session. Can I request our past president, Dr. Nagendra Prasad sir, to please facilitate Dr. Shishir. And Dr. Shalabh, is he here? Dr. Shalabh Sinha. Okay, so thank you everyone. This concludes our scientific session for, oh sorry, Shalabh is here. So this concludes our scientific session for day 2. It was a very exhaustive, power-packed sessions with lot of interesting interactions and learning. So now I welcome everyone for the inauguration, which will be followed by live entertainment and dinner.
हम लोग का डॉक्टर पूजा ये जी कैन वी डू द जीबी यहीं पे तब तक प्रिपरेशन होते रहेगा कैन वी मतलब डू द जीबी राइट नाउ कर सकते हैं हम लोग क्योंकि लोग भी इन्हें तो भाग जाएंगे फिर इट्स विल बी डिफिकल्ट एंड हाँ यहाँ पे बैठ के हम लोग ये लोग क्योंकि यहाँ तो प्रिपरेशन जब तक चल रहा होगा ना हम लोग 15-20 मिनट हाँ ऐसे भी हो जाएगा दैट वुड बी बेस्ट requested all of you are requested to please stay back. We are going to have GBM now. क्योंकि उसके बाद तो इंटरटेनमेंट वाला भी तैयारी करेगा ही करेगा तो इन एनी केस तो वो तो वहाँ अपना हाँ दिस इज द बेस्ट टाइम सारे लोग रुक जाइए उसके बाद फिर वो तो
प्रदीप वहाँ दिखता है ना वहाँ दिख रहा है ना यहाँ पे लिखा हुआ PMCH है ना चलाते हैं मोहम्मद देना ठीक है ना अच्छा हो जाएगा ठीक है ना टॉमी का है तुम्हारा कर सकते हैं आइए ला कॉपी कर दे लगा देगा
So we are going to have GBM right now. All are requested to please be seated. All the members of VRSB. यही इतना ही होना जो एक्सिक्यूटिव और ये में हाँ प्रीपोन कर दिए तो सुनिए वैलिड पॉइंट है कोई भी चीज़ है को नियम से चलता है आप उसमें
फ्लाइट को 2 घंटा पहले ही उड़ा रहे हैं
अपने आप उसमें लिखे हुए हैं
बहुत सारे पैसेंजर आए नहीं अभी
7 से 7.5 GBM लिखे हुए हैं नहीं आप बाद में करते तो चलता पहले कर ले रहे हैं कुछ लोग बोलेगा मेंबर्स की ने देयर वाज सम वेस्टेड इंटरेस्ट पहले करा के पास करा दिए तो
वैसा क्या बोलेगा तो हम लोग फिर से करते हैं
नहीं फिर से दोबारा नहीं होता है अब फिर उस पर पता है ना जब बॉस में भी मालूम है वी नो दैट वी नो दैट नियम तो यही बोलता है ना क्योंकि कोई बॉस में भी कोर्ट केस हो चुका है नहीं हम कहने तरीका वही होता है व्हेन वंस यू हैव अनाउंस दैट इट विल बी GBM टाइम अगर आप पहले करते हैं तो देयर शुड बी प्रायर इन्फॉर्मेशन एटलीस्ट पहले हम लोग डाल देते हैं ग्रुप में भी ना क्या हमको लगता है कि कॉन्फ्रेंस में ये इनॉग्रेशन तो साथ में ख़त्म हो ही जाएगा क्योंकि उसको ये तैयार करने में जो म्यूजिकल वाले को लगेगा आधा घंटा उसको हाफ एन आवर तैयार करने में लगेगा तब तक हम लोग GBM ख़त्म कर सकते हैं क्या वही ज़्यादा अच्छा है हाँ वो जैसे हम लोग का इनॉग्रेशन ख़त्म होगा वी विल हैव हाफ एन आवर टाइम फॉर देम द म्यूजिक entertainment system and everything to be
We are just waiting for Professor Rajvardhan Azad. As soon as he arrives within 10 minutes, then we'll be starting the program. A very warm welcome to the inaugural ceremony of the 6th Annual Conference of VITREO Retinal Society of Bihar. Without much delay, I would like to straight away call our Chair Emeritus and founder of VITREO Retinal Society of Bihar, Professor Rajvardhan Azad, to please come on the chair, on the stage, please. I'd like to request our guest of honor, Dr. Binde Kumar Sir, who is the Vice Chancellor of Bihar University of Health Sciences and Director of IGMS, to please come on the We'd like to request our guest of honor, Dr. T.P. Das Sir, Vice Chair of Emeritus of L.V. Prasad Eye Institute, Hyderabad, to please come on the stage, please. We'd like to request our President, Dr. Subhash Prasad Sir, to please come on the stage. I'd like to request our Vice President, Dr. Shivendra Sahai Sir, to please come on the stage. I'd like to request our immediate past President, Dr. Nagendra Prasad, to please come on the stage. I'd like to request our Secretary, Dr. Pooja Sinha, to please come on the stage. And I'd like to request our Treasurer, Dr. Deepak Agarwal, to please come on the stage. Lamp ko upar rakhiye to. Ganesh Vandana. I'd like to request all the dignitaries on the dais to please come forward to light the lamp, please, to inaugurate the meet.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
लाल चढ़ायो अच्छा गजमुख को जोन दिल लाल विराजे सुत गौरी हर को हाथ लिए गुड़ लड्डू।
I'd like to request Rimjim to please give a welcome bouquet to Professor Rajvardhan Azad. I'd like to request Lata to give a welcome bouquet to Dr. Binde Sir, please. I'd like to request Neha to please give a welcome bouquet to Dr. T.P. Das Sir. I'd like to request Rimjim to give a welcome bouquet to our President, Dr. Subhash Prasad Sir. I'd like to request Lata to give a welcome bouquet to our Vice President, Dr. Shivendra Sahai. I'd like to request Vinita to give a welcome bouquet to our immediate past President, Dr. Nagendra Prasad. I'd like to request Neha to give a welcome bouquet to our Secretary, Dr. Pooja Sinha. I'd like to request Rimjim to give a welcome bouquet to our Treasurer, Dr. Deepak Agarwal, please. I'd like to request our Secretary, Dr. Pooja Sinha, to please welcome the delegates.
A very good evening to everyone. A very warm welcome to our guest of honor for this evening, Dr. Binde Kumarji, Vice Chancellor, Bihar University of Health Sciences, Director IGIMS Patna. A very warm welcome to our guest of honor, Dr. Tara Prasad Dasji, Vice Chairman Emeritus, LV Prasad Institute, Hyderabad. Our chief guest for the evening, Dr. Sunil Kumar Ji, Honorable Minister of Education, Government of Bihar. Unfortunately, he has not been able to be present for this meeting, but he has sent his recorded message and his blessings to our society. Our Chair Emeritus and founder of VITREO RETINA Society of Bihar, Professor Rajvardhan Azad Ji. Our President of VITREO RETINA Society of Bihar, Dr. Subhash Prasad. Our Vice President, Dr. Shivendra Sahai. Our immediate past President, Dr. Nagendra Prasad. And our Treasurer, Dr. Deepak Agarwal. A very warm welcome to this August gathering. I'm very honored to present the Secretary report for VITREO RETINA Society of Bihar 2022 to 2025, which was my term. So I'm very grateful for 3 years of opportunity to serve VRSB. It has been a very fruitful tenure where we have had CMEs within Bihar and our annual conferences in the years 2022 to 2026, which will be next year. So the CMEs within Bihar, we have included CMEs on different topics. There was a roundtable VRSB meet where the chief guest was Dr. Sangeet Mittal, VITREO RETINA Director in Thind Eye Hospital, Jalandhar. He also did a deferred live surgery today in the morning, which was on April 22nd, 2023. Then we had another meeting on May 17th, where Dr. Somnath Prasad presented his interesting retinal cases. And then we had a rendezvous of retina in September, where we had a galaxy of speakers from all over India. Our mentor, guru and guide, Professor Rajvardhan Azad, is the reason why we stand on this podium today. He has been instrumental in bringing us together, forming the society, and we are very humbled as well as proud that he has given us the foresight to think big, and with his blessings, the level of retina care in our state has improved by leaps and bounds. So these are our CMEs, which are a very good attendance and a very interactive audience always who learns and interacts. In 2022, we had our annual VRSB conference in Varanasi. Though we are in Bihar, but we always try to mix science with fun, just how our VITREO RETINA Society of India had started. So that makes a lot of learning, interacting, and we had a very successful conference in Varanasi where we had a full 2 days scientific extravaganza along with a holy temple visit. And the Vice President of All India Ophthalmic Society, Dr. Mohan Rajan, and his wife were also present, and they really enjoyed the conference. In 2023, we had our conference in Siliguri, and it was very well attended by a galaxy of speakers from all over India. The chief guest was Dr. Lalit Verma, the former EIOS and VRSI president, and it was also attended by the Nepal VITREO RETINA Society team, headed by the president of the Nepal VITREO RETINA Society, Dr. Sayam Bajimaya, and the current secretary of the VRSI, Dr. Manisha Agarwal, who is also a very good friend of mine. We were colleagues in Shankar Netralaya, where we did our fellowship together. So as I said, VRSB and the Nepal VITREO RETINA Society have come together, joined hands, and this has solely been possible because of Professor Azad sir, who is very, very close to Dr. Sayam and the other senior VITREO RETINA consultants in Nepal. And we have thought of uniting together and holding annual conferences every year. So this was the meeting in Siliguri. which was extremely well attended, followed by a cultural program, and there was a train ride from Patna where all the families and the kids, they also had a gala time. And here you can see we had a riverside picnic, and you can see Lalit Verma sir and Dr. Sangeet Mittal, our president, Dr. Subhash Prasad, and so many other colleagues. We had a very nice time. So in 2024, we had a meeting in Ayodhya. Again, very well attended, where we had free papers for medical retina, surgical retina, debates, a video assisted skill transfer, and it was extremely well attended. And we had divine darshan of Ram Lalla, and we consider ourselves very lucky that we could go to the spiritual land and receive his blessings along with our scientific presentations. So this was the pictures, and Dr. Ajay Arora and his wife Dr. Ritu Arora from Delhi were also, they had joined us for this. These are some more pictures of the same conference. And now in 2025, we have gathered here in the spiritual land of Gautam Buddha in Patna for our 6th annual VITREO Retina Society meeting. We have, our conference started from last evening, where we had an excellent collaborative research discussion and presentation by the two doyens of ophthalmology, Professor Rajvardhan Azad sir and Dr. Tara Prasad Das sir. We had, they told us how to collaborate, how to research, how to write, come together and publish data, so that more patients will be benefited from all across India. Along with this, we had a whole extensive and exhaustive surgical and medical retina day today. We started with a deferred life surgery, where the vitreoretinal surgeons, about 4 from our own state and 1 from Jalandhar, Dr. Sangeet Mittal, they did deferred life surgeries, meaning that the surgeries were recorded 2 days before, and they were replayed here and the link was there to share nationally, as well as it was on air, so everyone in India could see the surgeries as they were being presented. And these are our national guest faculties. We are very honored to have Dr. T.P. Das sir, Dr. Padmaja Kumari, Dr. Rupak Kanti, Dr. Vishal Agarwal, Dr. Sangeet Mittal, Dr. Richard Tiwari, and Dr. Chaitra Jaydev from almost all parts of India, which are representing us today. So this was the deferred life surgery in the morning, and this was from last evening. These are the pictures. And I would like to specially welcome everyone tonight for the gala banquet and musical evening, and then tomorrow in the morning again a whole scientific day awaits everyone. And just to close, in VRSB in 2026 we have dreams of holding our annual conference in association with the Nepal Society, Bangladesh Society, Bhutan Society and Sri Lanka Society, because though geographically we are very close together, but we were close but yet very far apart, and our surgical acumen could not be shared earlier. But now with we are trying to make endeavors to get everyone together on the same podium and platform and learn from each other. So our VRSB 2026 is scheduled to be held in Chandragiri Hill Resorts, Kathmandu, Nepal, and we are very excited and looking forward to it. So very grateful to immediate past President Dr. Nagendra Prasad, a tenure very well completed. He is now resting and relaxing, and deeply indebted to President Dr. Subhash Prasad for his constant support and encouragement, and without whom I think we would not be able to accomplish even half of it. He is the force behind us, always prodding us, pushing us, aur karo, or publications badhao, or presentations badhao. So thank you so much, sir. And last but not least, very, very grateful to the entire executive of VRSB, especially Professor Azad sir, for his constant support and encouragement. Thank you so much to all the members.
Thank you, Dr. Pooja. I would now like to request our President, Dr. Subhash Prasad sir, to please welcome the guests.
Good evening to all. It gives me great joy and pride to welcome you all to the 6th Annual Conference of VITREO RETINA Society of Bihar. At the outset, I feel deeply honored and extend a special welcome to our Chief Guest, Mr. Sunil Kumar Ji, Honorable Minister of Education, Government of Bihar. Though he could not come today, yet we can feel his presence today. And there will be a short video that will be shown by Dr. Satyajit, his blessings. I am equally privileged to welcome our distinguished guest, Professor Binday Kumar sir, Vice Chancellor of the Bihar University of Health Sciences and Director of IGMS, a pillar in the field of medical education and healthcare leadership. A very warm welcome and heartfelt respect to Dr. Tara Prasad Das, the Vice Chairman Emeritus, LV Prasad Institute of Hyderabad, and one of the most known eminent ophthalmologists of our country, whose presence has really given glory to this conference today and yesterday. From yesterday itself, sir has been there, and he has been a source of guidance and inspiration to all of us. I must also take a moment to pay tribute to the visionary who laid the foundation of our society, Professor Rajvardhan Azad sir, former Chief of the RP Center, AIMS New Delhi, Chairman Clinical and Research Advisory Board, Akhand Jyoti Eye Hospital, and the creator of the VITREO RETINA Society of Bihar. He has been the guiding force of so many ophthalmologists, not only of the Bihar, India, but abroad also. And his belief in the power of collaboration among retina specialists of Bihar has actually brought to the platform where we are today. I like to welcome other eminent ophthalmologists, Dr. Padmaja Kumari Madam, Dr. Chitra Jayadev, Sangeet Mittal, Rupak Kanti Vishwas, Dr. Vishal, Dr. Ruchir, who are coming actually tomorrow. The VITREO RETINA Society of Bihar actually was established in, that was the brainchild of Professor Azad sir in 2018, where we had the first conference, and it has grown into a vibrant platform for academic excellence, collaboration and fellowship among retinal surgeons across the state. What began as a vision is now gradually becoming a movement, bringing together expertise, innovation, and most importantly a shared response. And that is the reason that today we slowly we are growing, and it's all because of sir's guidance. This conference actually reflects that spirit which we are conceived by Professor Azad sir, and with a robust scientific agenda, interactive sessions, and the opportunity to engage with leaders in our field. I am confident that we will have all the we will have the enriched scientific session, which actually started from yesterday for another one day. And this conference actually is a landmark for two reasons. That first time we started deferred live surgery, actually it was a planned live surgery, but due to some guidelines, we changed it in 1 or 2 days to deferred live surgery, and that was quite success. And this was our experience that it was no less than a live surgery actually, and we could interact more. So I think this is the way we can go ahead. And another thing is that sir has told us that go for a website creation. So we have created website for VRSB also, that will be launched by sir himself. A special note of appreciation goes to our dedicated secretary, Dr. Pooja Sinha, whose tireless efforts and attention to detail have made this event possible. Apart from our secretary, all our executive members and particularly Dr. Agarwal has been doing a great work in collecting funds and all the things, and Vice President Dr. Sahai and immediate past President Dr. Nagendra Prasad, they have all been working. This time we have worked as a team, a very cohesive team, and that's the reason that we have collected funds also for our society, and we are really grateful to our sponsor. Because of that we are able to hold this conference. And we cannot forget one man. सब लोग बोलते हैं कि एक सक्सेसफुल पर्सन के पीछे एक वुमेन का हाथ होता है, बट यहाँ मैं बोलूँगा कि एक सक्सेसफुल सेक्रेटरी के पीछे जो है वो डॉक्टर सत्यजीत, दिन रात वो लगे रहते हैं। एंड हम लोग उनको अडॉप्ट कर लिया कि अगर डॉक्टर सेक्रेटरी नहीं भी रहेंगे, वो डॉक्टर पूजा नहीं भी रहेंगे सेक्रेटरी, इनको लाइफ टाइम यहाँ पे काम करना है। तो इसी के साथ मैं जस्ट सबको थैंक यू बोलना, वेलकम करना चाहता हूँ, धन्यवाद देना चाहूँ. थैंक यू सो मच.
Thank you, sir, for those words of encouragement. I would like to request Professor Rajvardhan Azad and Dr. Swat Prasad to assist him in inauguration of the VRSB website. Okay, ठीक है. I'd like to request Professor Rajvardhan Azad to please speak on vision of Vitreoretinal Society of Bihar.
विजन तो तुमको दे दिया. सबसे पहले मैं हमारे जो माननीय शिक्षा मंत्री हैं बिहार के और हमारे अनुज हैं, वो मेरे छोटे भाई जैसे हैं, तो उन्होंने मुझे कहा था कि मैं आऊँगा और दुर्भाग्यवश वो नहीं है. हो सकता है कहीं व्यस्त होंगे, आजकल चुनाव का समय भी है, तो मोस्ट लाइकली वो कहीं पे फंस गए होंगे. तो मैं उनको उनकी अनुपस्थिति में बहुत बहुत धन्यवाद देता हूँ, क्योंकि उन्होंने यहाँ पे आने का हम लोगों को वादा किया था और हम आशा करेंगे कि शिक्षा के क्षेत्र में जो भी काम हम करेंगे विट्रेओरेटिनल सोसाइटी की तरफ से, तो उसमें वो हमारी मदद करेंगे. हमारे डॉक्टर बिंदे जी हैं, जो ये भी हमारे अनुज हैं और ये अभी डायरेक्टर हैं IGIMS में, और बहुत सिंपल आदमी हैं, बहुत सहज हैं. जब भी मैं फ़ोन करूँगा किसी भी समय में, उस समय में ये रिस्पॉन्स देते हैं. और अब ये बिहार यूनिवर्सिटी ऑफ हेल्थ साइंसेज के वाइस चांसलर हैं. हम लोगों के लिए गर्व की बात है कि हम में से ये बिहार यूनिवर्सिटी ऑफ हेल्थ साइंसेज के वाइस चांसलर हैं. इनसे हमको पर्सनली बहुत ज़्यादा अपेक्षा है, क्योंकि मुझे इन पर अधिकार लगता है. इसलिए मैं बोलूँगा, अभी बोलूँगा मुझे क्या अपेक्षा है उसके बारे में. और हमारे मित्र हैं, इनको मैं TPD बोलता हूँ, लोग बोलता है TP, तो मैं D उसमें ऐड कर देता हूँ. तो ये हमारे TPD हैं, हमारे मित्र हैं. हमसे कितने कॉन्फ्रेंसेस में, कितनी मीटिंग में, इंटरनेशनल हो नेशनल हो, हम लोगों की मुलाकात होती है. हम लोग विभिन्न इस विषयों पर बातचीत करते हैं. तो मतलब क्या बताएं, हम जैसे हम कल बोल रहे थे कि ये हमारा पीछा करते हैं और हम इनका पीछा करते हैं. जैसे हम विट्रेओरेटिनल सोसाइटी में पहले प्रेसिडेंट बने, फिर उसके बाद ये प्रेसिडेंट बन गए. हम ऑल इंडिया ऑप्थेल्मोलॉजिकल सोसाइटी में प्रेसिडेंट बने, फिर ये प्रेसिडेंट बन गए. फिर हम एशिया पैसिफिक एकेडमी ऑप्थेल्मोलॉजी में प्रेसिडेंट बने. अब ये फिर मेरे पीछे लग गए हैं और प्रेसिडेंट इलेक्ट हो गए हैं. इनके लिए ताली हो जाइए. He will be the next Indian to become the president of Asia Pacific Academy of Ophthalmology, which is a strong, body of, I think, maybe 21 countries of South Asian region. And I think 2 more countries, maybe, I think it is Abu Dhabi, and I think it is Iran also, if I am correct. तो सारा लेकर के करीब 2.5 लाख ऑप्थेल्मोलॉजिस्ट ऑफ द वर्ल्ड, एंड ही इज विल बी द प्रेसिडेंट. सो हमारे लिए गर्व की बात है. और हमारे सुभाष जी हैं, तो और हमारे नगेंद्र जी हैं, तो उनके लिए क्या कहना. हम तो मतलब इनको हम लोगों ने यहाँ पे भेजा इसीलिए कि तुम यहाँ का जो ये है ऑप्थेल्मोलॉजी का स्टैंडर्ड है, इसको ऊपर करो. और ये सच में दोनों जो है बहुत मेहनत कर रहे हैं. हमारे ये शिवेंद्र सहाय जी हैं, तो ये बहुत गंभीर दिखते हैं, लेकिन इनकी सोच बहुत गंभीर है और बहुत आगे का सोचते हैं ये. तो बड़ी अच्छी बात है. कल मेरे साथ बैठे थे तो बहुत सारी बातें हुई इनसे हमारी. और पूजा है और उससे बगल में दीपक हैं. तो दीपक हैं, तो ये अपने जगह जहाँ भी रहते हैं वो प्रकाश देते रहते हैं. और पूजा के बारे में तो मैं क्या बोलूँ, ये फ़ोन नहीं उठाएगा लेकिन पूजा ज़रूर फ़ोन उठा लेगी. इसलिए बहुत बार ऐसा होता है कि हम पूजा को ही फ़ोन करते हैं डायरेक्टली कि उसी को फ़ोन करो. ये तो पता नहीं मतलब कहीं रहता है. सैटरडे चला आता है, फिर संडे आता है. और यहाँ बैठे हमारे अरविंद जी जो मुस्कुरा रहे हैं, दाढ़ी वाड़ी पूरा ले करके, मतलब ये साइंटिस्ट लग रहे हैं ये. बट इनका बहुत योगदान है यहाँ पे बिहार में रेटिना को आगे बढ़ाने में. इनका बहुत, ये लोग मतलब शुरू से जब हम एम्स में थे तब से ये यहाँ पर मतलब रेटिना प्रैक्टिस कर रहे हैं। वहाँ भी एम्स में भी आए थे ये, हम लोगों से मेरी मुलाकात हुई थी। बहुत अच्छा लगता है इनसे जब मेरी मुलाकात होती है। ये डॉक्टर पद्मजा आई हुई हैं एलवी प्रसाद से, कुछ और लोग आने वाले हैं जो कल आएंगे, और तमाम आप लोग जो यहाँ बैठे हुए हैं। कुछ मेरे विद्यार्थी हैं, कुछ मेरे दूर के विद्यार्थी हैं, मतलब डायरेक्टली मेरे अंडर नहीं थे, लेकिन ऐसे विद्यार्थी हैं। कुछ हमारे ये फार्मा कंपनी के लोग हैं और जितने तमाम लोग हैं। तो मैंने तो आप लोग को विजन दे दिया। आप कहते हैं मुझे विजन दो, मैंने विजन आप लोगों को दे दिया। और कल जो बात हो रही थी कोलैबोरेशन के बारे में, तो आप लोग कोलैबोरेशन कीजिए, क्योंकि बिना कोलैबोरेशन के नहीं होगा। अब तो ये हमारे तारा प्रसाद दास जी भी आ गए हैं, तो ये और भी हम लोगों को हेल्प करेंगे। कोई नई चीज़ होगी कहीं पे, मान लीजिए कोई इस तरह का जो है वो रिसर्च टॉपिक है या कोई इसे रिसर्च एरिया है जहाँ पर हम लोगों को करना है, तो उसमें हम लोगों को इनसे मदद मिलेगी। और सौभाग्य की बात यह है कि ये भी रेटिना में है और हम लोग भी सब जो ग्रुप है उसी का है, तो इनसे हमारी अपेक्षा है, बहुत अपेक्षा है। और जो हम बोल रहे थे अपने डॉक्टर बिंदे के बारे में, तो डॉक्टर बिंदे से हमारी ये अपेक्षा है कि यहाँ पर जो है बिहार में जो रेटिना के लिए जो यहाँ पर ये ग्रुप बना है, तो उसमें मेरे दिमाग में ये है कि हम लोग कुछ रिसर्च करें। रिसर्च के लिए आपका IGIMS भी है वहाँ, तो हमने आई डिपार्टमेंट में वहाँ पर इन लोगों को दिया ही था, करवाई था। शिवानी बैठी हुई है तो इसको भी पता है, अभिषेक है यहाँ, तो इन लोगों को पता है। तो हम चाहते हैं कि आप जो है बिहार यूनिवर्सिटी ऑफ हेल्थ साइंसेस के तरफ से कुछ फंड एलोकेट कीजिए। आप कम से कम 10 लाख रुपया या 20 लाख रुपया जो है मांगिए मंत्रालय से, उसको बोलिए कि रिसर्च के लिए पैसा दीजिए। और जब वो पैसा मान लीजिए 10 लाख 20 लाख रुपया मिलता है, तो वो अगर सोसाइटी के तरफ से कोई प्रपोजल आपको जाता है कि, और आपको लगता है कि अच्छा एरिया है, अच्छा टॉपिक है, जैसे कि मान लीजिए डायबिटिक रेटिनोपैथी है, लाइफस्टाइल डिजीजेस तो बहुत इंपॉर्टेंट है आजकल, तो उसके लिए जो है हम लोग आपको हम से रिक्वेस्ट करेंगे कि आप इसमें रिसर्च के लिए जो है या तो आप एक बोर्ड बना लीजिए जो अप्रूव करेगा ये सारा, और दूसरी बात कि उसके लिए फंड एलोकेट कर दीजिए। तो उससे क्या होगा कि एक थोड़ा सा एक्टिविटी होगा। इन लोगों को भी मैंने कहा है कि ये लोग जैसे कि मान लीजिए कि देखिए रिसर्च के लिए कोई ज़रूरी नहीं है कि आपके पास में 2 करोड़ रुपया हो, इट इज़ नॉट नेसेसरी। सबके पास में सब इक्विपमेंट है, छोटा छोटा काम हो सकता है, जो छोटे काम से बहुत बड़ा नाम हो सकता है। तो जब छोटा काम कीजिएगा तो बड़ा नाम होगा, और जब बड़ा नाम कीजिएगा तो और भी बड़ा नाम होगा। तो वो कहीं तो हम लोगों को शुरू करना पड़ेगा। तो आपसे ये हमारी गुजारिश है कि आप ज़रा इसको प्रायोरिटी में लीजिए। और बाकी हम क्या बोले, बाकी यह है कि ये लोग कॉन्फ्रेंस की बात कर रहे थे कि ये कॉन्फ्रेंस अगले साल नेपाल में करने का है, वहाँ साउथ एशियन आएगा। तो नेपाल में क्यों करोगे, अभी अगले साल मोस्ट लाइकली हम सोच रहे हैं, अभी हम जाएंगे ढाका 22-23 सितंबर को। तो जब जाएंगे वहाँ पे एक्चुअली हम लोग को साउथ एशियन करना था, तो वो होना था वहीं ढाका में, बट अनफॉर्चुनेटली जो वहाँ पे पॉलिटिकल इवेंट्स हो गया तो उसकी वजह से हम लोग नहीं कर पा रहे हैं। तो अब मोस्ट लाइकली थिंग्स विल सेटल डाउन फॉर द नेक्स्ट ईयर, एंड नेक्स्ट ईयर वी विल डेफिनेटली डू इट देयर। सो इफ़ यू वांट VRSB को तो हम इंटरनेशनल बना देंगे। आप ये तो शुरुआत है, आप लोग हमको साथ दो। उसके बाद अब जैसे ढाका में होगा वहाँ तो सारे कंट्री आएंगे, श्रीलंका भी रहेगा, नेपाल भी रहेगा, मालदीव्स भी रहेगा, पाकिस्तान भी रहेगा। अब तो पाकिस्तान जोर से जाएगा ढाका फॉर द रीजंस वी ऑल नो। हो सकता है कि इंडिया से ज़्यादा पाकिस्तान के ही लोग वहाँ पे हों, तो बट जो भी है वहाँ पे तो साउथ एशियन का होगा ही होगा। तो मेरे कहने का मतलब ये है कि आप लोग आइए, बाहर आगे बढ़िए, और हम तो तुम लोगों को विजन दे दिए, तुम लोगों को बना दिए, अब तुम लोग आगे करो। डेफिनेटली पिछले ये 6ठा साल है ना इसका, पिछले 6 साल नहीं, पिछले 7-8 साल में जितना यहाँ रेटिना का डेवलपमेंट हुआ है, इसमें क्या नाम है बिहार में, हमको लगता है कि ये सब्सटेंशियल है और ये हम लोगों के लिए बहुत गर्व की बात है और हम लोग इसको और आगे बढ़ाएंगे। और इससे पहले कि हम समाप्त कर दें, एक छोटी सी कहानी बोलता हूँ। एक फ्रांस काफ्का करके एक राइटर थे। ही वॉज एन ऑथर, ही वॉज अ पोएट एंड ही वॉज अ जीनियस। ही डाइड एट द एज ऑफ 40 years. He was an Austrian, but he lived in Berlin, in Germany. तो वो जो है बर्लिन में पार्क में जो है वो घूम रहे थे, तो वहाँ पे पार्क में देखा कि एक छोटी सी लड़की थी, शिवानी के जैसी। तो वो लड़की वहाँ रो रही थी। तो फ्रांस काफ्का गए अंदर और उन्होंने कहा क्यों रो रही हो? तो बोले कि मेरी डॉल थी, वो डॉल गुम हो गई है। तो फ्रांस काफ्का बोले कि चलो कोई नहीं, अगर तुम्हारी डॉल गुम हो गई है तो हम तुमको ढूंढते हैं, हम लोग साथ मिल करके। तो पूरा शादी दौरा सारा घुमा उमा, डॉल नहीं मिली। दूसरे दिन उसी दिन फ्रांस काफ्का बोले कोई बात नहीं, हम नेक्स्ट डे आएंगे और तुम्हारा डॉल हम तुम्हारे साथ ढूंढेंगे। वो नेक्स्ट डे क्या किए कि वो एक डॉल बाजार से खरीद के ले आए और उस छोटी लड़की को दे दिए। तो जब छोटी लड़की को दे दिए तो बोली नहीं नहीं, ये मेरा डॉल नहीं है, ये मिलती जुलती नहीं है। तो फ्रांस काफ्का बोले कि तुम्हारी डॉल जो है ना वो गई है इसमें वर्ल्ड टूर में। तो और वो रोज़ दिन आते थे, नेक्स्ट डे फिर आए, बोले आज तुम्हारी डॉल जो है लंदन गई हुई है, लंदन में है। फिर दूसरे दिन गए तो बोले कि दूसरे दिन गए तो बोले कि तुम्हारी डॉल जो है ना वो यूरोप घूम रही है। तीसरे दिन बोले कि यूएसए गई है। करते करते उसका 8-10 दिन उस छोटी लड़की का उसको सांत्वना देते देते अंत में लास्ट डे वो एक डॉल, दूसरा डॉल लाए और वो डॉल उसको दिए। तो बोली कि नहीं ये मेरा डॉल नहीं है। ये बोले कि देखो ऐसा है ना कि जो डॉल इतना घूमी ना तो उससे थक वक गई है, तो इसीलिए उसका चेहरा जो है थोड़ा सा बदल गया है, लेकिन है तुम्हारी यही असली डॉल। तो उसको डॉल दे दिया। फ्रांस काफ्का डाइड एट वेरी अर्ली एज, एट द एज ऑफ 40। और जब वो डेथ हो गया उसका और वो लड़की बड़ी हो गई, तो जब बड़ी हो गई तब उसने उस डॉल के पीछे में जो है वो एक नोट चिपका हुआ था। उस नोट में लिखा था कि गुड थिंग्स डोंट लास्ट फॉर एवर, बट गुड थिंग्स आर डेफिनेटली रिप्लेस्ड बाय अनदर गुड थिंग। मेरे कहने का मतलब ये है कि हम नहीं रहेंगे आने वाले 5 साल 10 साल में, लेकिन कोई अच्छा और भी कोई अच्छा तुम्हारे सामने आएगा। तो यही हम कहना चाहते थे और हम कुछ नहीं कहना चाहते हैं। हम चाहते हैं कि आप लोग आगे बढ़िए, जब तक हम हैं जब तक हम आपको ले चलेंगे। बहुत बहुत धन्यवाद।
थैंक यू सर फॉर योर काइंड वर्ड्स। अभी आपका बहुत बहुत सालों तक हम लोग पर आशीर्वाद बना रहेगा। I'd like to request Professor Rajvardhan Azad, Dr. TP Das sir, Dr. Binde sir, Dr. Shivendra
और
Sahai,
ये एक
Dr.
नया
Mohan
माइलस्टोन है कि हम लोग
to the digital
नया
launch of the
माइलस्टोन है
Vitro
कि हम
Retinal
लोग एक
Society of
वेबसाइट
Bihar.
जो है वो लॉन्च कर रहे हैं। वेबसाइट ये कौन डिवाइस किया? वो लड़का। अच्छा ठीक है, वेरी गुड। चलो हाँ ठीक है ठीक है। तो करना क्या है?
बस सर ये सर हो गया, इसमें
हो गया।
पेजेस जो है ये आपका होम पेज में यहाँ पे का वो है ऑफिस बियरर।
चलिए बहुत बढ़िया है, बहुत अच्छा है।
पहला कॉन्फ्रेंस का सर जो बोध गया वाला।
बोध गया का हाँ।
यशवाल दाढ़ी नहीं उसमें।
हाँ यशवाल दाढ़ी बना लिया है।
दिस इज अबाउट अस, past presidents, past secretaries, ये सब है इसमें। और एक और नया इसमें सर देखिए CLC कहते हैं हम लोग इसको, चीफ लॉजिस्टिक कोऑर्डिनेटर।
ये बिल्कुल सही है, चीफ लॉजिस्टिक कोऑर्डिनेटर।
जो मीटिंग हुआ क्लिक करने से सारा सर वो आएगा।
चलिए बहुत बढ़िया है, बहुत अच्छा है आपका।
अवार्ड सेक्शन सर, और ये प्रोफेसर राजवर्धन आजाद और इसमें कि मेंबरशिप फॉर्म डाउनलोडेबल, लिस्ट ऑफ VRSB मेंबर्स, जो कि अभी हम लोग इसको और अपडेट करना है सर, एंड कॉन्टेक्ट उसमें सेक्रेटरी।
चलिए बहुत बढ़िया है।
थैंक यू सर।
मैं वो 2 किताब दे देता हूँ, जरा मुझे पुस्तक दीजिए। कुछ लिखने पढ़ने की आदत है मुझे, तो इसमें 3 किताब है, 3 पुस्तक है हमारी जो पब्लिश हुई है। देयर इज वन बुक विच इज इन हिंदी, ऑल 3 बुक्स आर इन हिंदी। So one is Sone Ka Haath, which is Golden Hand. The English translation is coming very soon. Maybe another 1 month you will get the English translation. So then Padmaja will be able to read. I don't know if she can read the Hindi version or not. But then I have got one book, Sone Ka Haath. The second is a collection of poems, and that is also in Hindi. नीम का शहद। नीम का शहद में क्या है, नीम भी है और शहद भी है, और दोनों मिला हुआ भी है। और तीसरा जो है वो मैंने अभी जो बिल्कुल लेटेस्ट राजकमल प्रकाशन का दो पुस्तक है, नीम का शहद और ये जो है आयुष्य। आयुष्य क्या है कि ये हमारा बीता हुआ कल है, और जो आज का कल है और जो आने वाला कल है। तो इंसान जो पैदा होता है और तब से ले करके उसके मृत्यु तक का इसमें विवरण है सब अध्याय में। और एंड में ये क्या है कि हमने जो है, जो इंसान जब चला जाता है, जब जाता है तो उसको हमने यूनिवर्स से, ब्रह्मांड है ना, ब्रह्मांड, तो ब्रह्मांड जो है एक दिन ख़त्म होगा, क्योंकि इट इज़ अ बिग बिग बैंग थ्योरी। बिग बैंग थ्योरी है कि भाई बलून है, द यूनिवर्स इज़ लाइक अ बलून, बढ़ेगा बढ़ेगा बढ़ेगा, एक दिन वो फट जाएगा। तो वो उसको मैंने क्या बोलते हैं, साइंस को मैंने अध्यात्म से जोड़ा है। दिस इज अ कॉम्बिनेशन ऑफ साइंस एंड स्पिरिचुअलिटी एंड ऑल्सो विथ द लाइफ। सो दैट इज व्हाट इट इज हियर। द 2 दिस थिंग आर देयर, वन फॉर माय फ्रेंड क्या बोलते हैं, डॉक्टर टीपी दास,
और आगे आके फोटो ले लीजिए।
डॉक्टर विजय के लिए है, और विजय जी से मैं रिक्वेस्ट करूंगा
10 लाख और।
विजय जी से मैं रिक्वेस्ट ये करूंगा कि जो मेरी पुस्तक है सोने का हाथ, इसमें छोटी छोटी कहानियां हैं, 20 कहानियां हैं। और 20 कहानियां जो हैं, जब मैं एम्स में था तो उस समय की कुछ कहानियां हैं, कुछ कुवैत में हम थे वहाँ का है, कुछ मेरे इंटरनेशनल पेशेंट्स थे, चाइना का है जहाँ हम ऑपरेट किए थे, कुछ पेशेंट हमारा फिलीपींस का है, कुछ पेशेंट हमारा सिंगापुर का है, सबकी कहानी है उसमें। और इसमें एक बहुत जो विषय बहुत गंभीर है, और वो है, एक कहानी है उसमें, एक हमारे पांडे जी थे, वो यहीं बिहार के थे, तो उनको रेटिनल अटैचमेंट हो गया। तो पांडे जी जो थे, ही वॉज वन आइड, और जिस आई में उनको रेटिनल डिटैचमेंट था वो इतना ख़राब था, कोरोइडल डिटैचमेंट, फोल्ड्स रेटिना में। तो मैंने उनको बोला, पांडे जी मुझे नहीं लगता है कि वी विल बी एबल टू सेव योर आइज़। तो वो बोला, नहीं नहीं सर, आप ऑपरेट कर दीजिए, हम ठीक हो जाएंगे। तो मेरे दिमाग में इतनी संशय थी, इतना हम सोच रहे थे, और पांडे जी बड़े निश्चिंत थे। तो जिस दिन ऑपरेशन होने वाला था उस दिन बोले, पांडे जी देखिए, हम आपको सही बात कहेंगे, क्या होगा नहीं होगा हम नहीं कह सकते हैं, लेकिन जो है आपका हम कोशिश पूरा करते हो. He was all the time fully assured. He was more confident than me. कि सर आप ऑपरेट कर दीजिए, हम ठीक हो जाएंगे. एंड ही बिकेम ऑल राइट एंड ही until his death. And whenever he'll go to Delhi from here, he'll bring mangoes for me. तो मैं डॉक्टर बिंदे जी से कहना चाहता हूँ, जो सोने का हाथ है, इसकी कुछ प्रति मंगवाइए आप और लोगों को दीजिए. इट इज़ अ वेरी मोटिवेटिंग. पेशेंट को क्या फील होता है जब आप ऑपरेट करते हैं, उसकी क्या भावना होती है, आपकी क्या भावना होती है जब आपको कोई कहता है कि आप भगवान हैं. हम भगवान तो है नहीं, लेकिन वो सब सारा इसमें लिखा हुआ है. तो वो सारी जो अंदर में जो लोगों का भाव उठता है, जो ग्रेटिट्यूड होता है, और आप क्या फील करते हैं जब पेशेंट आपका ठीक हो जाता है और आपका पेशेंट जो है वो चलने लगता है. अभी हमको कल फोन आया, एक आरोपी की बच्ची थी, मैंने उसको मेरे ख्याल में 20 साल पहले उस लड़की का हमने लेज़र किया था. कल मुझे फ़ोन आया, जयपुर, लड़की जयपुर की है, माता पिता उनके हर साल आते हैं मेरे पास में. वो लोग ने फ़ोन किया कि मेरी बेटी का एडमिशन LSR में हो गया है, जिसका हमने लेज़र किया था. आई कांट टेल यू द हैप्पीनेस आई हैव गॉट. और वो लोग इतने खुश थे, बोले कि सर हम अपनी बेटी को आपके पास लाना चाहते हैं और उनको जो है वो LSR में हो गया. हम बोले ज़रूर मिलेंगे, हम अभी दिल्ली जाएंगे तो उससे मिलेंगे बच्चे से. तो ये है, तो जो उस छिपी भावना है ना, जो वो है बिटवीन पेशेंट एंड द डॉक्टर, वो उसमें है. तो मैं चाहूँगा आप उसकी प्रति मंगाइए. ठीक है, बहुत बहुत धन्यवाद.
Thank you, sir. Moving on with the inaugural program, we have a very eminent personality amongst us, and who, especially our secretary, Dr. Pooja Sinha, was very, very particular that we have to invite her, and she has been wanting to invite her for a very, very long time. We have with us Dr. Padmaja, who is a senior consultant at LV Prasad Eye Institute, and I'd like to request Dr. TP Das sir, Dr. Binde sir, Dr. Azad sir to please honor Dr. Padmaja for having come to VRSB. Laiye. Dr. Subhash Prasad sir, Dr. Shivendra sir, Dr. Nagendra Prasad. Can I request all of you to please stay here? Please stay, sir. Please stay, sir. We would like to say also thank you to, sir, we would like to request you to wait here, sir. We would like to say thank you to all our sponsors who are here for today, because of whom this program has become successful. So we would first like to call representative from Roche to please, who is representing Roche? We are very grateful to all the sponsors who are here. Arshad ji, jaldi jaldi laiye. We would like to request representative from Intas Pharmaceuticals. Intas Pharmaceuticals, is anybody there? We would like to request somebody from Novartis to please come up. Novartis. We deeply appreciate your help to VITREO Retinal Society of Bihar. We would like to request representative from Alcon. Anybody there from Alcon? We would like to request somebody from Bayer. Do we have somebody from Bayer? We would like to request somebody from JB Pharmaceuticals. JB. बेर आइए, बेर अर्षा जी बेर कर दीजिए. We have a representative from Sun Pharmaceuticals. Sun Pharmaceuticals. Reliance Life Sciences. सन कर दीजिए. Reliance Life Sciences. Cipla, we have a representative from Cipla. Please come forward. We would also like to say thank you to Zydus. Anybody from Zydus? NRI? Zydus. NRI Vision Care. Carl Zeiss India Private Limited. Anybody from Carl Zeiss? Mankind. Mankind. Mankind का दीजिए अर्षद जी. Lupin, we have somebody from Lupin. Next is Entod Pharmaceuticals. Anybody from Entod? Anybody from Entod Pharmaceuticals? And anybody from Toshbro Medicals? Toshbro, please. Yeah. Thank you so much, sir. May I request the dignitaries to please take your chairs. May I now request our President, Dr. Subhash Prasad, sir, to introduce our guest of honor, Dr. Binde Kumar, sir.
I am so privileged to introduce my senior, my friend, and with whom I have been associated with so long, Dr. Binde sir, Professor Binde Kumar, who is currently Director of Indira Gandhi Institute of Medical Sciences and Vice Chancellor of Health and Medical University of Bihar. Actually, Dr. Binde आज जिस मुकाम पे हैं, वो he started his journey from small village called small village in Nokha, जो कि रोहतास district में है, from where he did schooling. Then he went to joined MBBS in 1981 in Patna Medical College Hospital, where he passed MBBS with lot of honors in almost all subjects. He was brilliant throughout, and after that he joined MS course in Raipur Medical College, Jawaharlal Nehru Medical College, Raipur, from where he did MS. Then he joined PGI Chandigarh in pediatric surgery, because his ambition was to become a pediatric surgeon from the very beginning. And after having done MCH, he came back to Patna, his mother state, and he wanted to serve the people of Bihar. He joined IGMS in 1996, as assistant professor, and from there he established the first pediatric surgery branch of Bihar, and he is the first MCH of pediatric surgery from Bihar who came to Bihar and started the department where he trained lot of MCH students, and not only that he did remarkable surgeries, and Bihar का नाम उन्होंने इस फील्ड में काफ़ी आगे बढ़ाया, and then he joined AIIMS Patna as professor. When Patna AIIMS was not actually functioning properly, it was in the stage of evolution, he contributed there as administrator at many posts, and then established the department where he again मतलब flourished the department like anything, जहाँ पे उन्होंने कई MCH students को बनाया. And after getting the opportunity to come back again to IGMS director, he came to director, and here he is almost completed 2 years, and he is serving very nicely. आज IGMS है कि धीरे धीरे और भी आगे जा रहा है, जैसे कि आप लोग हमेशा न्यूज़ में देखते होंगे. It is still regarded as the one of the best health care provider of the Bihar, and he is the director. We are so proud of Dr. Binde, so please give a big clap to Dr. Binde sir. And he is down to earth person and very spiritual also. He always believes in God कि आज जो भी मिला है ऐसे नहीं मिला है, ऊपर भगवान ने चाहा है तभी मिला है.
May I request Professor Rajvardhan Azad, our President Dr. Subhash Prasad, Dr. Nagendra Prasad, Dr. T.P. Das sir to please felicitate Dr. Binde sir. Azad sir. Shawl Subhash Prasad sir. T.P. Das sir को भी दियो. Thank you, sir. May I request our guest of honor, Dr. Binde Kumar sir, to please address the gathering.
मंच पर उपस्थित doyen of ophthalmology, not in country, Asia Pacific, and I tell you, in broader sense, the whole world. प्रोफेसर राजवर्धन शर्मा आजाद सर, आपने याद नहीं होगा, आपसे पहली मुलाकात मेरी हुई थी जब 2002 में DNB में हमको गोल्ड मेडल मिला था पीडियाट्रिक सर्जरी में. यू आर द मैन हु कन्फर्ड मी द गोल्ड मेडल एट कोची. दैट वाज द फर्स्ट इंटरेक्शन. मैं मिलना चाह रहा था, ऐसे टॉरिंग पर्सनालिटी से सुनता तो मैं बहुत था, तो पहली मुलाकात हमको कोची में आपसे हुई थी, और ये सौभाग्य है कि मैं आपके साथ आज मंच शेयर कर रहा हूँ. मैं अपने को बहुत सौभाग्यशाली समझता हूँ. आप सब टी.पी. दास द LV इंस्टीट्यूट, मैंने सर को बोला कि मैं आपके इंस्टीट्यूट में 8-10 बार मरीजों को लेके गया हूँ, मेरे अपने कलीग सही सब. जिस तरह से आपने इलाज किया है, जिस तरह से आपने इस्टेब्लिश किया है, मैं सोचता था कि काश ऐसा सेंटर बिहार में भी होता. और आज मैं प्राउडली कह सकता हूँ कि वी हैव नॉट वन सेंटर. अखंड ज्योति सर ने आपने शुरू किया है, RIO शुरू किया है, सुभाष जी शुरू किए हैं, सहाय जी बैठे हुए हैं, नागेंद्र जी. द मेनी सेंटर, ऐसा नहीं, एक चीज़ नहीं है, न्यूक्लियस नहीं है सर. इस पूरा का पूरा एरिया जो है आज देख के लगता है कि हम लोग भी आई के क्षेत्र में आगे बढ़ रहे हैं. डॉक्टर सुभाष प्रसाद जिन्होंने बहुत अच्छी बातें मेरे बारे में बताई, और सुभाष प्रसाद और हम लोग एक ही हॉस्टल, ओल्ड हॉस्टल में रहते थे आजू बाजू, और पढ़ाई एक जुनून था, जानते थे कि कुछ करना है तो पढ़ना ही है और दूसरे कोई उपाय नहीं है. तो हम लोग नेपोलियन की तरह थे, या तो इंग्लैंड जीत लो या पीछे समुंदर है, नाव तो डुबा ही दिया गया है. तो हम लोग उस तरह से पढ़े, इसलिए कोई क्रेडिट नहीं है कि हम लोगों ने पढ़ाई की, इट वॉज कंपल्सन. डॉक्टर शिवेंद्र सहाय जिनके साथ मैंने काम किया, Nagendra ji, ever smiling, smartest man and most well groomed and well dressed man of the IGMS में तो बोल सकता हूँ ये पूरे जितने लोग हैं उसमें सबसे अधिक अच्छे कपड़े पहनने वाले और अच्छे दिखने वाले नागेंद्र जी हैं। मैडम पूजा, थैंक यू वेरी मच। प्रोफेसर दीपक अग्रवाल, भाभी बैठी हुई है हमारी, संजीता भाभी, बेटी बैठी हुई है, और मैं देख रहा हूँ कि मेरे कुछ असिस्टेंट प्रोफेसर भी हैं, डॉक्टर शिवानी है, अभिषेक जी हैं और उधर प्रतीक हैं। सर 3 जनरेशन ऑप्थेल्मोलॉजिस्ट मैं यहाँ पर देख रहा हूँ। एक जनरेशन आप टीपी दास सर आप हैं, एक जनरेशन में हम लोग हैं जो इधर बैठे हुए हैं सुभाष जी, तीसरा जनरेशन उधर बैठा हुआ है, और मैं 2 जनरेशन को तो मैंने विटनेस किया, तीसरा जनरेशन हमको देखने का मौका मिल गया। अभी मैं इंटरव्यू कंडक्ट किया हूँ 4 बार ऑप्थेल्मोलॉजी का, 22 हम लोगों ने असिस्टेंट प्रोफेसर सेलेक्ट किए RIO के लिए, और मैं आश्चर्यचकित था कि इतने काबिल लोग हम लोगों के पास अवेलेबल हैं। कल ही था आपका इंटरव्यू अभिषेक, हाँ कल था ना 30 को। अभिषेक जब दे रहे थे इंटरव्यू दे रहे थे, मैं बैठा हुआ था, मैं यही सोच रहा था, और एग्जामिनर को 60 में 58 देना पड़ा, वो डिस्क्लोज नहीं करना चाहिए। सच ए कैंडिडेट और सच ए नॉलेज, कहीं से भी कुछ पूछा जाए एंड ही इज देयर आंसरिंग ऑल द क्वेश्चन। सो विद शिवानी सिटिंग देयर, प्रतीक, हम लोग का जो उसका पहले भी हम लोगों ने एग्जामिन किया था, हम लोगों का जो नया जनरेशन है हम लोगों से बेहतर है, और हम लोग पूरी तरह सान्वित हैं कि ऑप्थेल्मोलॉजी आँख का डिपार्टमेंट जो है बिहार में सुरक्षित हाथों में है। सर मैं आपने एक रिक्वेस्ट किया रिसर्च के मामले में, जब मैं ज्वाइन किया ना सर 2022 में, तो मेरा मुद्दा ही था कि ट्रेनिंग एंड रिसर्च को करना है। ट्रीटमेंट में हम लोग एट पार हैं, हम लोग कर रहे हैं, हमने देखा है, देश में भी देखा है, ऑन अब्रॉड भी देखा है। इस रिसर्च के मामले में हम लोग उससे साई अवे कर जाते हैं। उसका कारण है कि हम लोग को रिसर्च मेथोडोलॉजी आती नहीं है, उसका कारण है कि एक्सपोजर नहीं है। तो हमने पहला प्रपोजल जो बोर्ड में ले गए वो था कि 5 लाख रुपया सारे फैकल्टी को दे दिया जाए, और आपको विश्वास नहीं होगा हमारे पास 350 फैकल्टी है, और अभी हम 100 घर में 450 फैकल्टी हो गए। 450 इंटू 5 लाख हमने दे दिया सर इंटरमिनल फंड में, और बोर्ड से पास हो गया और हमने ऑर्डर भी निकाल दिया है। तो सर आपके यहाँ जो है अभी 22-25 फैकल्टी हैं आपके यहाँ से, मेरा मतलब ऑप्थेल्मोलॉजी से है, 25 इंटू 5 125 लाख रुपया हम लोगों ने आई के रिसर्च के लिए हम लोगों ने दे दिया है सर, इंटरमिनल फंड। इसके बाद भी स्काई इज द लिमिट। अगर आप एक्स्ट्रा मिनरल फंड के लिए जाते हैं, वी आर देयर टू हेल्प देम कि किस तरह से लिखा जाता है प्रपोजल, ग्रांट प्रपोजल किस तरह से लिखा जाता है, कैसे पैसे मिलेंगे, उसके लिए ऑल द टाइम हम लोगों के पास एक सेट ऑफ एक्सपर्ट्स हैं जो उनको गाइड करते हैं, बीच बीच में हम सिम्पोजियम करते हैं, वर्कशॉप करते हैं। ये रही इंदिरा गांधी की बात। बिहार हेल्थ यूनिवर्सिटी मैंने सर 4 तारीख को ही ज्वाइन किया, अभी 1 महीना भी पूरे नहीं हुए हैं। तो रिसर्च की बात हमने वहाँ पर की, और रिसर्च के लिए हम लोगों ने पहली मीटिंग जो की उसमें हमने ICMR के जो ये हैं डायरेक्टर जनरल हैं उनको बोले कि आप आ जाइए, कहे कि सारे प्रिंसिपल की हम लोगों ने मीटिंग बुलाई है। ये 12 तारीख को हुई, 12 जुलाई को हमने 4 को, तो 8 दिन के बाद मैंने मीटिंग बुलाई थी। ऑल मेडिकल कॉलेजेस जितने प्रिंसिपल्स थे या डीन थे उनको उन्होंने बुलाया, और उनकी मीटिंग हमने की। बोले हम फिजिकली नहीं आ सकते हैं, हम इस पर रहेंगे, जूम पे रहेंगे। और सर उन्होंने जो है उन्होंने बताया ICMR DG ने कि बिहार को अगर कुछ भी ज़रूरत है हम हैं। उसके लिए उन्होंने हमारा जो काउंटर पार्ट है डॉक्टर कृष्णा पांडे, मेरे बैचमेट ही हैं, हाँ, कृष्णा से भी बोला कि बिहार हेल्थ यूनिवर्सिटी से तुम एसोसिएट करो, और जो लोग भी रिसर्च करना चाहता है, अगर उनको ट्रेनिंग की ज़रूरत है, उनको ग्रांट की ज़रूरत है, प्रपोजल कैसे लिखा जाता है, वी आर गोइंग। एंड बोले मैं पर्सनली इंटरेस्ट लेके करूँगा, लेकिन ये बोले कि सब लोग नहीं कर सकता है। अगर 10 डॉक्टर हैं तो उसमें 2 ही और 1 ही डॉक्टर जो रिसर्च बेंट का होता है, तो उसको हम लोगों को ग्रूम करना है, उसको आगे बढ़ाना है। तो वो कवायद हम लोग कर रहे हैं हर एक मेडिकल कॉलेज में जाकर कि कितने लोग हैं जो इंटरेस्टेड हैं रिसर्च के लिए, कितने लोग, और बाकी लोग जो कर रहे हैं उनकी हम लोग ग्रुप बना के, हमने IGMS में ग्रुप बनाया, ग्रुप 30। ग्रुप 30 का मतलब है कि 350 डॉक्टर में 30 लोग तो प्रपोजल लिखेंगे ही। और वही कारण है कि जब हम शुरू किए थे तो हमारे पास 50 लाख का ग्रांट था एक्स्ट्रा मिनरल, और आज बढ़ के 7 करोड़ रुपया हो गया है। और मेरी कोशिश है कि हम 50 करोड़ जाते जाते हम कर सकें। ये मेरी कोशिश इंदिरा गांधी इंस्टीट्यूट में है। हेल्थ यूनिवर्सिटी में मैं कितना कह पाऊँगा मैं बता नहीं सकता हूँ, बट इतनी कोशिश जरूर होगी सर कि जो भी इंटरेस्टेड होगा उसको ग्रांट मिलेगा। प्रपोजल कैसे लिखना है, बहुत सा ऑब्जेक्शंस आया कि अगर आप जा रहे हैं इथिकल कमेटी इसके लिए, हमारे कुछ लोग हैं जो हर चीज़ में झंडा बुलंद करते हैं, बोले कि 50 किलोमीटर से अधिक नहीं दे सकते हैं। हम बोले किस लिए नहीं दे सकते हैं? तो नहीं, इथिकल कमेटी हम लोग 50 किलोमीटर तक नहीं अब लिख सकते हैं। तरह तरह की बातें हैं। हमने ये सब रखिए, हम पूरा दे रहे हैं पूरे बिहार को। हम लोग 15 मेडिकल कॉलेज से, जब मैं हेल्थ यूनिवर्सिटी का वाइस चांसलर नहीं था, हमने 15 मेडिकल कॉलेज को हमने IAC अपना का उसका रास्ता दिया कि अगर उनका प्रपोजल है तो मेरे IAC से पास होगा, वो अपना कर सकते हैं। तो सर विज़न है और आप हैं सर, और आपकी जो विज़न है, आपने जो किताबें लिखी, आपने बताई, मैं बहुत शिद्दत से समझ सकता हूँ कि इनका मूल क्या है। एक मरीज को जब ऑपरेट करते हैं, जब आप 70 के प्लस 65 प्लस, हम लोग भी पहुंच रहे हैं उसी उम्र में, जसवाल साहब हम लोग भी पहुंच रहे हैं, 65 साल के बाद आप पहुंचते हैं तो आप अतीत में मोस्ट ऑफ द टाइम चले जाते हैं, थोड़ी देर के बाद अतीत में चले जाते हैं, और इसलिए कहानियां हो जाती हैं। हम लोग जब बात करते हैं तो हो सकता है यंगर जनरेशन जो बैठा हुआ है ऊब जाए, यार क्या बात कर रहा है, पुरानी बातें कर रहा है। हम लोग रूमिनेट करते हैं उन आइडियाज़ को जो हम लोगों ने खाया हुआ है, उसको बाहर ले आते हैं, उसको एंजॉय करते हैं। सर ई रूमिनेशन इम्पॉर्टेंट इन लोगों के लिए है कि जो आपने किताब लिखी है वो वर्चुअली एक बायोग्राफी है, और उन लोगों को बिना जाने हुए, बिना समझे हुए वो एक्सपीरियंसेज एक बार मिल जाता है। तो इससे अच्छी बड़ी चीज़ और कुछ नहीं हो सकती है। मैं उसके लिए आपको साधुवाद देता हूँ। मैं अधिक समय नहीं लूँगा। मैं कॉन्फ्रेंस में आए हुए सब लोगों को, सत्यजीत जी का जो एनर्जी है हम देखते हैं हमेशा, हमने चौथी या पाँचवीं बार इन लोग हमको बहुत प्यार करते हैं, हर बार बुला लेते हैं, हम बहुत बहुत थैंकफुल हैं, और हम कभी ऑप्थेल्मी से हमको अलग नहीं पाए हैं। जब शुरुआत भी हुई थी तो उस समय 4 लोगों का ग्रुप था, सुभाष जी थे, नागेंद्र भाई थे, सुधीर भाई थे, हम लोग विभूति बाद में ज्वाइन किए। हम लोग बैठते थे और शाम को बिना चाय पिए हुए हम लोग घर नहीं जाते थे। वो दोस्ती आज भी है, तरह तरह की बातें होती थी, जितने सीनियर थे सबको हम लोग भरपेट सुनाते थे और खुश होकर घर जाते थे। थैंक यू वेरी मच।
Thank you so much, sir. It was so encouraging to hear your words of wisdom. One of the most important parts of this conference is the Professor Rajvardhan Azad oration. And this year we are blessed by the most sought after, as Professor Rajvardhan Azad said, that he's going to be the president of Asia Pacific. This year's oration is going to be presented by Dr. Professor T.P. Das, who is from LV Prasad Eye Institute, Hyderabad. And I'd like to request Dr. Shivendra Sahai, sir, our Vice President, to please introduce Dr. T.P. Das, sir.
It is our proud privilege to have among us Padma Shri Dr. Tara Prasad Das for Professor Rajvardhan Azad oration. Dr. Das is Vice Chairman Emeritus of LV Prasad Eye Institute, Hyderabad, India, and Mentor and Chief Advisor Shantilal Sanghavi Eye Institute, Mumbai, India. His academic profile is terrific. He has 19 research grants, 378 journal publications, 58 book chapters he has written, and has authored 13 books. He is President-elect Asia Pacific Academy of Ophthalmology, Counselor at Large Asia Pacific VITREO Retinal Society, is Member Advisory Board Asia Pacific Journal of Ophthalmology, member of Dr. APJ Kalam International Foundation, and he is one of the Board of Directors, Bhubaneswar City Knowledge and Innovator Cluster. He has several awards and lectures, 50 awards of India government, which includes Government of Odisha National Society Award, Asia Pacific APAO, International Awards, American Academy of Ophthalmology, his Doctorate of Science, and Government of India Civilian Award Padma Shri in the year 2013, and he is among 2% scientists of the world Stanford University survey according to that, and he is among the 100 influential ophthalmologists of Asia Pacific region. It is simply a great honor for the VRSB to have Dr. Tara Prasad Das among us. I welcome Dr. Tara Prasad Das sir to come for this oration.
May I request Professor Rajvardhan Azad to please felicitate Dr. Professor T.P. Das sir. I'd like to request our President Dr. Subhash Prasad Vice President Dr. Shivendra Sahai, Dr. Binde Kumar sir, Dr. Nagendra Prasad sir. Huh? Kya? Chair of honor. Chair of honor. Lai Arshadi Lai. A big applause for Dr. T.P. Das sir. थोड़ा नीचे कर लीजिए उसको सर, तब फोटो आएगा सर. हाँ. We have a memento for you, sir, Madhubani painting, which is a speciality of Bihar. There's another memento as the guest of honor, sir. T.P. Das sir has such a busy schedule globally, and we are so indebted to him that he has taken out time to come to Bihar all the way. This is the Professor Rajvardhan Azad Gold Medal for the oration. सर पकड़ लीजिए, आज़ाद सर पकड़ लीजिए, सवारी भी पकड़. हाँ. Thank you so much, sir. We feel so blessed by your presence. May I now kindly request you to please address the gathering, sir.
Good evening, all of you. Very, very humbling. I don't think I really deserve all the things, but then friendship of Professor Azad is you can't deny to that. Professor Binde Kumar ji, Professor Azad, the executives of BIHAR VITREO RETINA Society, my good friend Arvind, my younger colleague Padmaja and friend Satyaji, thank you very much for asking me to be here in Patna. When I arrived last, I had come to Patna only once, but that was in a kind of ceremonial thing where I did not see Patna at all. When I drove and I landed in Patna new airport, I was pleased that the Indigo, I walked through the only available right now, the Aero Bridge, which I was very pleased that I walked through the Aero Bridge. I thought that the tiles are very slippery. So as I told last night also, if I ever required to make a comment on Bihar new airport, I said make the tiles a little more rough so that Azad and I can walk comfortably. One important thing that why should form a society after we have got All India Autonomous Society? In 2005 or 4, when my late recently died Professor Nampramana Sami called me that we are forming a society called VITREO RETINA Society of India, and I don't ask you, I direct you that you must join the society. I am the 6th member of the VRSI. When I started growing, I realized that why the society is important. Society is important to not only collect people for a drama or for a function or a celebration, but actually to connect to people and started collaborating, thinking differently. We heard that Professor Azad made the society 6 years or 7 years ago, but then many of you may not know that he is also responsible for forming the Asia Pacific Vitreous Society in Hong Kong, and he and I, along with a few other people, late Ash Otano, current Dennis Lam, etc., were there, 5-6 people, we decided we must have APVRS. Now APVRS is a very vibrant society. India being a cataract-centric country, you cannot think of a society like a vitreous and retina. I will tell you my secret. When I passed my MBBS, I wanted to be a lazy person. So let me choose a subject where the combination of medicine and surgery had no emergency. Ophthalmology fitted into that. When I become an ophthalmologist, I find out that which volume of Duke Elder is the thinnest volume. It was volume number 10, retina vitreous, called retina, not vitreous, retina. So I entered the retina, but I didn't know that ophthalmology could be so vast, 18 volumes of Duke Elder. And retina will become vitreous, macula, cilia, ciliary body, optic nerve, macula, like this. But then I'm happy that I'm ophthalmologist today. In 1991-2, when Dr. Rao, the former director, chairman LV Prasad, asked me to start VITREO Retinal Fellowship, I was reluctant because am I really ready? The hospital might be ready with the number of people, but am I going to be a good teacher? To become a good teacher, you have to lead from the front, accept all the failures of the department or the people around you, and be humble enough to allow your coordinates, your associates to take forward and celebrate the success. And that's what I was thinking, that I took a 6 month to nearly a year to think. By the time of thinking, my contemporary Dr. Chandrasekhar of Glaucoma and Dr. Rao decided to recruit a fellow for me and thrust it upon me. That was Dr. Subhadra Jalali. I was forced to accept a fellow, start a fellowship program in retina. But today, looking back, I'm happy that I started it because retina has done so well. When 1981, when Dr. Chandran Abraham presented his paper on laser for submacular neovascular membrane, I thought, what is this? Why should I worry about the SMD? At that time, not called AMD, called SMD, too close to me. And I thought I will not learn this, but in fact is that he was wiser and I was not, because today AMD is such an important thing. Today, we are indented with a newer technology. When I had a optometry fellow, now she's in US, somewhere in US, called Arvind Kaur. Once in Arvind ran after me, room number 133, old building of LV Prasad, the old campus. Dr. Das, aap mithai khilao hame. I said, why? What did I do to give a mithai to you? Aapka patient ko 612 vision hai. Wow, 612 vision was unheard of. Today, 612, they do, almost every patient get after macular surgery, after injections, after so many other things. So retina has done so well. That is not the reason why you should work for retina. There are many other reasons. After cataract, retina is the most important disease in the world today, not only India, in the world today, because of the aging population, diabetes, neovascular AMD, and many other diseases. Today, we can diagnose and treat inherited retinal disease, which are unheard of several decades ago. So the population is of retina is increasing high. And few weeks ago, I was talking to the current medical director of Ganapati Netralaya in Jalna. He told that their volume of retina surgery, including injection, of course, is higher than the cataract volume, which is not unusual to hear, which is true. We also in a land, since I heard about Bihar, I was thinking about Bihar all the time, because once upon a time Bihar was number one. I come from Orissa, many of my teachers were trained in Patna Medical College. India's first president come from this state, Dr. Rajendra Prasad, and many other things there. Like here I'm standing there, that the national emblem, the 3 lions in 3 different directions, is from Ashok. And I am personally very fond of Ashok. If I have to give a posthumous Bharat Ratna to somebody, I will give to Ashok first. The city has also given birth to 3 important religions, Buddhism, Sikhism and Jainism, and which is unheard of, and 2 different things, what wonderful things happen. When talking about this fellowship of retina, which I know that many are doing it, I will have personal request to Dr. Vindre Kumar Prasad that like Rajiv Gandhi University of Karnataka does, can Bihar Health University also recognize the fellowship so that people can be trained? Like let's say the MCH of Chandigarh, PGI, similarly can it be there? Because that's very important to have a co-certification of the Bihar Health Science to our fellows who are getting trained here. This morning I had a wonderful sight, seeing is believing stuff today. Professor Azad took me to a place called Masti Chak, and to go to the Akhanda Jyoti Eye Hospital. This institution of itself, it should not be called eye hospital at all. But there is a huge land and bigger than what we have in LV Prasad. I went with my chest high, head high, that, well, I'm come from LV Prasad, kya hota hoga yahan par? I have only seen the Mukhra in website. When I went there, I saw that every area I saw, every place I visited, every doctor I interacted, every girl of trainees or employee, my status becomes small and somehow I become so humbled. But at the end of the journey of these 2 hours or so, I was proud that we have something like Akhanda Jyoti who is doing wonderful work. 1 million surgeries a year, 100+ doctors working, 40+ doctors working, and there are a lot of fellowship program. And the most important thing is that they recruit what we always say, local girls, and train them 700 in a year, 700 in a year, and all for free. Doesn't matter where do you get money from, they use it for so usefully. Next to the hospital, I saw the huge spiritual activities going on. I went to the temple of Gayatri. First time I saw a spiritualism and science being blended so usefully, but then dress code of the students of the hospital doctors were not anything spiritual. They are normal dresses. That means they are real blending of karma yogi, just not doing something else. I am delighted that Professor Azad selected me to give this oration in his name. More grateful that he took me to Masti Chak to the Akhanda Jyoti Eye Hospital, where one of our former faculty, Sumit, example, works there. He's not the head, but he's in the retina guy there and doing a wonderful job. So I'm sure that in years to come, like we heard from that, all the development happening in Bihar, both infrastructure-wise and other transformation happening, I'm sure that in Bihar, the society and Bihar in general of medicine and ophthalmology will do well. We have a big opportunity next year to have the meeting with Nepal, Bhutan, Bangladesh, Sri Lanka to find out what common disease you can pick up to do some work together. I'm sure there are a lot of commonality between all these 4 countries that we live in South Asia. Thank you so much for inviting me, and I am grateful. I thank all of you on behalf of Padmaja and me from LV Prasad that we will be available to you anytime you think that we can do any little help. We'll be always happy to help you. Thank you so much.
Thank you so much, sir. I'd like to also take this opportunity to inform Dr. Binde Kumar sir and Dr. TP Das sir that in the entire country, because of the blessings and leadership of Professor Azad, Bihar became the first state in which we had a proper society for retina specialists. Nowhere in India it was there. After us, Gujarat came, and just now Karnataka has formed a Vitreoretinal Society of Karnataka, Vitreoretinal Society of Gujarat. Bihar was the first one to have a proper Vitreoretinal Society of Bihar. Next, I'd like to take this opportunity to, although he is not here, but he had promised us to come, our Education Minister, Dr. Shri Sunil Kumarji, who has been a close family associate right from childhood, And he was very optimistic, but he said because of the election season, he got some urgent engagement, so he could not come. So he has sent his message, which we are going to play now. And I'm very proud, especially being a Mike Light, that he is my senior from St. Michael's. And he then became in IPS. He was in the police department. And as soon as he retired from the police department, then he straight went into politics. And when I met him, he is so humble, so quiet. I said, सुनील भैया अब आप इसमें आ गए हैं तो आपको मंत्री बन जाना चाहिए, मंत्री आपको जरूर बनाएंगे. And he said, तुमको पता नहीं हम मंत्री हैं. Because I have been seeing him since childhood, so he's so humble and nice. So we'll play his video now. Sunil Kumar ji.
Honorable Press.
आवाज दीजिए. फिर से play.
Honorable President and members of the VITREO Retina Society of Bihar, eminent doctors, dignitaries, ladies and gentlemen, a very good evening to all of you and namaskar. My apologies first for missing out on this event due to a pressing engagement outside the state. I'm sure this will be a great learning experience for all the participants. It will be a good platform to exchange ideas, cutting-edge technologies, and the outcome will be very fruitful from the medical point of view. It will also be a wonderful opportunity to meet each other and enjoy the workshops and the seminars to be held. Some of you must be meeting after a very long time. So enjoy this conference. On a personal note, when I was a young person, I was hit very badly by a cricket ball and my eyesight suffered a great damage. But thanks to the treatment I received at the hands of a very eminent doctor, and that my eyesight became perfectly normal. Later I could join the police service as well. As far as the government of Bihar is concerned, under the stewardship of Mr. Nitish Kumar, the health facilities and eye care facilities have taken tremendous strides in the last decade. I'm sure everyone knows that today the health care being offered to the poor patients are much better than it was before. And I'm sure that the members of the society are doing a great service, especially to the poor patients. I know for sure that Dr. Azad, Dr. Satyajit are holding free eye camps for the poor patients. And our eyes are the windows to the world. And it's a great humanitarian service that this society is doing in Bihar. Those of you who have come for the first time, I would also request you to visit the Gurudwara Sahib at Patna city, the ruins of Nalanda and Bodh Gaya. They are of great historical importance, and I'm sure you'll enjoy your visits there. Welcome once again to the ancient city of Patliputra, and I'm sure this conference will be of great success. I wish you all the best in this conference. Thank you and Jai Hind.
Thank you so much. Now I'd like to request our treasurer, Dr. Deepak Agarwal, please, to give the vote of thanks.
So at this outset, on behalf of all our executives, I would like to thank first Professor Azad sir for giving us this important and historic platform where we can meet and share our scientific views. I would like to thank our chief guest, Shri Sunil Kumar ji, guest of honor, Dr. Binde Kumar sir and Tara Prasad Das sir, for sparing their valuable time for us. And indeed, it's a moment of glory for our society. Your presence is indeed a matter of glory for all of us. I also would like to thank our guest speaker, Dr. Padmaja ma'am, and other guest speakers who will be there tomorrow, Dr. Vishal Agrawal, Dr. Chaitra Jaydev, Dr. Ruchir Tiwari, for sparing their valuable time and share their insights. I would like to thank our president, Dr. Subhash sir, for guiding us in shaping up this conference, our past presidents, Dr. Nagendra sir, our vice president, Dr. Shivendra Sai, for their support and guidance. And most importantly, the soul of our society, our secretary, Dr. Pooja Sinha ma'am, for her untiring efforts and nuances in carving out the scientific sessions, which serve as the core of any conference. So thank you, ma'am. And to add to the vibrancy and energy to our conference, we have our Chief Logistics Officer, Dr. Satyajit sir. A big thank you to you, because without you, any conference here is definitely not possible. My heartfelt gratitude to all our executives, Dr. Abhishek Kedia, Dr. Abhishek Anand, Dr. Satyaprakash Tiwari, Dr. Kumar Vivek, Dr. Shivani Sinha, Dr. Vishal Kishore, and Dr. Rajesh Agrawal for your support. Thank you so much. And thanks to all our sponsors whom we have felicitated, our audiovisual team over here, our event manager Pappu Gunjan ji, and all the staff of Hotel Moria for their support, untiring efforts. Thank you so much. Thank you.
Thank you. May I now request everybody to please stand up for the national anthem, please.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंधु गुजरात मराठा द्राविड़ उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंगा तब शुभ नामे जागे तब शुभ आशीष मांगे गाहे तब जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you very much. We'll now have the general body meeting, so I'd like to request all the members to come to the front row, and which will be for about just 15-20 minutes, and then we'll start the cultural program and the dinner soon after that. कोरियर बना ठीक है ठीक ठीक. Can I request all the